No problem. Easy questions if you get, you will easily make 180 to 200 marks, right? So let's get started. Let's not do more time pass. Let's focus. And on my Instagram, I have posted last 3-year PYQs. If you saw it, good. If you didn't see it, just have a look at the topics today, if you can. Okay. Last 3-year PYQs I have put. And these are the IMP GIT topics. Okay. Most of these I'll try to revise right now as we go. So first, we are going to do the malignancies. And in the malignancies, those of you who have attended before, you know how easy malignancies can become if your common sense and principles are correct. So first, C esophagus and side by side CA stomach. Both of these cancers cause late symptoms. They will carry poor prognosis. And both of these cancers have similar risk factors. The rule is SSSD for both. Smoking, spirits, sepsis. Sepsis for esophagus, human papillomavirus or candida. Who gets candida of the esophagus? Immunosuppressed patients. Sepsis for CA stomach, very important, H. pylori. Okay, very important, H. pylori. A diet for both N-nitroso compounds, consuming smoked foods, soya sauce, high salt diet, or a lot of preservatives. These are some of the risk factors. S for stomach. Now, in esophagus, the most common cancer overall is squamous cell carcinoma. Squamous cell carcinoma, one risk factor you should know is achalasia. And second is corrosive injury. These will cause squamous cell carcinoma of esophagus. Adenocarcinoma, this is what they will ask in the exam, will be Barrett. Correct. And Barrett's happens in patients with GERD. So GERD Barrett will be adenocarcinoma. ये mistake मत करना. Adenocarcinoma, Barrett's esophagus. Pre-malignant for stomach is going to be peptic ulcer. And second will be adenomatous polyps. So these are some one-liner PYQs. Then you come to clinical features, both esophagus and stomach. Remember our rule, elderly patients, male more than female, smoking history. Same for stomach also, elderly, male, more than female, smoker, EMS. Right, so this will be the start of the question. For esophagus, the main symptom will be painless dysphagia, and in malignancies, it is more to solids. Correct. Initially, more to solids. Later, he will get regurgitation also. And over time, he will get weight loss. What is these three together called? These three things together: dysphagia, regurgitation, weight loss. The same thing you see in achalasia also, but here it is called as pseudo achalasia. So pseudoachalasia means triad of achalasia in C esophagus. Similarly in stomach, depending on the type of the tumor, whether it is exophytic or infiltrative, you remember Borman classification, the person can present with upper GI bleed, that is hematemesis, or non-bilious vomiting. If you are able to, what I'm saying, if it is striking you, that means you have prepared well. If it's not, then just listen, because even if you just listen and these things come in the exam, it will strike you. Okay, because we are so close, this kind of a recall will help you. Some of the features of malignancy with metastasis, which are not specifically CA stomach, may be seen. Some features of metastasis, right? Like Furchow node, enlarged left supraclavicular lymph node, Systemaris-Joseph's paraumbilical nodules, or Krokenberg ovarian tumors. If any of this is present, it means it is metastatic. Metastatic means it is M1 tumor, distant metastasis. Okay, where else does liver go? Hematogenously. Where else does stomach cancer go? Hematogenously. Apart from these that I told you, most commonly it goes to liver. Esophagus goes to lung. Okay, stomach goes to liver. Colorectal also go to liver. So these are other distant metastases. right? So these are the basic clinical features. Now come to investigations and staging. For both of these conditions, thumb rule of upper GI, any elective presentation. Elective means chronic, dysphagia, regurgitation, upper GI bleed. Any chronic presentation, you will do upper GI scopy. Here you will see a tumor. So if you see a tumor, you will do biopsy. Biopsy will tell you adenocarcinoma, squamous cell carcinoma, whatever type of tumor it is. Then you want to see metastasis, local spread or depth of invasion, you will do endoscopic ultrasound. For distant metastasis, you will do PET scan. This is same for both. Okay, esophagus and stomach. The investigations are the same. Okay, first you will do diagnosis, then TNM staging, and the TNM staging, the T for both is depth of invasion. Mucosa, submucosa, muscularis, right? It goes like that. So T1A tumor, depth will be mucosa. T1B, mucosa, submucosa. T2 muscularis. This part is same for both. Okay, this part is same for esophagus and stomach. But T3 for esophagus is going to be adventitia. T4A, resectable adjacent organs like pleura, diaphragm. T4B, unresectable adjacent organs like trachea. Right. So that is going to be for esophagus. For stomach, T3 is subserosa. T4A will be serosal breach. Okay, breach of serosa or breach of visceral peritoneum. And T4B will be adjacent organs like pancreas. Right. So the only difference is in between T3 and T4. I think for 2 days you will remember this, right? So this much you will remember for next 2 days. So this will be the TNM staging. Then you come to treatment. Treatment is our favorite part, our easy part. Very easy treatment. First, divide the tumor as early, advanced, metastatic. Early tumor, first do surgery, then give chemotherapy. Advanced tumor, do reverse, first do chemo, shrink the tumor, then do surgery. Metastatic tumor, just improve quality of life by doing palliation. One of the ways is to do a stenting. This is our logic in all our upper GI cancers, correct? Early, advanced, metastatic. Usually early tumor will be T1, T2. Advanced will be T3, T4. And metastatic will be M1. Correct. So this will be our breakup. Now we go to individual surgeries. For esophagus, you need margin proximal distal. Proximal margin should be more than 10 centimeters. Distal margin should be more than 5 to 10 centimeters, depending on the location. So you will do a wide excision. You will remove the lymph nodes. That is called radical surgery. And to remove the tumor, you can do it in 2 ways. One is this double approach, 2 incisions. What is this called? Double approach of where you take 2 incisions. Ivor-Lewis. Correct. Ivor-Lewis, right thoracotomy and laparotomy. Go inside, remove the tumor, do the anastomosis. Second is triple approach, where you take 2 incisions of Ivor-Lewis and a left neck incision. This is called triple approach of Mekion. In Mekion, there is a neck incision. Mekion, Nekion. You can remember like that. And then you do the anastomosis. What is the preferred anastomosis? Preferred anastomosis means what do you use when you have resected the esophagus for the food to pass? Preferred. No, not jejunum. No, 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 no. Don't say jejunum. Not GJ. GJ kaise aaya? You do gastric pull-up. Okay. You do gastric pull-up. That is the preferred conduit. Pull whatever stomach is there up into the chest and do the anastomosis. Right. So this was about C esophagus. For stomach, the proximal margin should be more than 5 centimeters and distal margin should be till duodenum first part. Okay, it should be till duodenum first part. That is called D1, but I am not writing D1 because there is one more D coming in the way. Now, when we do gastrectomy, you also remove the lymph nodes. So if the tumor is over here, 5 centimeters above, till first part of duodenum, plus lymph nodes. Okay, plus lymph nodes. So what lymph nodes you remove is given by the name D1, D2, extent of dissection. D1, lymph node stations 1 to 6, D2, lymph node stations 1 to 6, and 7 to 11. And what is preferred is usually D2. D is dissection level. D is not duodenum. D means dissection level. Till what level you are going to remove the lymph nodes. So what we prefer to do is D2, lymphadenectomy. And after this, you will do anastomosis. That will be GJ. So then you will do anastomosis. That will be gastrojejunostoma. The job is done. And after both these, you will give chemotherapy. Right. So this is the treatment for CA stomach. See, in 10 minutes, we have covered two of the most important. It's not called Billrod 2. It is GJ. Billrod 2 is for peptic ulcer, where you do antrectomy and GJ. But yeah, kind of like Billrod 2 only. Kind of. But remember, Billrod 2 actually is for peptic ulcer. Now on to colorectal cancers, similar cancers. Risk factors are smoking, spirits, sepsis, diet. Sepsis here means problem in the gut bacteria. There will be a change in the gut bacteria. Like, people who have a lot of fiber, they have good bacteria, but people who have low fiber diet, constipation, red meat, or even alcohol, their gut bacteria becomes the bad ones and they can cause colorectal cancer. Pre-malignant lesion, adenomatous polyps, and ulcerative colitis. Ulcerative colitis most commonly affects which part of the bowel? Which part of the bowel commonly affected in ulcerative colitis? It's not colon, no, it is rectum. Okay, it starts in the rectum and then extends proximally. And there are two protective agents for CA colon. One is aspirin, other is metformin. Yeah, aspirin and metformin. So these are protective agents. They may prevent colorectal cancer. Now, overall colorectal cancer most commonly will occur in this area. You can see sigmoid 21%, rectum 38%. So overall most common site, rectosigmoid. Almost 60% will occur in rectosigmoid area. Almost. Remember, tumors on the right colon tend to have this shape, polypoidal. Smoking लिखा है. Okay, right-sided tumors, polypoidal. Left-sided tumors are going to be apple core like this. Correct. Left-sided tumors are going to be infiltrative or apple core. So polypoidal tumors will cause lower GI bleed. Infiltrative tumors will cause obstruction. So right-sided tumors bleed blood in stools. Left-sided tumors constipation. Rectal tumors, the first symptom is going to be bleeding. They cause blood in stools. Apart from this, they cause tenesmus. Tenesmus means he has a constant urge to pass stools. And sometimes they will cause early morning diarrhea, which is called a spurious diarrhea. Right? You will get a early morning spurious diarrhea. And they can spread to lymph nodes. Hematogenously, very important, they will spread to liver in 50% cases. Okay, 50% colorectal cancer will have liver metastasis. 50% liver metastasis come from colorectal cancer. Right? So most common mets to liver come from colon or rectum. That's why it's such an important cancer. Now, these are the clinical findings. The rest of the things are easy. Now you go to investigations. This is our second thumb rule. Patient who is having lower GI symptoms. Elective, not emergency. Lower GI symptoms. LGI means lower GI. like blood in stools or non-stop diarrhea, those kind of things. Prognosis same, poor prognosis, late symptoms. So first step here will not be endoscopy, here will be stool examination. In stool, you will see blood. Any patient in whom you see blood in stools, pus cells in stools, mucus in stools, this person must undergo colonoscopy. And if you see a tumor, you will do biopsy. Biopsy will be adenocarcinoma. Okay, so barring esophagus, all the other GI cancers are adenocarcinomas most commonly. So you will get adenocarcinoma now for staging. For local spread in colon, you prefer to do CT scan. In rectum, you prefer to do MRI. Okay, remember rectum, MRI, radiation, right? Because in pelvic tumors, MRI will be the preferred local spread. And you can give radiotherapy for pelvic organs. You must have studied cervical cancer also, prostate. You can give radiation because it's a safe area. So radiation will not cause much harm. And MRI is preferred for pelvic organs, right? So that will be the local spread. For metastasis PET scan, tumor marker is CEA, carcinoembryonic antigen. Correct. So that will give you the TNM stage. Now T here also stands for depth. And T1 means mucosa plus submucosa, T2 muscularis, T3 subserosa, T4A serosal breach, T4B surrounding structures. This is almost same as stomach. Almost same as stomach. There is just one exception, only one exception that you should know. If it is only mucosa, then it is not T1A. Okay, if it is only mucosa, then what is it called? It's not called T1A. It is called something else. Yes, only mucosa is called in situ. That is TIS, in situ. Okay, it is not a T1A for colorectal cancer. It is in situ, right? So that is a T stage. In olden days, there was a very nice simple staging, Duke staging. What he said, tumor invading mucosa, submucosa, call it Duke's A. This is like T1. Tumor invading muscularis, T2, T3, T4. He called it Duke's B. Spread to lymph nodes, he called it Duke's C. And later someone added Duke's D. That was hematogenous metastasis. Okay, that was hematogenous metastasis. Simple. So this Duke staging was actually very nice. Used to be used in the past. Now not used. Now we use TNM. But this name at least you should know. If you don't want to memorize the types, at least this name you should know, Duke staging for colorectal cancer. It was used before TNM was there, and they have asked this, right? So that is the investigations, the TNM stage. Then you come to treatment. Same logic, early cancer, first do surgery, then give adjuvant chemo. Okay, then give adjuvant chemo. Advanced colonic cancer, give neoadjuvant chemo. Okay, then give neoadjuvant chemo. Then do surgery. For rectum, you will give both neoadjuvant chemo and radio. So in rectum, you give MRI. In rectum, you can give radiation, then do surgery. Metastatic, do palliation. Okay, metastatic, do palliation. Now in colon, the resection is not just a number. Okay, it is based on the blood supply. It is a vascularity based resection. Okay, it is a vascularity based resection. If you want a margin, it should be more than 5 centimeters. But in reality, it is based on the blood supply. Like depending on where the tumor is, if the tumor is in the right side, the resection will be based on which blood vessels you are going to ligate. So you should know that the right side of colon gets blood supply from superior mesenteric artery. 3 arteries supply this area: ileocolic, right colic, and middle colic, left and right branches. Right? So these 3 arteries supply. You will ligate ileocolic at the origin, right colic at the origin, and right branch of middle colic. Okay, right branch of middle colic. These 3 will be ligated. all this area supplied by these three arteries, you are going to resect with the lymph nodes. So what you have ligated? Ileocolic and right colic at origin and right branch of middle colic. Okay. This surgery, when you are going to resect, it will be a radical surgery. This is called as radical right hemicolectomy. Remember, you will remove the lymph nodes, huh? So it's a radical surgery. You will call it radical right hemicolectomy. This is for tumors on the right colon. Similarly, if there is tumor in the transverse colon, proximal part, here you will ligate all the three arteries at the origin. Okay, ileocolic, right colic, and main middle colic. All three you ligate at the origin. So here you will ligate ileocolic, right colic, main middle colic at origin. Resect all this. It will be little more than what you did before, little extra resection. So this is going to be called as extended radical. Okay, it will be extended radical right hemicolectomy. Little more than a right hemicolectomy. And then you do the anastomosis. After this is resected, you do the anastomosis of the ileum with the colon. Third tumor will be left colonic tumor, descending colon or sigmoid colon. Blood supply of this area comes from inferior mesenteric. Okay, this was superior mesenteric. Now we have IMA, inferior mesenteric. This will supply the left colon. So you have left colic artery, sigmoid artery, and the last one is superior rectal. They all come from IMA. IMA lies at what level? At what level does the IMA lie? Hello. IMA lies at what vertebral level? No, don't say T12. IMA lies at L4, L5. You know why, na? Because horseshoe kidney gets stuck at L4, L5. Horseshoe kidney attack jata na udhar. That's where IMA lies. So you ligate left colic, sigmoid, sometimes superior rectal. All three, sometimes at origin. And then you resect. So this you will call as radical left hemicolectomy. And then you do the anastomosis. So for colonic cancer, depending on the location, you will do the blood vessel ligation, then you will do the resection, then you will do the anastomosis. Fine. Remember this, it's an important page. Something from this page often comes in the exam. So this is the treatment of colonic cancer. Last will be rectal cancer. Rectal cancer also you need a margin. Proximal margin more than 5 centimeter. Distal margin more than 1 to 2 centimeter. Okay, what is preferred will be 2 centimeters. 2 centimeter, of course, is preferred. If the tumor is in the upper rectum, means this is sigmoid colon, tumor is in the upper rectum, and this is the pelvic floor, the levator ani muscle. For tumors located in the upper part, you go 5 centimeters above, 2 centimeters below, remove everything. This is called as anterior resection. It is done fully from the abdomen. Okay, this is called anterior resection. It is done fully from the abdomen. And then you do anastomosis. Whenever you are doing anterior resection or whenever you're doing surgery for rectal cancer, behind the rectum over here are the lymph nodes and the lymphatics. That is called as mesorectum. That also you will remove. So it will always be radical mesorectal excision or total mesorectal excision. Means remove rectum with mesorectum, the lymph nodes basically. So for high lesion, you do fully from the abdomen. For low lesion, which is near the sphincter, so if this is the rectum here, and the sphincter starts here at the pelvic floor, this is the sphincter. If the tumor is very close to the sphincter, within 2 centimeters, then upper dissection you do from abdomen. But the lower 2 centimeters you have to do from below, partly from below. So you have to go from two places, abdomen also and perineum also. This is called as APR. No, mesorectum invasion is stage 3. But mesorectum you will remove, na? It's radical surgery. Mesorectum has the lymph nodes. So lymph nodes you will remove, na? That is called mesorectum. So if the tumor is below, you will do APR, abdominoperineal resection. And here, since the sphincter will get cut, you can't do anastomosis. And if you can't do anastomosis, you have to do a proximal colostomy. Okay, you'll have to do a proximal colostomy. This colostomy will be permanent. Right. Yeah, below levator ani, tumor near the levator ani, where you have to cut the part below the levator ani, you will have to do. No choice, na. This much removal, this part which is below the levator ani, you will have to remove from below. Right. You have to remove from below. That's why double approaches. Abdomen also, perineum also, for low rectal tumors. If you want to avoid doing this APR, if the tumor is very early, if it's a T1 tumor, very early tumor, you can try this. This can be tried if you have the facility. This is called transanal resection. Transanal total mesorectal excision, TATME. Transanal means you go from the anus. You don't take any incision. That is going from the anus. This will be a scarless approach. Correct? This will be scarless. Yeah, TURP, a poem jaisa. This is scarless. But only if it's a very early tumor and you have the facility to do it. Not everybody will have this instrument to do it, right? This is called TATME. Isme to everything is done from the anus, right? Today people can do many things from below, na? This is one of them. Now this is the treatment for CA rectum. 4 important cancers we have done. The most difficult cancers. Don't think any vulgar things you want to do from below. Please don't. Patient comes with progressive dysphagia, initially to solids and weight loss, and he is little old. What is the investigation of choice? If it is initially more to solids, you are thinking of CA esophagus. So answer will be upper GI scopy with biopsy. If it was a younger patient and the dysphagia was more to liquids, then the answer would have been manometry. Correct? If it was a younger patient. So see the question properly. This has been asked 3 times in the last 5 years. In the last 3 years, 3 times I have asked this. Constriction noted at 25 centimeters. What is the possible cause? It will be arc of aorta and left bronchus. Sometimes now, if both are there in the option, then see if you want to know exact. Arc of aorta exact is 25 centimeters and left bronchus exact is 27 centimeters. If both are there in the option, then I'm telling you. Otherwise, you take both as one only. Okay, you take both as one only. That is also fine. Now come to achalasia. It's the most common motility disorder of esophagus. And remember, it is not achalasia cardia, it is achalasia esophagus, where the lower esophageal sphincter becomes very tight. Ileus is very tight. Typically seen in middle-aged females, may be linked to Chagas disease or trypanosomiasis, and rarely linked to a syndrome called Algrove syndrome or AAA syndrome. A for Algrove, associated with adrenal insufficiency, alachrymia, achalasia, AAA, or AAA. But this syndrome is very rare. Clinically, it will be seen in middle-aged females more than males. Okay, females more than males. They will present with the classical triad dysphagia to liquids, weight loss, regurgitation. To this triad, if I add a 4th symptom, that is heartburn. Okay, if I add the 4th symptom, that is heartburn, I will get a symptom severity score called Eckhart score. Okay, it is called Eckhart score. I will try to revise as many scores as possible, okay, today only, so you don't have to study them again. In the exam, they love asking these barium images. So this is your smoother tapering with narrowing at ileus, body area. This is achalasia. Okay, keyword smooth tapering. Second one, sudden tapering with filling defects. This will be CE esophagus. Sudden tapering, also called as shouldering. Third one, esophagus is having this shape. Corkscrew esophagus. This is seen in diffuse esophageal spasm. See, in the exam now, they will tell you what they have done, or at least they will tell you the symptoms. Then you will know whether it is barium meal, barium swallow, or barium enema. They will tell you the symptoms. Based on that, you can predict. Okay, if you can't make out from the image whether this is esophagus or anus, then you can predict from the symptoms. Any person who comes with dysphagia, the first investigation will be upper GI scopy. And if you don't have upper GI scopy, you can do barium. Okay, you can do barium swallow, but wherever possible, do upper GI scopy. Investigation of choice will be manometry. You know how to recognize manometry, right? You can recognize manometry. This image shows over here of Hg. So you know it is manometry. On manometry, you will divide achalasia into 3 types based on Chicago. Okay, so Chicago classification for 3 types of achalasia: type 1, type 2, type 3. Where type 1 is the most common, the classical type. So this you will see on manometry, you will get the diagnosis. You will see high pressure at lower esophageal sphincter, ineffective peristalsis in body. That means it is achalasia. Now to treat achalasia, do I always treat? Is treatment a must? Answer is yes. Because it is pre-malignant. Right, so some treatment you will have to do. If it's a very early stage of the disease, you can give calcium channel blockers, you can inject Botox, or you can do endoscopic dilation. Yes, it is pre-malignant for squamous cell carcinoma. First slide of the day, squamous cell carcinoma. But definitive treatment will be Heller's myotomy. Okay, that is the treatment of choice as of today. In Heller's myotomy, you cut the muscle of the distal 6 to 7 centimeters of esophagus and 2 to 2.5 centimeters of gastric cardia. That's why it is called cardiomyotomy. Always here, spare the mucosa. Don't cut the mucosa. Otherwise, esophagus will be perforated. Right? Cut the adventitia, cut the muscle, spare the mucosa. It will become loose and relaxed. Food will pass. If it is type 3 achalasia, the preferred treatment is going to be POEM or per oral endoscopic myotomy. Per oral means you go from the mouth into the esophagus, open the mucosa a little, then do the myotomy from inside. And here you will spare the adventitia. Into out, correct. So this will be your scarless surgery. Correct. Also called as NOTES surgery. Natural orifice transluminal endoscopic surgery or NOTES. Simply put, scarless. No cuts will be there. Many times whenever I do achalasia and Heller's myotomy, I often have a risk of GERD. So I often add a prophylactic fundoplication. Many times many surgeons will do this. Okay, prophylactic fundoplication. And the preferred fundoplication here will be 180-degree door or 270-degree toupee. Normally, we don't do floppy Nissan in this case. Normally, no, it will be door or toupee. So what are the fundoplications that we do in GERD? If I ask you treatment of choice of GERD, answer is going to be medical management. Okay, treatment of choice is medical plus lifestyle. But when will I offer the person surgery? If he has severe symptoms. Give example of severe symptom of GERD. Severe symptom like, very good, regurgitation or volume reflux. Okay, regurgitation or volume reflux or water rash. Such symptoms means it is severe, or if he has complications. Complications like hiatus hernia, Barrett's esophagus. These patients, you will tell, sorry, let's not give PPI. Let's do something more aggressive. That is called fundoplication. The earliest fundoplication that used to be done was called floppy Nissen, where you would do a 360-degree wrap. It was a 360-degree complete posterior wrap. Okay, so you take the fundus from behind, 360 degrees like this, and wrap it. So it is posterior 360 degree. Problem was, if the wrap became too tight, you would get short-term dysphagia. It is because of the edema of the wrap. Now, if it is short-term, it's okay. Means fine. After some time, it gets better. No problem. It would last for 3 months. But if it lasts longer than 3 months, it's a problem. You will have to undo the fundoplication. You'll have to open the stitches, the acid reflux will come back. Other complications, which some people consider to be the most common, is gas bloat syndrome. Patient will say he is unable to burp. Right? He feels air is stuck in the stomach. That is called gas bloat. So these are the two common complications, which is why now surgeons became conservative. They started doing partial wraps. Okay, they started doing partial wraps like a toupee. You paid 270. Wow, 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 wow. So you do a partial wrap like a 270-degree toupee. One second. So it's a 270-degree posterior wrap, that is toupee, or 180-degree anterior wrap, that is door. The main advantage of these partial wraps is the risk of dysphagia is much lower, right? All of these are image-based questions. They can ask this in the exam. Door at 180, you pay 270, आधा वर्जन. ऐसे निमोनिक मिल गए ना एग्जाम में तो लाइव बन जाएगी. Now, one of the complications of GERD is hiatus hernia. Remember, whenever we see hernia, the question we ask is, where is the defect? Defect is the esophageal hiatus in the diaphragm. Okay, defect is the esophageal hiatus at the diaphragm, means this. This is the defect. The first type is the type 1 or the sliding type. This is the most common type. In this, the esophagus got contracted fibrosed because of GERD. So the esophagus became shorter. So the GE junction got pulled up. And this is the one which you see in patients with GERD. This is due to GERD. This is type 1. Overall, the most common type. Second one, the esophagus has not gotten shortened. Here, the diaphragm has become weak. So the stomach is going from the side of the esophagus. This is called rolling type or para-esophageal type. Okay, or para-esophageal type. This is due to muscle weakness. Now, most people will have both. Most people will have muscle weakness also. They will have GERD also. So this will be mixed. It will be type 1 and type 2 both. That is a mixed type, right? So these are the three types you should know. There is a type 4 also. Anybody knows? Type 4 hiatus hernia. किसी को पता है? There is a type 4, huh? But it's extremely rare. Type 2, nothing is pulled up. In type 2, G junction is normal. The stomach goes up from the side. So nothing is pulled up. There is a type 4 in which other organs go up. Other organs like liver or transverse colon, if that goes up, that is type 4. Okay? No, it's not cardia. It is the stomach which is going up from the side. Now, any person with a hiatus hernia, if they ask you investigation of choice, it's not going to be endoscopy. It will be CT. Okay, CT with oral contrast. Okay, it will be CT with oral contrast. And if this is not there in the option, next best answer will be barium swallow. Basically, you have to give oral contrast to diagnose hiatus hernia. Like you can see here, the stomach has gone up in the chest above the diaphragm. Diaphragm के ऊपर चला गया. So this will be a hiatus hernia. And the treatment for hiatus hernia will always be surgery. ठीक है, always surgery. Hernia equal to surgery, right? Second complication is Barrett's esophagus. This is due to long-standing GERD when the epithelium becomes columnar. It has goblet cells, right? You can see over here. This is the normal G junction, and here the G junction has gone up like this. There are tongue-like projections at the G junction. So this is going to be Barrett's. This image was asked in INI-CET. And this mucus secreting goblet cells was FMGE PYQ. All of this has been asked. Patient will have symptoms of GERD. You will diagnose by doing endoscopy. You will get this appearance, tongue-like projections. And what will you do? You take multiple biopsies. Okay, it's not single biopsy. You take multiple biopsies as per Seattle protocol. So you have to take 4 quadrant biopsies at 1 to 2 centimeter intervals each. So you start from below, 4 quadrant biopsies, then go 2 centimeters up, take 4 more biopsies till the top of the Barrett's, right? Because you want to ensure, is there any dysplasia? Because the treatment depends, is there any dysplasia or no? If there is no dysplasia, then just do endoscopic surveillance. If there is low grade dysplasia, it has to be removed, endoscopic resection or radiofrequency ablation. And here your endoscopy will be every 6 months, not every 3 years. So anytime you see dysplasia should always be removed. And if there is high grade dysplasia, means dangerous student like some of you, you will do a multidisciplinary discussion, and this will also have to be resected. Here the surveillance is not defined. Resection is more important because this is high grade dysplasia. Remember, in high grade dysplasia, risk of cancer is 7% per year. Okay, high grade dysplasia, risk of cancer 7% per year. Right. So here also it will have to be resected endoscopically or surgically, depends on how big it is. If it's very big, you may have to do surgery. So this is the treatment of Barrett's IMP topic. Now answer this. Yes, 7-letter Barrett's. But you better know spelling of Barrett's, huh? And it is not Barrett's, it is Barrett. उसमें 2 T आते हैं, आपके Barrett में एक ही T है, लफड़ा हो गया. So scomocolumnar junction is located proximally, means this is a type 1 or a sliding hiatus hernia. Okay, this is type 1 or sliding. Rolling and paraesophageal both are the same. That is type 2. Okay? Okay. Now come to other benign conditions. One is infantile hypertrophic pyloric stenosis. है ना? Infantile hypertrophic pyloric stenosis. It is called infantile because it will be seen in children usually in the third or fourth week. It's not at birth. And the child will present with non-bilious projectile vomiting. Very famous. So stomach will become very big, pylorus will be very narrow, and the child will vomit normally from the third or fourth week after birth. When you will examine him, you will feel a mass, olive-shaped mass. Okay, olive mass in the right upper quadrant. When the baby is relaxed. Relaxed means the baby should either be feeding or he should be sleeping. He should not be awake and screaming. Second thing, when you give him a test feed, you will see peristalsis from left to right when you are giving him a test feed. So these are the clinical markers of pyloric stenosis. Investigation of choice will be ultrasound. Pylorus will be more than 4 millimeters. You can see this one. Pyloric thickness more than 4 millimeters. This means it's a pyloric stenosis. You will, of course, check the electrolyte problem, the very famous electrolyte abnormality, hypokalemia, hypochloremia, metabolic alkalosis. Right, metabolic alkalosis. This imaging, you don't do it, but they can ask in the exam. This is a barium meal. This is showing mushroom sign. Again, this is not something you will do. It's only for exam purposes. This is a X-ray abdomen showing air in the stomach. This is called single bubble sign. Okay, again, no need to do X-ray. Okay, no need to do X-ray. The treatment of choice, the surgery is going to be this. You cut the muscle of the pylorus. This is called Ramstead pyloromyotomy. No, length nahi. Length should be more than 16 millimeters, but don't remember the length. Remember the diameter, the thickness. Okay, this surgery is called Ramsted's pyloromyotomy. Okay, where you cut the muscle of the pylorus, don't cut the mucosa. Mucosa has to be spread. So this is going to be the management of pyloric stenosis. Remember, similar condition in a 4-week-old child where the vomiting is non-projectile and the abdomen is normal. What is that condition? 4-week-old child gets regurgitation, non-bilious vomiting, 4-week-old, but abdomen is normal. That is neonatal GERD. Okay. No, not Hirschsprung. In Hirschsprung, there is constipation. In atresia, it is at birth. Atresia bachpan mein hogi na, it will be at birth. That is neonatal GERD. Child, when the child is born and you feed him, you always burp him so that he does not regurgitate. उसको डकार कराते हैं ना, burping कराते हैं. That is to prevent neonatal GERD. So if abdomen is normal, everything else is the same, 4-week, 5-week-old child, then think of neonatal GERD. Okay, then it is not pyloric stenosis. Okay, answer this. This question has been asked 3 times. So 30-year-old dysphagia, you are seeing a barium image where the tapering is gradual. Gradual tapering. So this is going to be achalasia. Okay, this is going to be achalasia. अभी ठीक है? लैग दिख रहा है ना? I don't know. Are there so many people watching? I am surprised. No, my internet is full 100%. There is no problem. It's not even raining. बारिश वारिश भी नहीं है इधर. There are around 500 people I can see here. I don't know how many are on YouTube. YouTube का नहीं पता मुझे. But here there are 500 people. 400 and something I can see. अच्छा, ठीक है. Acha, 150 on YouTube are there? My God, that's a lot of people. Few days I was seeing other teachers, there was 50, 60 people. Okay. Anyways, no Jalwani, because people take this seriously. Maybe that's why. People are scared also. That's why it's the fear more than anything else. So what about peptic ulcer treatment? Again, peptic ulcer, the most important risk factor is H. pylori or smoking or NSAID. They are the important risk factors. Now, when patient has peptic ulcer, you are going to do endoscopy. So first step is going to be UGI. You will see the ulcer and you will always take a biopsy. Okay, you will always take a biopsy of the antral mucosa. That is the H. pylori. It is called rapid urease test. Okay, it is called rapid urease test. Means you take antrum, you take a piece of the mucosa, put it on the slide. If the slide turns pink within a few minutes, the test is positive, means H. pylori is positive. Right? So H. pylori ऐसे diagnose करेंगे. Now for treatment, the treatment of choice is going to be here also medical. It will be PPI and you will give H. pylori eradication. No, urease breath you will do if you have not done endoscopy. Any person you want to diagnose H. pylori, you can do urease breath. But if I am doing endoscopy, then obviously I will do biopsy, na? Obviously. Then that's the best way to get it. So you have to understand what the question is saying. Are they saying endoscopy? Then it will be antral mucosal biopsy. This slide is always antral mucosal biopsy only. इस पे breath नहीं डालेंगे. Right? So that is going to be the treatment of choice. When will you offer surgery? If the person is having intractable symptoms or uncontrollable symptoms. So intractable peptic ulcer disease, or if he gets complications. Same like GERD. So if he gets a bleeding or a perforation, that's where you will think about surgery. Yeah, breath test can be done after treatment also. Correct. Basically, breath test will be done when I'm not doing endoscopy for follow-up, or any person wants to know H. pylori hai ki nahi, then you don't need to do endoscopy. But if you are doing endoscopy, obviously you will do biopsy. No doubt about it. Right. Now, when you are doing surgery for peptic ulcer, if it's a gastric ulcer where the acid is normal, then the surgery you are going to do is not to reduce the acid. The surgery you are going to do is going to be to resect the ulcer. That's it. So for gastric ulcer, the treatment is ulcer resection. But for duodenal ulcer or Johnson type 2, type 3, where the acid is high, they are due to hyperacidity. For these ulcers, you will do acid lowering. Okay, so the surgeries which are acid lowering, vagotomy, antrectomy, they are done for duodenal or for Johnson type 2, type 3, where the acid levels are high. So how do you lower the acid? Either you can do vagotomy or you can do antrectomy. These are the two principal surgeries, or you can do combination. Vagotomy also, antrectomy also. Vagotomy is of two types. One is you do truncal vagotomy. Trunk means go in the abdomen, divide the anterior and posterior vagus at the GE junction. Correct. Yes, very harsh, very aggressive surgery. Divide the anterior and posterior vagus at the GE junction. Problem is, whenever you divide it, all these nerves will get destroyed. Even the pyloric nerves will get destroyed. Now the pylorus will not open. Pylorus will go in spasm. So whenever you do a truncal vagotomy, there will be pylorospasm. The peristalsis will reduce, which is why a drainage procedure has to be done. So it will always be truncal vagotomy and drainage, which means you may do a pyloroplasty. That is one. Or you can do a GJ. One of the two. And if you are going to do drainage, dumping will be there more. Risk of dumping increases. And acid lowering is good. Good acid lowering but high risk of dumping, high risk of complications. Anastomotic problems can also occur. If you don't want all this, then a milder surgery is highly selective vagotomy. It is little milder. Here you divide individual branches. Okay, so here you will divide these chote small branches individually and spare the pyloric nerves. So don't cut the pyloric nerves. So pylorus function will be intact. So here you spare the crow's feet. That's why you are going to do surgery where drainage is not required. And if you don't need drainage, lesser risk of dumping. Right, drainage is not to prevent dumping. Drainage procedure will cause dumping. Because when you do a GJ, food will get dumped. Na? Here I don't need to do a GJ. So no drainage, lesser complications, lesser risk. So this is the best tolerated procedure. But yes, some acid lowering may not happen. Okay, it may not lower 100% acid. It will reduce 50-60%. This will reduce 80-90%. Highly selective, some nerves may be left. So it may be 50-60% effective, which is okay. Baki ka you take PPI, no problem. But complications are very less. So these are vagotomies. Other way to reduce the acid is antrectomy. Whenever you do antrectomy, you resect the antrum. This will reduce the gastrin. And this will reduce the acid. So your acid lowering is by antral resection. And after resection, if you do this joining, if you join the duodenum to the stomach, this is called Billroth 1. But instead, if you just close the duodenum and join the jejunum to the stomach, that is called Billroth 2. Obviously, Billroth 2 is easier to do, easier to perform. So Billroth 1, Billroth 2 are basically antrectomies plus anastomosis. But if I want more acid lowering, if I want to reduce the acid more than truncal vagotomy, more than antrectomy, if I want a maximum acid lowering, I will do combined. Okay, so if I ask you max acid lowering, it will be by combined procedures. Means you do vagotomy, truncal vagotomy plus antrectomy. Needless to say, it will also have max complications. Right? With great power come great responsibilities and more stress. So your complications will also be maximum. Right? If I ask you least complications, it will be highly selective vagotomy. So obviously it works hand in hand. Now, what was this dumping? Dumping happens after these gastric surgeries. So where the food gets dumped in the jejunum. And that can cause two problems. One is early dumping, which will happen almost immediately. Why does this happen? Early dumping reason. It is due to what problem the person gets. It happens due to hypotension after certain food. He eats certain food, Coca-Cola, fruit juice, refined flour, bread. It will cause hypotension because of the osmotic effect. Because of hypotension, he will start getting epigastric fullness, lightheadedness, sometimes diarrhea. It will be relieved by lying down and by elevating the legs. Improve the blood flow, he will be fine. It takes a few minutes. But obviously, he will get very scared when this happens, because he just collapsed. Imagine eating food and within a few minutes collapsing. That is early dumping. Late dumping happens because of hypoglycemia. And this will happen after about 1 to 2 hours. That is why it is called late dumping, where you are eating foods which cause sugar spike, which will cause reactive insulin spike, which will cause hypoglycemia. This also will be relieved, but here you will have to eat more food to relieve it. Here the symptoms will be of hypoglycemia, like tremors, fainting, palpitations. Those hypoglycemic symptoms will occur. If you want to treat both, you have to avoid the triggers. Okay, the triggers have to be avoided. He cannot have fruit juice, Coca-Cola, alcohol. Those things have to be avoided. Right? So this will be the management of dumping. Okay, answer this. Duration of late, all these attacks last for a few minutes, but late dumping will be after 1 hour. Early dumping within a few minutes, it will come. Which of these causes the least side effects? It will be highly selective vagotomy. I am trying to discuss as many PYQs as possible. Na? If you'll see the PDF, na, as many recent PYQs as I can, I'm going to discuss. So at least those fresh topics, if they come in couple of days, those you won't make mistaken. So patient long clinical stem. But which artery is responsible for bleeding from a posterior duodenal ulcer? Posterior duodenal ulcer will erode GDA, gastroduodenal artery. Okay, so if the ulcer is over here in D1 on the back side, there is one artery which runs like this on the back side. This is the GDA, and this will cause the bleeding. How do you manage this bleeding? After stabilizing, what will you do? Yes, anterior perforate, posterior bleed. After stabilizing, you will do UGI-scopy. And in UGI-scopy, you will see the bleeder. What will you do? How will you stop the bleeding? No, no, no. Banding is for varices. Here you don't do banding. You can clip, you can coagulate. Coagulation is called argan plasma. Or you can inject adrenaline in the ulcer. Okay, inject adrenaline. But you have to do any 2 out of 3. Okay, 2 out of 3 have to be done. This is called dual endotherapy. Okay, remember in varices, you only need to do binding or sclerotherapy, one of the two. Here you have to do both. 2 out of 3 things have to be done. That is called dual endotherapy. If you just do one of the 3, chances of him bleeding again is more. Okay, he can bleed again more commonly. That's why dual is preferable. When you come to peptic ulcer perforation, anterior ulcers perforate. There will be peritonitis. Person will come with acute abdomen. There will be cardboard rigidity. He'll have history of peptic ulcer. Okay, history of peptic ulcer means he will be taking antacids or he may be taking painkillers for headache or something. Some peptic ulcer history will be there. He comes with a rigid abdomen, peritonitis. First step after you stabilize, what are you going to do? First stabilize and do X-ray. Very famous X-ray. If you see this right dome of diaphragm, black thing below, that is pneumoperitoneum. So if pneumoperitoneum or free air is seen, okay, if free air is seen present, then straight away do surgery. Surgery is this Graham's closure. If free air is not seen, then what will you do? So free air seen surgery, Graham's closure. But if free air is not seen and you're suspecting perforation, then you do CT scan. Okay, CT is the investigation of choice. Yeah, it is Graham's omental patch. Yes, same thing. But Graham's omental patch is for DU perforation, as you are seeing in the photo. If it's any other perforation, you can just primarily repair it. Then just do suture repair for other small perforations, right? But for DU perf, of course, you will do a omental patch. What is this? 38-year-old presented with 1 year history of low-grade fever, anorexia, weight loss. Similar question was asked in Jan 2026 also. Very similar. Only there they had given a CT scan image. So here they have given you barium. What you are seeing is pulled up IC junction. Okay, pulled up IC junction. Low-grade fever means it will be a ileocecal TB. This narrow terminal ileum, what is it called? Simple repair, primary repair is the same. What is this narrow terminal ileum called? This area. It is called string sign. Okay, the same string sign, if you see in Crohn's disease, it is called string sign of Cantor. But that Cantor comes in Crohn's. In TB, it is just called string sign. So how do you get intestinal TB? Most common site, ileocecal junction. How did it reach the ileocecal junction? Swallowing sputum. You had an active TB, you swallowed the sputum, it reached the IC junction. So it is a secondary TB. There are two types or two effects. One is you will get ulcers. That is called ulcerative type. This one. You can see the typical shape of the ulcers. Transverse ulcers, classical. So terminal ileal transverse ulcers is going to be ulcerative TB. Second type is called hyperplastic cecal TB. Okay, that is hyperplastic cecal, where there is inflammation, fibrosis, thickening. That is hyperplastic cecal. What will be the effect of all these problems? He can get a stricture, like you're seeing here. The ulcers will form stricture as they will narrow. So there can be stricture, which can cause obstruction. These ulcers can also perforate. So there can be perforation, ascites. Yes, in typhoid, the ulcers did not cause stricture. In typhoid, the ulcers were like this. This is in typhoid. Longitudinal ulcers. Okay. Now, how will you diagnose the person? If he is a stable patient, means his presentation will be long-standing diarrhea, plus pain, plus weight loss and fever. So chronic presentation. In this patient, first you will do stool examination, then you will do colonoscopy with biopsy. And what will you do with the biopsy? What will you do with the biopsy? You send it for, yes, very good, CBNet and liquid culture. Okay, one is CBNet, other is liquid culture, which is called MGIT, right? So CBNet and you can do MGIT or liquid culture. Stool will show pus cells. It will not show any organisms. But if he presents with acute abdomen, in acute abdomen, please don't do any liquid culture, stool and all. Here you will first do X-ray, acute abdomen protocol. Then if required, you will do CT. And if it's a perforation, you will operate. If it's obstruction, you may have to operate. Depends on the CT findings. So the acute presentation treatment may be surgical, right? So this will be the management of intestinal TB. Very simple now. Then come to acute appendicitis. So you have three thumb rules. Huh? Upper GI for dysphagia, regurgitation, stool routine, followed by colonoscopy for diarrhea or blood in stools, acute abdomen, X-ray followed by CT, where applicable. Now come to appendicitis. Very easy topic, but important topic. It is seen in young patients, usually teens and 20s. Okay, usually in teens and 20s, where the person will come with right iliac fossa pain, plus little bit of fever, plus little bit of fever, plus vomiting or nausea. What is these three things together called? This is called Murphy's triad. Where do you get Murphy's sign? Where you get Murphy's sign? That is right upper quadrant tenderness in cholecystitis. Okay, right upper quadrant tenderness in cholecystitis. So appendicitis, young patient like you, right iliac fossa, pain, fever, vomiting or nausea. When you will examine, maximum tenderness will be at McBurney point. It is a point of maximum tenderness. It is on the right side, spino-umbilical line, 2/3 distance, means somewhere here. This is a McBurney point, 2/3 from the umbilicus. Second, you will get Bloomberg sign, that is rebound tenderness. Means you will press, when you will release, he will get pain. Pain on releasing the hand. Third is Rovsing sign. You press in the left, he gets pain in the right. That is Rovsing. Press in left iliac fossa, he gets pain in right iliac fossa. And the fourth is psoas sign. He gets pain on hip extension. So when he comes, the hip is flexed. When you try to straighten it, when you try to extend it, he gets pain. Okay, yeah, reverse is obturator. The reverse, pain on hip flexion and internal rotation is obturator. But psoas is more common because psoas sign is seen in retrocecal appendix, which is overall the most common appendix. Retrocecal में या pelvic appendix में, you will get a psoas sign. You may get a psoas sign. Rovsing sign is not specific. It is not due to peritonitis. It is an appendicitis. सारे appendicitis के ही signs हैं. Nothing to do with peritonitis. Investigation of choice in children will be USG, which you are seeing here. The appendix will be thickened. The diameter will be more than 6 millimeters. There can be edema of the wall and all those inflammatory changing also. In an adult, IOC will be CT. In a pregnancy, IOC is MRI, but rarely ever needed. Usually ultrasound is enough. Okay, usually ultrasound is enough. If you don't have ultrasound, what can you do? No ultrasound. If no ultrasound available, then how will you diagnose appendicitis? Hello, excuse me, give the answer. Yes, thank you. You do what is called as Alvarado score. Okay, you use a Alvarado score, also called as Mantrel score. Okay, you use Mantrel score. If Mantrel score is more than 7 out of 10, appendicitis is likely. Yeah, in pregnancy, you will do surgery and diagnosis. Correct. It will be means don't wait for the pregnancy to get over if that's what you are trying to ask. You don't wait, you do surgery. So, management of appendicitis, lap appendicectomy, preferred to open appendectomy. Open भी कर सकते if you don't have laparoscopy, right? But preferred will be lap appendectomy. If it's a appendicular phlegmon, then you don't do surgery, you do what is called as Ochsner-Sharon regimen, conservative management of appendicular phlegmon. And later, when the phlegmon settles, then you will do appendectomy. Later, you will do interval appendectomy after the lump disappears. Okay, you will do interval appendectomy. Preferred surgery in pregnancy, lap appendectomy. It's lap only. Of course, it's risky, but mother's life before child. Na? So for the mother, you will do what is the best treatment. Now, in open surgery, there are 3 incisions we should know. First is McBurney, also called MacArthur or Gridiron. They are all the same. These are muscle splitting incisions. You split the flank muscles, that is external oblique, internal oblique, transversus abdominis. They are going to be split. If you can't see the appendix, you can do muscle cutting or Rutherford-Morrison incision. And Lance's skin crease is a cosmetic incision. If they ask you most common early complication of appendectomy, it is wound infection or surgical site infection. Most common late complication, adhesive obstruction. Okay? By looking at the image, how do you know this is appendix? How do you know this is appendix, not Meckel's diverticulum? Meckel's looks like this only, na? First thing, appendix has this yellow thing on the side. That yellow thing is the mesentery of the appendix. It is called a mesoappendix. Okay, it is called mesoappendix. Second thing, appendix comes from this big organ over here. You can see it has this white thing on top. So this is cecum. And the white thing on top is the tinea coli. Okay, that is tinea coli. The incisions of appendectomy, this is McBurney point. So your gridiron or your Rutherford Morrison will have this shape. So same shape, same site. One is splitting, one is cutting. Lance's incision will be here, skin crease. So this one is lance. Okay. The ones that are in red, that is your McBurney or Rutherford Morrison. Location is the same. Hmm. Now it will make sense for the question that I was asking. During appendectomy, this finding was seen. This is Meckel's radiculum. Now you can compare, na? Here there is no mesentery. In fact, it is arising from the anti-mesenteric border of the small bowel. See, it is not coming from cecum. It is coming, this is small bowel. Maybe it is ileum, but it is small bowel. This yellow thing you are seeing, that is the mesentery of the small bowel. इस पे कहाँ tinea coli है? There is no tinea coli on it, na? So this is small bowel. So Meckel's comes from small bowel. Appendix comes from cecum. If you find incidentally, what will you do next? Next step. Incidentally found Meckel's. What is the next step? Do nothing. Okay, leave it. छोड़ दो उसको. ठीक है, just let it be. Nothing needs to be done. Answer this. 45-year-old female with history of constipation undergoes imaging as shown. So constipation, and what imaging is this? Now someone can answer. You were asking before, na? So this big thing that you are seeing, this is rectum. Okay, and you can see contrast going from the rectum into the sigmoid colon and descending colon, which is on the left side. So that is why this is barium enema. Don't say barium meal, please. Barium will not go in meal all the way till the rectum. This is barium enema. This appearance is sawtooth appearance, sigmoid diverticuli. Right? In sigmoid, the only thing you should know is going to be Hinchi classification. This one thing you should know, Hinchi. It is a classification of perforated diverticuli. So when these diverticuli perforate, the grading is called Hinchi. 1, 2, 3, 4. In grade 1 Hinchi, there is going to be pericolic abscess. In grade 2, the abscess has gone into the pelvis abscess. In grade 3, there is purulent peritonitis. So peritonitis is there, but it will be purulent. And in grade 4, there will be fecal peritonitis. Obviously, as it is becoming more grade, it is becoming more severe. So the grading tells you the severity of the condition. Fine. Before rectal prolapse, I'll just talk a little bit about one topic someone was asking. One is Mallory-Weiss tear. And second is Boerhaave. They are not at all similar. Not at all similar. Mallory-Weiss is a tear. Tear means person has a lot of retching. He has a lot of alcohol, lot of retching. Then he gets hematemesis. And because of hematemesis, he will get scared. But usually it's a mild bleed. There is a tear at GE junction. Tear means only mucosa tears. Nothing happens. This is self-limiting. Even if you do endoscopy, okay. Boerhaave, person he is unable to vomit. There is vomiting against a closed sphincter or closed epiglottis. This is also seen after binge drinking. So both of these are related to binge drinking. But here he tries to vomit. He is not able to vomit. And because of this, there is a tear in lower esophagus. I won't use the word tear. I'll say perforation of lower esophagus. Now, since it is perforated, there will be leakage of contents. Okay, there will be leakage of contents, and this will present with the macular triad. It is because of the leakage. So here he'll have pain plus retching plus subcutaneous emphysema. Okay, so here there is no hematemesis. At least it's not expected. And this patient will be very sick. He's not going to come walking. Okay, he'll be a very sick patient. So here the IOC after you stabilize him will be CT with oral contrast. This oral contrast has to be a safe oral contrast. Huh? You cannot use barium. You have to use contrast like gastrographin. Something safe that even if there is leak, okay, no problem. And here the treatment of choice will be surgery. And this is not a very easy surgery. Opening the chest and closing the perforation is not a very easy thing to do. So this is a dangerous surgery and this is a dangerous disease. This has a high mortality. The person who got Boerhaave, after him the name was made, that person died after the Boerhaave perforation. It was found on his autopsy. ठीक है, autopsy पे आया उसके that he had a esophageal perforation after binge eating and binge drinking, right? So वो खुद इंसान मर गया था जिसको Boerhaave हुआ था, जिसके नाम से the condition is made. This is a very easy topic, rectal prolapse. In rectal prolapse, the rectum comes out of anal verge. Why does this happen? Why does the rectum fall? And it comes out like this, scary looking, bhayanak. It is due to pelvic floor weakness. Okay, it is due to pelvic floor weakness. So usually it will be seen in old people or people who are malnourished or people who have had multiple deliveries, obstetric trauma. है ना? So pelvic floor weakness is the basic problem. Same thing happens in uterine prolapse also. Uterine prolapse, same problem. Now here, if he comes with this, obviously you push it back surgically. So treatment is only one, that is surgery. और तो कुछ option है नहीं. Surgery can be done in two ways. Either you operate from below, perineally, or you operate from abdomen. Perineal procedures are preferred in unfit patients, elderly unfit, because the recurrence is high. So, ठीक है, no problem. There can be recurrence, but okay, they are safe procedures. One of the old procedures is called Thiersch's anal wiring. So you can see this image. He would do what you all like to do, ungli. So with the ungli, he would push the prolapse back. And on top of the ungli, he would take a stitch like this. A stitch like this. Circumferential stitch. That is called as purse string stitch. So he'll take a purse string stitch at the anus and make the anus tight. So prolapse has gone inside the anus and he has just made the anus tight. Obviously, this is a very gory procedure. These patients would have a lot of problems like a anal narrowing, obstruction. It was very common. So this surgery didn't work in the long run. Now it is not done. And originally he used to put a steel wire. This was the original Thiersch's anal wiring. He would use a steel wire. Nowadays we don't use steel wire. If you want to do it, you will use nylon. Nylon is ethylone. You can do a ethylone and do a purse string stitch. Second procedure, which is preferred for strangulated prolapse, is Altemeyer. In this, he does a stapled rectal resection from below. So he uses a circular stapler and whatever prolapse is there, he excises it. तो उसको निकाल दो. Cut it, excise it. That is called Altemeyer's rectal resection. And the third one, this is called Delorme procedure. So here there is no resection. Here he is taking stitches like this on the prolapse and making it shorter. He's reducing the length of prolapse by taking plication stitches. Okay? So don't confuse the two. In Thiersch, it is purse string. Purse string means circumferential. In Delorme, they are longitudinal, that is plication stitches. So here he will shorten the prolapse. Okay, here he will shorten the prolapse. So these three, mnemonic is TAD, Thiersch, Altemeyer, Delorme, are done from below. In today's day and age, none of these are done. In today's day and age, everybody is going to be young and fit. So even if you are 70 years old, you will say, I'm young. And if you are physically fit, then you go abdomen. And in abdomen, what you will do? You pull the prolapse up and you fix the rectum with a mesh. That is called mesh rectopexy. Two names you should know of mesh rectopexy, Wells and Ripstein's. So you fix the rectum to the sacrum with a mesh. However, nowadays we put the mesh laparoscopically. That is called laparoscopic ventral mesh rectopexy. This is the most commonly done treatment in today's day and age. What mesh do you use? What mesh is used in mesh rectopexy? Chance of recurrence negligible. Here you use proline mesh only. Yeah? Even though you are putting it in the abdomen, even though it is intra-abdominal, you will think, but sir, आपने तो बोला है IPOM में you use composite. That is different. Here you are placing it near the rectum. Nothing else will get stuck to it. So here it will be proline only. Okay, this mesh is proline. It is not IPOM mesh. IPOM mesh is composite mesh. Okay. Now come to paralytic ileus. After this, I'll give you shorter break. But first, we'll do 1-2 more topics. Small break, don't worry. Proper break will only be lunch break. I think around 1:15, 1:30 or so. बाकी सारे ब्रेक छोटे छोटे होंगे 5-10 minutes only. If you want, you study in that period when I give you the chota break or revise the topics that we have done. So first is paralytic ileus. This is a functional obstruction. Okay, this is a functional obstruction. And here it is not going to affect any one part of the bowel. It will affect multiple parts. So entire small bowel with colon can be paralyzed. Most common risk factor is laparotomy. Most common electrolyte problem, hypokalemia. Okay. Intestinal rule. Intestine, electrolyte, hypokalemia. 99% it will be this. Any intestinal disease. Pyloric stenosis was also hypochloremic alkalosis. This person will present, he'll have history of laparotomy. He'll be still in the hospital 2-3 days ago. Now he's having vomiting, distension, constipation, but no colicky pain. Colicky pain is a feature of mechanical obstruction, not paralytic ileus. Okay, this question was asked in INICET. So colicky pain won't be there. Other findings will be there, distension and all. When you will examine him, bowel sound will be absent. Any post-op patient after 2-3 days, if bowel sounds are absent, consultant will be worried. He'll be like, oh no, he has a paralytic ileus. He will do an X-ray abdomen. And on X-ray, one of these two findings are expected. First one, air fluid levels, step ladder pattern. If you see step ladder pattern, it is not a paralytic ileus. It is a mechanical obstruction. Okay, it is a mechanical obstruction. It means maybe there is a stricture or something. And here he will do CECT abdomen. Okay, here he will do CECT abdomen because he wants to know where is the obstruction. Does the person require surgery for the obstruction? So here he will do CT. Second image you are seeing, dilated bowel, but air has gone all the way till the rectum. So this is no step ladder and air all the way till the rectum. This is paralytic ileus. Which is worse, paralytic ileus or mechanical obstruction? Which is worse? Mechanical, obviously, because in mechanical obstruction, first you have to do CT. Second, you may have to do surgery. Paralytic ileus, no need to do CT, no need for surgery, just do conservative management. Job is done. ठीक है? Conservative management will be sufficient. No need for surgery in paralytic ileus. Okay, cool. ठीक है, we take short break, 10 minutes break. See you in 10 minutes. Then we'll complete intestinal obstruction and then we'll go to the rest of the GIT. Hello guys, let's move on. Shall we move on? Okay, so paralytic ileus IMP topic, it's a functional obstruction. It can affect any part of the bowel, right? Now, in mechanical obstruction, usually it will be at 1 or 2 points. It will be fixed areas. So one of the important mechanical obstructions is intussusception. Intussusception means there will be telescoping of bowel. Means bowel goes into adjacent bowel. Okay, that is called telescoping. Now, why it is important? Because there is something very unique. When bowel goes in adjacent bowel like this, the inside bowel, which is called intussusceptum, it can get strangulated. So this intussusceptum, the bowel which has gone inside, is at risk of ischemia. In children, the usual intussusception is ileocolic. Overall, this is the most common type. It is due to hypertrophic Peyer's patch. In adults, it is colocolic, which is due to polyps, colon going into adjacent. So these are the types of intussusception which are common. Usually the one that we see is the child one. It will be a child who will be between 6 months to 12 months of age in the weaning period. When the child is started having other things, he gets a GI infection, the Peyer's patch become hypertrophic, the intussusception starts. And when it will start, it will be an acute presentation. The child will start crying suddenly, loudly. He will lift his legs, and the stools are going to be red currant jelly. Classical finding, red currant jelly stools. When the pediatrician will examine the child, he'll get some classical features. Umbilical mass, it will be sausage shaped. Right iliac fossa will be empty. This is called sign of Dance. Right, because the intussusception has moved away towards the paraumbilical area, sign of Dance. If you are suspecting intussusception, first stabilize the child. You will do X-ray first. It may show intestinal obstruction. Then you will do ultrasound, or you can do barium enema. Usually ultrasound is sufficient for diagnosis, right? Ultrasound shows this appearance, target sign or donut appearance. Bowel has gone inside bowel. This is barium enema. Now again, see how it is going. It is going from down to up. This is barium enema. It stops over here. This is called claw sign at the site of the intussusception. Upper one is called target sign. So all these appearances will give you the diagnosis. Diagnosis is very simple. Treatment is what is more important, what they love to ask in the exam. So if the child is stable, in a stable child, what treatment will you prefer? You will prefer to do non-surgical treatment. You will give high pressure enema, which is called hydroreduction. So first you do barium enema, see it is an intussusception, then give with some force. When you give it with force, it may push out the intussusception. It may come to place. It may get reduced. Child will start passing flatus and stools. Job is done. But if he's unstable, or if there is ischemia of the bowel, or if the hydroreduction failed, in that case, you will do surgery. Usually in surgery, you will do resection and anastomosis. Okay, usually you will do resection and anastomosis because the intussusception was not getting reduced otherwise. Right? So that will be the management. One question will come from intussusception or from paralytic ileus, or the third topic that I will teach you, that is sigmoid volvulus. One question will 100% come because intestinal obstruction they love to ask. And you get so many surgery questions in FMGE exam. This is one of the pet topics. Now, sigmoid volvulus, what is unique? Your sigmoid colon, if you are chronically constipated, it takes this shape. So the risk factor, elderly patient with history of chronic constipation. Now what has happened? Your sigmoid colon has become like this, elongated. And one fine day, it will twist anti-clockwise. Okay, one fine day, it will get a anti-clockwise twist. And this will form a closed loop obstruction. Closed loop means things cannot enter, things cannot come out. So entry point, exit point, both are blocked. This will cause ischemia very fast. Things cannot go in, things cannot come out. This will distend and it will become obstructed and strangulated very fast. So it is a true emergency. So now when the obstruction will happen, suddenly the person will get sudden distension. And now he will say, doctor, I can't even pass gas. What is that called? If you can't pass gas also, what do you call it? Obstipation. And if you will palpate the abdomen, it will be hugely distended. You can feel the sigmoid colon. First step here will be X-ray again. See now acute abdomen protocol. First you will do X-ray. X-ray will show coffee bean sign or bent inner tire sign. Okay, coffee bean or bent inner tire. This is the dilated sigmoid, twisted sigmoid with the partition. If you want to confirm the diagnosis, you will do CECT abdomen. Is it compulsory to do CT or is coffee bean enough? Is it compulsory to do CT or is coffee bean sign enough on X-ray? Coffee bean is not enough. If the patient is stable, you must do CT scan because you want to look for ischemia. The bowel will not show enhancement, means it is ischemic. If it is ischemic, then the treatment will change. Obviously, if he is stable, if it has already perforated, he'll have peritonitis, so obviously you won't do CT. But if he is not perforated, if he is okay, then you must do CT for ischemia because the treatment will depend on if stable, no ischemia. Then what will you do? You will do colonoscopic decompression. Means try to put an endoscope from below, suck the contents out and untwist it endoscopically. That is called colonoscopic decompression. You may also put a flatus tube. Okay, you may also put a flatus tube. Obviously, if there is evidence of ischemia, emergency presentation, then you will do emergency sigmoidectomy. Okay, then you will do emergency sigmoidectomy. You may do Hartmann in the reconstruction. Hartmann means you will do a colostomy. You won't do an anastomosis, you will do a colostomy. That is called Hartmann. Here in this scenario, after you put the flatus tube, it's not that sigmoid volvulus will never happen. Here you will also do sigmoidectomy, but later. Here you will do elective sigmoidectomy. Means after some days, when the person is in a better physical state, you do elective sigmoidectomy. Okay, that's a difference. So treatment for sigmoid volvulus will always be sigmoidectomy. No, if you have worked, if it has gotten resolved with enema, you don't need to do resection. Then it won't happen again. You just ensure that the child grows without GI infections. Then intussusception will not happen again. It's not necessary. This is a permanent problem because here your sigmoid colon has become this shape. So it can always undergo volvulus. That's why sigmoidectomy is the treatment here. Right? Now come to fistula and fistula is nothing but a complication of perianal abscess. Okay, it is a complication of perianal abscess. Where first you had an abscess, it burst open, then it formed an opening, which is called external opening. This one over here. Inside there is an internal opening. So the entire road connecting the two openings is called the fistula. What you can see from outside is this, the external opening. Now Parks gave you a classification of fistula and depending on the course of the tract. So if you look at the tract, this is the internal sphincter, this is the external sphincter. Okay, internal sphincter, external sphincter. If the tract mainly passes between the two sphincters, it is called intersphincteric. and intersphincteric is overall the most common. Type 1. Intersphincteric. If the tract crosses the external sphincter, like this, you can see it is crossing the sphincter. That is called transsphincteric. That is the second most common. These two only are the common fistula, type 1 and type 2. Rarely, the tract will go above the levator ani and then come down. So it went up, crossed the levator ani, then came down. That is called suprasphincteric. And the fourth one, it starts in the rectum and then comes out. So this is actually a rectal fistula, that is extrasphincteric. Extrasphincteric is rectal. It's not an anal fistula. Type 3, type 4, since they are crossing the levator ani, they are called as high fistula. Type 1 and type 2 are called low fistula. Right, basics. Now, how will the person present? He will say, doctor, I had a painful swelling. It burst. Initially, there was pus coming. Now, some red liquid comes out. And when you will see the external opening. And if you want to predict how the tract will it go like this? Will it go like this? You can use one rule, which is called Goodsall rule. It will predict the course of the tract. But in practice, we don't use Goodsall rule. In practice, if I want to know the course of the tract, I will do MRI perineum. This is the gold standard or investigation of choice. It will tell you intersphincteric, transsphincteric, single, multiple, everything will be seen on MRI. Most of the times, the fistula will not go away by itself. Most of the times. So, most of the times, the fistula has to be removed. If it's a low fistula, you can do surgeries like a fistulotomy, in which you cut the fistula. Otomy means to cut. Or you can do fistulectomy, in which you excise the fistula, not just cut it, but cut and remove. That is fistulectomy. Problem with both these surgeries is when you are cutting the fistula, you may end up cutting the sphincter also. The sphincter can get cut, which is why there are newer procedures like LIFT lift, ligation of intersphincteric fistula, or WAFT, video assisted anal fistula surgery, or FILAC, fistula laser assisted closure. These surgeries are sphincter saving. Okay, the sphincter will not be cut. They are sphincter saving new procedures. Right. And if the person is having a complex fistula or an infected fistula, in these cases, we don't do surgery. We just put this thread inside the fistula. That is called Seton or Shar Sutra. Okay, that is called Seton or Shar Sutra. It will cause chemical fibrosis, inflammation and fibrosis. But obviously, it's not a surgery. The rates of cure will be lower. Recurrence will be a little more. That is why it's not the preferred treatment. Preferred treatment will always be surgical. Either you do the olden surgeries or the new surgeries. Surgery always will be the preferred treatment because the Shar Sutra may or may not work. Okay, there is no guarantee. If you want to know a little bit about Goodsall rule, I'll just tell you in a very simple way that what did the rule say? Okay, I don't think they should ask, but in case they ask, this is the anal verge. What the rule says, make a horizontal line at the anal verge and make a 3 centimeter semicircle anteriorly. Okay, this is anterior, this is posterior, and you make a 3 centimeter semicircle. If the fistula opening is within this semicircle, the fistula will be straight and it will open in the same line. Like if this is at 2 o'clock, if this is at 2 o'clock, the tract will be straight, it will open at 2 o'clock. If this is at 11 o'clock, the tract will be straight, it will open at 11 o'clock. This is the rule. Any opening outside this, anywhere else, if the opening is here, or if the opening is here, anywhere outside this, the tract will open at 6 o'clock. It will turn like this, wherever, anywhere outside this, it will open at 6 o'clock. Bus, this is the rule. So in the exam, they will say a photo like this. They will say this is the external opening and it lies, let's say, 4 centimeters from the anal verge. Just saying, so this is the anal verge. I draw a semicircle, 3 centimeters ka. Opening is outside, it is at 4 centimeters. So if it is at 4 centimeters, where will the internal opening be? 6 o'clock. Any posterior tract, where will the opening be? 6 o'clock. Bas, itna hi hai. But if it was inside this semicircle, then it would be straight at the same line. Okay. Now come to hemorrhoids. Hemorrhoids are nothing but dilated superior hemorrhoidal veins. Dilated superior hemorrhoidal veins. Where are they located? Hemorrhoids. Where are they located? Hemorrhoids located. They are above the dentate line. Okay, means they are in the upper part of the anus. Dentate line ke upar they start. And because they are above the dentate line, they will bleed, but it will be painless. So there will be painless bleeding. It is described as splash in the pan. Patient will say, when I sit to defecate, few drops of blood fall and they hit the commode. That is called splash in the pan. Investigation of choice will be proctoscopy. But remember, don't do proctoscopy if there is a painful anal condition. If there is a painful anal condition, like a fissure. Okay, like a fissure. That's why first do PR examination. Rule out a fissure, rule out anal spasm, only then do proctoscopy. ठीक है, yes, otherwise disaster का भी disaster. Patient can die on the spot, he will collapse. So you do proctoscopy, but first do PR exam, put your finger where you should, okay, and then confirm, oh, there is no sphincter problem. Then do the proctoscopy and see where the hemorrhoids are. And then you grade them. Grade 1 hemorrhoids are entirely inside the anus, they don't come out. And if they are asymptomatic, then just do observation. Grade 2, they exit the anus, but they go back by themselves. So if it is grade 2 or grade 1 plus bleeding, grade 1 or grade 2, in this you will have to do some treatment. One treatment is you can do banding, which you are seeing in the photo. This is a PYQ. You can do this band ligation or you can do sclerotherapy. So grade 1 symptomatic or grade 2, do banding or sclerotherapy. Grade 3, they exit the anus, but you can push them back manually. धक्का मार के अंदर डाल सकते हो. Grade 4, remain outside permanently. Here you'll have to do surgery. Either you can do staple surgery, what you are seeing in the photo, circular stapler. This is called stapled hemorrhoidopexy. Or you can do open surgery, that is called Milligan-Morgan hemorrhoidectomy. Okay, either of these can be done, either stapled surgery or Milligan-Morgan open hemorrhoidectomy. Okay, so these are the treatments for hemorrhoids. Important topic, but easy topic. I don't think you will make a mistake in this. Last GIT topic is inguinal hernia. Again, I told you, whenever you see hernia, you should see defect. Yeah, sclerotherapy, polydocanol, ethanolamine oleate, same chemicals. Polydocanol is preferred over here. In inguinal hernia, always see where is the defect. Defect in an indirect hernia is the deep ring. Okay, defect in an indirect hernia is the deep ring. Deep ring is a hole in fascia transversalis. In a direct hernia, defect is Hasselbalch triangle. It is a medial triangle. Okay, it is medially located, medial to inferior epigastrix. Femoral hernia, the defect is the femoral ring, which is in the thigh. Okay, here the defect is femoral ring, which is in the thigh. Overall, most common hernia is indirect. Okay, male or female. Overall, most common indirect. Femoral hernia is seen in females, but it's not the commonest hernia in females. It's actually very rare. Certain named hernias, one is Richter, this one. Just a part of the wall is in the defect. That is called Richter, part of circumference of bowel. Opposite of that is middle. In middle, two loops of bowel are in the defect in the shape of the letter M or W. It's also called as hernia W or hernia NW. Amine hernia is a inguinal hernia with appendix, A for amine, A for appendix. Later hernia, the content is Meckel's diverticle. So if you notice, these four hernias that I have named, they are named based on the content. Name is coming from the content of the hernia, not from the location of the defect. That is why they are unique. Whenever a person has a hernia, he will come with a swelling like this. So he will come with a inguinal swelling. What is unique about the swelling? What is unique about the swelling? Hallmark, swelling shows reducibility. When the person will lie down, the swelling becomes smaller. Second is when the person will cough, the swelling will bulge. That is called cough impulse. Right? If this is not there, reducibility is not seen, cough impulse is not seen. That means the hernia is getting complicated. Maybe it is getting ischemic, strangulated, obstructed. Direct versus indirect, clinically you can make out a direct hernia does not enter the scrotum. Indirect hernia often enters the scrotum. Often, at least later on, indirect will go into the scrotum because it is accompanying the spermatic cord. Direct hernia won't enter the scrotum. It will remain inguinal. Like you're seeing this one. It will not go down. Okay, it won't enter scrotum. Okay, direct hernias are typically seen in elderly. Indirect hernia seen in what age? Who gets indirect hernia? Siddharth is saying old and young. That's not very accurate. Indirect hernia can occur at any age. Any age. So a 1-year-old child can get a hernia. It will be indirect. PYQ. Last exam. 1-year-old child with an inguinal swelling. Everybody mark direct. बच्चे में सिर्फ indirect ही होगा because it is congenital. Okay, it is congenital ना patent process vaginalis. That will always be indirect. Even me, if we get a hernia, it will be indirect. Of course, senior people can also get indirect. So indirect at any age. Direct only in senior people. So in the exam, 1-year-old child, it will always be indirect because it is patent process vaginalis. Now, when you are naming the hernia, you use this European Hernia Society nomenclature. They say label the hernia as P for primary or R for recurrent. If it's a direct hernia, give it the letter M, M for medial. Indirect hernia, L for lateral. Femoral hernia, F. Okay, females be indirect only, yes. So it will be M, L or F, depending on which type of hernia it is. Size of the defect should be based on the fingers. How many fingers you can put? 1 finger, 2 fingers, 3 or more fingers. Okay, don't put more than 3. At 3 fingers, you stop. And 1 finger, I hope you guys measured this on yourself, is approximately 1.5 centimeters. Approximately. I hope you measured. Index finger, you should know the width and the length. So if it's a primary hernia, you will call it P. If it's direct, don't say D, say M. M for medial. 3 centimeter defect should allow 2 fingers approximately. 2 fingers should pass. So you will call it PM2. Okay, not PM3, PM2. Right? So this will be the nomenclature. Don't put full hand. Don't put 4th finger fist. Stop at 3 fingers. Okay, it's an inguinal canal. How much do you want to insinuate? Let's be little gentle with the patient. Now come to hernia surgeries. The surgery of choice in all adults with a hernia will be hernioplasty. Obviously, hernioplasty or mesh repair will be the preferred treatment in adults. In child, it is herniotomy. So if the hernia is congenital, in congenital inguinal, then please don't put mesh. Okay, in congenital inguinal, the treatment is otomy, herniotomy. But in adults, you are going to do mesh repair. So up to 18 years of age, herniotomy. Adults like even me, if we get a hernia, it will be mesh repair. If you do open repair, it is called Liechtenstein tension-free mesh repair. This is the name of the open repair treatment of choice in adult. Now the mesh we put, this one is a polypropylene mesh and it will be put on top of defect. In open repair, it is on top of defect. What is that called? Mesh placement defect के ऊपर. It is called onlay mesh repair. In the exam, if they give you an open repair, 99% it will be onlay. Okay, not 100%, but 99% open mesh repair will be onlay. It will look like this. This is also onlay. Okay. If you can make out where they have placed the mesh, nothing like it. Now, the problem with a mesh repair is chronic pain because the mesh will cause inflammation, pain lasting more than 3 months. Open repair nerve injury is ilioinguinal. This will cause sensory loss in medial thigh. Okay, sensory loss in medial thigh or root of penis in males. Nowadays, we prefer to do laparoscopic repair, TAPP, TAP. The main advantage of TAPP, TAP is reduced pain. Recurrence wise, the rates are the same, but reduced pain compared to open. This is the main advantage. Now, when you are doing a laparoscopic TAPP or TAP, in one incision, you can repair 4 hernias. Okay, and it can be done bilaterally at the same time. Same incision, bilateral, same incision, these 4 hernias can be repaired. Open, you can only repair inguinal. For femoral, incision is different. But laparoscopy, all 4 in one. And some landmarks you should know. Please remember them now. Now don't say, sir, please give us some mnemonic. Now you can remember triangle of doom. Triangle of doom is the medial triangle, this one. This is triangle of doom, bounded by vas deferens medially, testicular vessels laterally, iliac vessels are the content. Okay, that is why triangle of doom. So vas deferens medially, testicular vessels laterally, iliac vessels are the content. There is one nerve here, genital branch or genitofemoral. That is the only nerve which is there in this triangle. Okay, all the other nerves are in the triangle of pain. That is the lateral triangle. This one. This is triangle of pain. This is bounded by testicular vessels medially, inguinal ligament laterally. Okay, so in triangle of pain, the boundary is going to be testicular vessels medially and inguinal ligament or iliopubic tract laterally. So this is the lateral triangle. It contains 4 nerves: lateral cutaneous nerve, anterior cutaneous nerve, femoral branch of genitofemoral, and the main femoral nerve. So notice here, genital branch of genitofemoral, triangle of doom. Femoral branch of genitofemoral, triangle of pain. Right? Most common nerve in laparoscopy injured is lateral cutaneous nerve of thigh. It will cause meralgia paresthetica. That means lateral thigh, he will get paresthesias. Okay? So this is about the laparoscopic views and the laparoscopic landmarks that you should know. Last thing in hernia is where all can you place the mesh. So if the defect is here and I'm putting the mesh on top, it is called onlay. Usually onlay, usually equal to open repair. Okay, usually it means open repair. If this is a defect and I put the mesh only in the defect, just plug it. That is called inlay. Inlay means just plug the defect. But this is not done anymore. Okay, nobody does inlay because you need the mesh to be much bigger than the defect. Like you see, mesh is so much bigger in all the other places. The mesh should be more than 5 centimeters on all sides. On all sides. Means if the defect is 1 centimeter, you need 5 centimeter above, 5 centimeter below, medial lateral. Means 11 centimeter minimum. Mesh has to be at least 5 centimeters extra on all sides. Right? Which is why inlay repair does not work, because in inlay you are not putting a big mesh, you are putting it only in the defect. Third is putting the mesh below the defect in the pre-peritoneal plane. That is called sublay. Sublay or pre-peritoneal. This is the place we place the mesh when we are doing laparoscopic TAPP, TEP. So what we just studied? Inguinal hernia, TAPP, TEP here. Here the mesh is placed sublay or pre-peritoneal. ठीक है? Last is IPOM. IPOM will always be done laparoscopically. It is intraperitoneal mesh. You can see over here, it is below the defect. It will always be laparoscopic. And the mesh used in IPOM is a double layer mesh. That is called as composite mesh. Okay, you can see in the photo. This is the mesh. You are fixing it with these stackers and you can see the bowel inside. So you know what is laparoscopic repair. So laparoscopic, 99% will be IPOM unless they specify they are doing TAPP, TEP for inguinal. अगर specify किया है, then it will be pre-peritoneal. Otherwise, if you see an image and they ask you like this, then it will be IPOM. Okay? And the mesh in IPOM is not proline, it's a composite mesh. It should have double layers. Right? So that is about the types of mesh repairs. This is a PYQ asked. Very nice question. Post-surgery, patient had a swelling, initially reducible. Now it has become irreducible. So this is a complicated incisional hernia. The diagnosis is a bowel strangulation in a incisional hernia. एकदम पेट क्वेश्चन है ये एग्जाम का. If I ask you what is the next step, what will be the answer? Next step in this question. What will be the answer? It will be emergency surgery. Okay, it will be emergency surgery. Go inside, see how the intestine is. If the intestine is strangulated, resect it. If it is not strangulated, reduce it and do a mesh repair. So that will determine what the status of the intestine. But immediately you have to operate. You can't wait here. Bowel is maybe strangulated. Right. Now, we have done many topics in GIT in barely 2 hours. Now let's do hepatobiliary. Let's get a grip on these topics. From GIT, you can expect 4 to 6 questions. From what we have done, surely 2-3 questions will come. 4 to 6 is the average GIT questions. Pure surgery. Yeah? If you had anatomy, radiology, then even more. So radio anat patho will be added. But pure surgery, 4 to 6 questions. Hernia, 100% 1 question will come, maybe 2. Now come to hepatobiliary. These are the IMP topics. Hepatobiliary means 2 to 3 questions. Right? So first, hydrated cyst of liver. On the treatment of hernia, what about it? Treatment I already told you, na, mesh repair. So hydrated cyst is due to the parasite Echinococcus. Right? Echinococcus granulosus. The parasite stays in the dog intestine and the hydrated cyst happens in the sheep. So this hydrated cyst, the hydrated cyst is supposed to happen in the sheep. Man is the accidental host. Man should not get it. And when man gets it, either he will be asymptomatic or he will present with hepatomegaly. If the cyst is very big, he may get hepatomegaly. That's it. Or it can burst and he can get anaphylaxis. Now, understand thumb rule of hepatobiliary system. Any person with hepatomegaly or jaundice, the first investigation is always going to be LFT with USG abdomen. Most of the times, LFT will be normal. USG will give you some appearances like floating membrane, or on CT you can see honeycombing, like you're seeing all these septations. So the diagnosis comes from imaging. It's an imaging disease. Diagnosis imaging. Floating membrane, water lily. On ultrasound, you can do GERD classification of the activity of the cyst. If you have a doubt, you do CT, or if you are planning treatment, you do CT. FNAC or biopsy obviously is contraindicated, right? Because there can be spillage. Now, why you are doing this GERD activity? Because the treatment depends on it. Treatment depends on activity. For example, if it's an inactive cyst, means it is a calcified cyst, then you do nothing, just do surveillance, which means every hydrated cyst disease does not require treatment, not even medicine. Just do surveillance. Obviously, if it is active or it is causing symptoms, this will require treatment. Like these are active, na? Honeycombing means it is active. So honeycombing वगैरह में you will have to do some treatment. So in the treatment, there are two steps. First step, give albendazole for 3 weeks. This is the pharma part, which can be asked. And after that, the treatment of choice is PAIR. PAIR stands for puncture, aspirate, inject, reaspirate. Okay, the P is puncture, huh? It's not percutaneous. Puncture, aspirate, inject, reaspirate. This is done by radiologist. Image guided procedure. It's not a surgical procedure. Where the radiologist will do this, he will aspirate the contents. He will inject some scolicidal agents like a hypertonic saline. Okay, 10% hypertonic saline. HS I'm writing, it means hypertonic saline or povidone iodine. So those agents will be injected, wait for a little while, reaspirated. So eventually the cyst will undergo like a sclerotherapy. It's like sclerotherapy of the cyst. Yeah, not formalin. Why would you use formalin in a cyst? Okay, that is so unusual. So this will be the treatment of choice unless for some reason you can't do PAIR. If the cyst is very deep or it's very superficial. Okay, if it's very superficial, if it is not, you're not able to puncture it, or if you puncture it will burst. So in those cases, or if it is honeycombed, then you can't do PAIR. Or if there is a cystobiliary communication, you can't do PAIR. If any of this is there and PAIR is contraindicated, then you will do surgery. And in surgery, you do pericystectomy. Pericystectomy means remove the cyst with the pericyst. Pericyst is the wall of the cyst. So either you do pericystectomy or you do marsupialization. If you can't excise it, you marsupialize it. Okay? So that will be the treatment, very simple. This is the pathway you need to follow for management of hydatid cyst. And it's not a very complicated pathway. Just remember, treatment of choice is PAIR. Where it is not possible, you think about surgery. Second condition is choledochal cyst. Another case of PAIR, at least not to my knowledge. But we do sclerotherapy in many places. But not PAIR. If you have if you have lung hydatid, what will you do? What is the treatment of lung hydatid? There will you do PAIR procedure. Lung hydatid mein you don't do PAIR, there you do surgery. Okay, lung hydatid don't do puncture aspirate because he is breathing, na? How will you puncture aspirate when he is breathing? There you do surgery. One surgery name I will tell you. It is called capitonage. This is one of the surgeries. It is called capitonage. for lung hydrated. At least remember, pair is not done in lung hydrated. This much you can remember. Now, what is this choledochal cyst? It is when some part of the bile duct is dilated since birth. Congenital dilation of the bile duct. It's dilated since birth. Now, since it is dilated, what problem happens? Like you can see here, part of the bile duct is dilated. What's the big deal in this? The problem here, one is bile cannot flow. Bile will come here and get stuck. There will be stasis of bile. And if there is stasis of bile, you will get jaundice. Second, very important is it is pre-malignant condition. So VIMP, pre-malignant. What cancer happens? There is risk of which cancer? Two cancer risks are there. One is cancer of bile duct, cholangiocarcinoma. But also cancer of gallbladder, CAGB. दोनों का risk is there, CAGB and cholangiocarcinoma. Now what you need to know, this classification of Todani. Who is Todani? Todani is from where? He is Japanese Todani, because this condition was seen very commonly in Asian girls. Okay, it was young Asian girl. That will be the presentation. So Todani, Japanese. Young Asian or Indian girls, based on where the cyst is, you should know that in type 1, the shape of the cyst is fusiform. In type 2, it is a lateral outpouching, which is called diverticular CBD dilation. In type 3, the dilation is in the terminal CBD, the last part, which is called intraduodenal CBD or choledococele. These three types, type 1, type 2, type 3, they are localized. They are only in the CBD or some part of the bile duct. Which is the most common type? Most common type of choledochal cyst? Most common type is type 1. Okay, classical type, fusiform type. 4A, 4B, 5 are diffuse types. In 4A, there is dilation of bile ducts inside and outside, double, intra and extrahepatic. In 4B, multiple extrahepatic. Okay, 4B is diffuse only extrahepatic. And 5 diffuse only intrahepatic. That is called Caroli's disease. So these 4A, 4B, and 5, they are the diffuse types. Diffuse types obviously are worse. They are harder to treat. Whatever type it is, young Asian girl will present with lump and jaundice because of the stasis. If it's an elderly person, means 40, 50 years old, he can present with cancer also, cholangiocarcinoma. Any person with hepatobiliary symptoms, first you will do LFT and USG abdomen. What will LFT show? What finding you expect on LFT? Since there is jaundice, obstructive jaundice, you expect raised alphas and raised direct bilirubin. Okay, direct bilirubin will be raised. Ultrasound will show dilated bile duct. 4B and 5 are not the same. In 4B, it is multiple. In 2, it is single. 1, 2, and 3 are single, only one. There will be only one cyst. In 4 and 5, there will be multiple cysts. Okay, based on the location. Any person with a dilated bile duct, investigation of choice, MRCP. Okay, anywhere in your life, dilated bile duct, filling defect in bile duct, raised alkaline phosphatase, Mirizi syndrome, CVD stone. If you don't know the answer, go for MRCP. Okay, in abdomen it is CT, in bile duct it is MRCP. Okay, thumb rule लगा देना, आ जाएगा answer. Now, how do you treat? All of them have to be cured surgically. If it is 1A or 1, if it is type 1 or type 2, the focal types, means this one or this one, then the treatment will be excise. So you will do excision. And after excision, you'll have to do some joining. some reconstruction. That reconstruction is hepatico-jejunostomy. Okay, that reconstruction is hepatico-jejunostomy. Yes, you will remove gallbladder. Obviously, the risk of CAGB is there. Cholecystectomy is a part of the surgery. So you remove the cyst with the gallbladder and you do a reconstruction. Hepatico-jejunostomy. Use your favorite friend. For 4A also, you will do excision. But the problem is liver will also have to be removed in 4A. Similarly, in 5, liver will also have to be removed. So in 4A and 5, you will have to do hepatectomy. And since you are doing hepatectomy, you will have to do a liver transplant in 4A and 5. So this 4A and 5 are same. In 4B, you can do it excision and reconstruction. So it will be same as type 1, type 2. Excision and reconstruction. Anywhere intrahepatic, nahi. If it is very small intrahepatic, you can do partial liver resection also, if possible. If there are very few, maybe just remove this much liver and see will the person survive or no. That has to be measured. If it is too much into liver, then sorry, then you will need a new liver. So that depends on the extent of the disease. In the exam, what they ask is type 3. That is this type. This is very difficult to remove. So here the treatment is not a resection. Here the treatment is ERCP plus cyst deroofing. Okay, this is the only type where we don't do excision because it's difficult. Stenting is not necessary, no. It is cyst deroofing, means cut the cyst partially. Yeah, sphincterotomy is a part of the deroofing. Because sphincter is right there, na? So when you deroof the sphincter, automatically will get cut. So for type 3, the treatment is not resection. For all other types, the treatment will be resection. Okay, answer this. So please understand, this is the gallbladder. Don't imagine anything else. This is the gallbladder. The last part of the CBD is dilated. So this is type 3. Okay, this is type 3. Sometimes they will give you an image like this. Okay, maybe this is the one. If they want to ask image based, they will ask this one. What is this? Is this double gallbladder? Will you call this double gallbladder GB over here? And this is an extra gallbladder. No, this is type 2. Okay, this type 2, it looks like it mimics an extra gallbladder. But it's not gallbladder, it is a cyst. Means if you'll remove it and see, na, it will be a cyst, it will not be gallbladder. That is type 2. Same thing over here, this one. Okay? But on imaging, you will not know na it is gallbladder. You will think, array, he has 2 gallbladders, lucky patient. No, it is a choledochal cyst type 2. Okay. Now come to landmarks in cholecystectomy. So when you are doing chole, some basic things you should know perfectly. First is when I go inside, I see this. So I will see gallbladder here. I will push it up. This will be the liver. My focus of dissection is this area. This area is called as hepatocystic triangle. Okay, this is not Callet's triangle. Huh? Callet's triangle is the old name. The correct name is hepatocystic. It is this big triangle here. Now, what is the boundary of this big triangle? You should know. If you see in this image, the lateral boundary is the cystic duct. The medial boundary, that is a common hepatic duct. And the superior boundary is the liver. Okay, superior boundary is the liver. So this makes the triangle common hepatic duct, cystic duct and gallbladder and liver. Inside this triangle here is the cystic artery. Okay, these images have been asked twice. Last 2 years में 2 बार पूछा है ये. The anatomy of this area. So common hepatic duct, cystic duct, inferior border of liver. This is hepatocystic triangle. Cystic artery is the content. The smaller triangle is called the Callet's triangle, which means if I go inside here and I look at the smaller, this triangle, the yellow one, that is the Callet's triangle where cystic artery forms the border. The upper border is the cystic artery. A lot of people use it interchangeably, but it's not the same. What we actually see in surgery is not Callet's, it is hepatocystic. So I am seeing this is the hepatocystic triangle. I start dissecting here. But the problem is, if my dissection goes little lower down over here, there can be injury to this important duct over here. What is this duct? Little lower down. What duct is that which can get injured if my dissection is little low? Hello, yes, that is CBD. So what surgeon does know? He does not know where cystic duct, where hepatic duct, where CBD is. So he uses one trick, surgical trick. He says, forget it. I look at this structure. That is called Ruvier sulcus. He says, I will make a horizontal line at Ruvier sulcus. Like this. That is called R4U line. Dissect above R4U line. Ruvier sulcus 4B and umbilical fissure. Means dissect over here. It is safe. Don't dissect below. It is unsafe. It may cause CBD injury. If you want to prevent CBD injury, dissect above it. When you dissect, you will get this appearance. Now after dissection, now you can see here, now it's very clear. There is one thin structure going inside, this thin one. That is a cystic artery, PYQ. This image has been asked before. That is a cystic artery, the inner one, the thinner one. And the big, thick outer one, that is a cystic duct. So what I'm seeing are two tubes entering the gallbladder. Artery which is on the inner side, duct which is on the outer side. This view is called critical view of safety. Only when this view is attained, now you can clip. Now you can clip and do the cholecystectomy. Means now clip the duct, clip the artery, and now you can do the cholecystectomy. Now proceed with cholecystectomy. If for some reason, like there is a lot of inflammation in that area, and I'm not able to proceed, I'm not getting the critical view of safety, then what to do? नहीं मिल रहा है, dissected, but it's bleeding a lot. It's very inflamed. If critical view not possible, then what will you do? Then what you do, it is called as bailout techniques. Bailout means use some alternative. जाने दो. नहीं निकल रहा, नहीं हो रहा, जाने दो. One of the bailout techniques is what you guys are saying. Convert to open. This is one of the bailouts. Convert to open. Other bailout, abandon. जाने दो. नहीं करना ही नहीं है. किसी और को बोल दूंगा. मैं नहीं करूंगा. Abandon. Or do a subtotal cholecystectomy. Subtotal means don't remove full gallbladder. Remove some, leave some. It's okay. Subtotal. These are some bailout procedures, right? Now answer this question. Patient came, blood investigation shows this is normal AST/ALT. Bilirubin is 6 mg/%. 6 means normally up to 1 होना चाहिए. Alphos is elevated. What will you do next? It will be USG. After USG, you decide whether you want to do CT or MRCP. MRCP is usually going to be the step after USG, usually. So, whenever you are investigating in hepatobiliary system, first step usually is going to be LFT plus USG. If there is deranged LFT, like a raised alphos, raised direct bilirubin, basically, if you are suspecting obstructive jaundice, or if there is a dilated CBD, if you see these words, go for MRCP. Okay, MRCP is the IOC for CBD stone, for choledochal cyst, and for cholangiocarcinoma. And for Mirizi syndrome. Okay. For any of this, if you are suspecting, you will do MRCP. When to do ERCP? If MRCP shows CBD stone or bile leak is seen on earlier imaging. ऐसा कुछ मिल गया ना, then you do ERCP. Okay, are we clear? Yes, ERCP is a very good test, but it is not diagnostic. It is a therapeutic test. Okay, don't use it for diagnosis. Use it for therapy, for treatment of CBD stones or for bile leak. Okay. Now, in a bile leak, the most important bile leak is acute bile duct injury. This was asked in the last FMG exam also. Mirizi syndrome is when you have a very big stone in the cystic duct, which is compressing the common bile duct like this. So you have a very big stone in the gallbladder, and the stone is compressing the bile duct from outside like this. That is called Mirizi, extrinsic compression. It is compressing from outside. That is called Mirizi syndrome. Now, how do you get acute bile duct injury? One of the ducts was cut by mistake. So usually it will present on post-op day 1, post-op day 2. Patient will have symptoms of bile leak. So he'll have right upper quadrant pain. Okay, right upper quadrant pain plus fever. 1 or 2 days after cholecystectomy. So he may have just gone home or he may still be in the hospital. First step, LFT USG. Okay, LFT may be deranged, but USG will show bilioma. Means bile collection in the area of the gallbladder. There will be some bile collected over here. That is called bilioma. Next step, here you put a pigtail catheter. Or you may have to do surgery, surgical drain. Like if the leak is very high, patient is having peritonitis, you may do surgery and you may put the surgical drain. The peritonitis has to be treated. Once this is done, now you want to know where it is leaking from. The Strasbourg type, this is a Strasbourg, ABCD. So to identify the site of leak, you can do MRCP or ERCP. If the leak is from the cystic duct or from one of the smaller bile ducts, it is type A. Type A is the most common type, cystic leak or chota, small duct leak. If this is the case, it's easy to manage. Do ERCP and stenting. Okay, put a stent in the CVD, the leak will stop. This is the easiest to manage, and luckily this is the most common type. But the other leaks, like type B, where the right posterior duct is blocked, B for blocked, or type C, where the right posterior duct is cut. So B for blocked, C for cut. Or type D, where common hepatic duct is cut. So these leaks or these cuts, these are tough to manage. So in these conditions, you do a delayed reconstruction. Means you wait for 1 or 2 months, let it form a stricture and you repair the stricture. You do a delayed repair. Right? So these leaks are tough to manage. Chronic injury is given over here, type E. That was a stricture. That is easier to manage. But these acute injuries, especially BCD, you wait it out and later after 1 or 2 months, you do the planned reconstruction. All right. This is about acute bile duct injury. You can answer some questions now. Very famous questions. Patient had cholecystectomy. MRCP shows bile leak from cystic duct. Patient is stable. What will you do? ERCP and stenting. How to identify right posterior? You have to imagine, just a little imagination in it. If the duct is going in the liver, it is a hepatic duct. If the duct is going in the GB, it is a cystic duct. ऐसा सोचो ना. See where the duct is going potentially. This cannot be going in the gallbladder, na? It's such a big duct. So this is right posterior. Usually, right posterior and right anterior come together. Usually, they become a single right hepatic duct. ऐसा हमेशा नहीं होता, but usually this is what happens. Right anterior, right posterior usually merge together. Stable होगा तो मतलब ये नहीं, यहाँ पे लिखा हुआ है ना, it is a type A leak. That's why. अगर type A नहीं लिखा होता, if it was type B or type C, then the answer would not be ERCP. So the management depends on the side of the leak. This was a nice, tough question that was asked in the exam. Quite a tricky question. Patient was undergoing cholecystectomy. During the surgery, a lateral injury happened to the CBD. This is intra-op. This is not post-op. This was post-op. Now you are talking about intra-op. While doing the surgery, by mistake, the duct got cut. So there was an injury. There was a significant bile leak. And the surgeon had limited experience in laparoscopy. Now understand, when the bile duct gets injured, ideally you should stitch it at that time. But the problem here was surgeon is not experienced. So you cannot repair it. See, if I am doing this surgery, I can repair it. But not everyone will be experienced in laparoscopy. So then they can't repair it. Closing the abdomen is not acceptable here. Two choices are here. Either you abandon and you place a pigtail, or you convert to open. Better answer here will be option D, convert to open. Simply because they are saying his laparoscopy experience is limited. So he can convert to open. Or you call some other laparoscopic surgeon and tell him to repair it. Intra-op injuries should be repaired intra-op. If you can't repair it intra-op laparoscopically, you should convert to open. Okay? That is the best way. And understand what is this T-tube. T-tube is a tube which you put inside the CBD. Okay, it's an intra-CBD tube which you put in open surgery. Okay, that is the role of T-tube. Whenever there is a CBD injury or you're doing CBD repair, you put the T-tube inside it, and T-tube is normally placed for about 2 to 3 weeks. No, normally whenever we do surgery consent, now we take consent for both. Any laparoscopic surgery, na, we always take consent for open also. If experienced, then option A is the correct answer. Yes, if he is experienced. But if he is experienced, now this question won't come only. Then the question won't come ना. अभी कुछ भी cut हो गया, and if you are experienced, automatically you will fix it. वो question नहीं बना ना. Question बनेगा if you are inexperienced. अब क्या करें? Right? That is the logic. I believe this was the logic of the question. Huh? Strasbourg also, we should wait until CBD is repaired. See, Strasbourg is recognizing post-operatively. Post-op to go in and repair is very difficult. That's why for BCD, you do delayed repair because it's difficult. After 1 or 2 days, when you go inside, there is so much leakage, so much inflammation that you won't be able to do repair at that time. You'll have to do delayed repair. In principle, this management works for acute bile duct injury after 48 hours. In principle. If it is recognized within 48 hours, now you can do immediate repair. But exam में ऐसा नहीं होगा. In exam, they will not expect immediate repair. In exam, the presentation will always be after 48 hours. 48 hours के अंदर recognize ही नहीं होगा. हो गया तो नसीब. पर नहीं हुआ ना, then this is the pathway. In principle. Okay. See, I cannot teach you if, then, else or everything. Then easy questions you will make mistaken, which I don't want. Varna everything as a if, then, else. As you must have studied in other subjects. If A, then B, then C. If A1, then A2, then A3. ऐसा करोगे तो यार कचरा हो जाएगा एग्जाम में, कुछ भी याद नहीं आएगा. Let that not be the case. So where we can use pigtail, you can use pigtail if there is a bilioma. ठीक है, you can use pigtail if there is a bilioma where you just want to remove the bile and not worry about the repair at that time. There the repair will be delayed. Okay. Last things in hepatobiliary, acute and chronic pancreatitis, easy topics. Acute pancreatitis is very important. Most common cause of acute pancreatitis is not alcohol, it is biliary stones, gallstone into the gallbladder. Most common cause of chronic is alcohol. Okay, most common cause of chronic is alcohol. Acute pancreatitis is more or less reversible. More or less means like if there is no necrosis, it is reversible. More or less. Chronic pancreatitis obviously is irreversible. Whatever injury has happened has happened. Whatever happened, happened. Right. Now, acute pancreatitis, patient will have history of binge drinking or history of gallstones. Some history will be there. And now he comes with acute abdomen, epigastric pain, radiating to back. Okay, epigastric pain radiating to back. So this kind of a presentation, tenderness in epigastrium, is classical of pancreatitis, easy to clinically appreciate. To confirm the diagnosis, you will do serum lipase, which is better than serum amylase. You can do both also if patient has money, but normally lipase is better, more sensitive, more specific. Right. If there is a doubt or if you want the severity, then you will do CCT abdomen. So it is the imaging of choice, but it is not necessary. Usually it will be done after 72 hours. Okay, it is for severity. It's not for diagnosis. You can use it for diagnosis, but it's not really required. It is more for severity. You get a score, it is called CT severity index, CTSI. CT severity index, if it is more than 7 out of 10, it is a severe pancreatitis. Which other score out of 10, if it was 7, it was a diagnostic test. That was Alvarado. But Alvarado, remember, is for diagnosis. It's not for severity. 7 or more, Alvarado score, it is appendicitis. 7 or more CT severity, severe pancreatitis. So the application is different. These two clinical signs which are seen in hemorrhagic pancreatitis, one is called Cullen sign, other is called Gray Turner sign. One is paraumbilical, other is flank. These are all PYQs. Okay, Cullen sign and Gray Turner sign. They imply hemorrhage. How is the hemorrhage over here? Did someone punch him over there that he's having bruising at the umbilicus or at the flank? What do these signs represent? If I'm having these signs, understand bleeding is near the pancreas only. It's just that the blood is tracking anteriorly. So these are ectopic hemorrhage signs or ectopic bleed. So don't think the bleeding is in the flank. It is not. Blood in the retroperitoneum has come till there. Okay, ectopic markers. Right. Now, what are the problems that can happen in pancreatitis? The local complications given by modified Atlanta. First is going to be if there is leakage of enzymes. If there is leakage of enzymes, it will form fluid collections. So that amylase lipase, which has leaked out, it will be diluted by the peritoneal fluid, forming cysts. Those are called as acute fluid collections. And if these fluid collections persist for more than 4 weeks, they will form a lining that is called as pseudocyst. So what is pseudocyst? It's a fluid collection in the vicinity of pancreas persisting for more than 4 weeks. Okay, it is lined by inflammatory tissue. That's why it is pseudo, right? That's why it is pseudo. If there is necrosis also, so if there is fluid collection with necrosis, it is called acute necrotic collection. And if this lasts for more than 4 weeks, it is called as walled off necrosis. Right. So these terminologies you should know for local complications. Someone is asking Fox sign. Fox sign is if the hemorrhage is in the flank, it's in the inguinal ligament. That is called Fox sign, but I don't think they will ask. It's very rare. These signs at least you will see. Fox sign is in the inguinal ligament. The blood has tracked till the groin. Okay. So these are the local complications. What are the systemic complications of pancreatitis? What will kill the person? First, he will get SIRS, systemic inflammatory response syndrome. Second, if the pancreatitis gets infected, if there is infected necrosis, necrosum got infected, it is also called as pancreatic abscess. Okay, it is called pancreatic abscess. This will give rise to septicemia. Okay, this will cause sepsis and this will kill the person. Right. So the problem with acute pancreatitis, what will kill is going to be infected necrosum causing sepsis. So one way of severity was CT. Second way of getting the severity is also given by modified Atlanta. Right. It is called by modified Atlanta. Now what do they say? Pancreatitis will be mild if there are no complications. No complications, mild pancreatitis. If there are local complications like acute fluid collection, necrosis, pseudocyst, then you will call it moderate. Or if there is organ failure for less than 48 hours, that is going to be moderate. If the organ failure persists for more than 48 hours, it will be severe. What is the cause of the organ failure? How can pancreatitis cause organ failure? Means what is the connection? He'll get acute kidney injury or ARDS. It means he is having sepsis. And if he's having sepsis, it means he's having infected necrosum. Please understand. If he's getting worse, this is the problem. Okay, 99% the problem is this. Yes, air in the necrosum. Correct, absolutely right. So one marker of severity, Atlanta. One marker of severity, CT severity index. Some old scores of severity. One was Ranson and Glasgow, not used anymore. CRP more than 150, another old marker. Apache 2 score, this is non-specific. None of these are for pancreatitis alone. Okay, Ranson Glasgow used to be used in the past, not used anymore. All of these scores expect you to wait for 48 hours, except BISAP. BISAP score, it's a bedside score. It can be done anytime. It can be done multiple times. You can do it on admission, day 1, day 2, day 3. Keep doing it, no problem. The components are also given by BISAP. B for B1, I is for impaired GCS, S is for SIRS, age more than 60, pleural effusion. These 5 parameters are there. If 3 or more are deranged, high mortality. Okay. What is the connection between pancreatitis and B1? Blood urea nitrogen. B1 is actually kidney marker. How it is connected to pancreatitis? How is GCS connected to pancreatitis? How? AKI. Yeah, it means he's having organ failure. Okay. It means he's having organ failure, or encephalopathy means septicemia. So the more the derangement, more the chance that he's having sepsis, and sepsis induces organ failure. Okay. So don't think how GCS came. It is because of septicemia. And the last thing you should know, amylase lipase don't correlate with severity. Everything else is telling you severity except amylase lipase. So if your amylase is 1000 and your friend's amylase, who's also an alcoholic, is 3000, 3000 is not more severe than 1000. ऐसा नहीं. They are purely for diagnosis. Okay. तो दो लोग पार्टी की एग्जाम के बाद बहुत दारू पिया and then you got epigastric pain, elevated lipase. It does not mean 1000 is less severe than 3000. Both are pancreatitis only. These signs are in severity now. No. Severity, you will come to know from all these parameters like CT scan or Atlanta, organ failure, BISAP. Right? Last thing, answer this question, then I'll give you lunch break. Can Mallory be stare also? No. Lipase is specific for pancreas. Lipase will not be elevated in other GI conditions. That can happen to amylase. Amylase can increase in perforation, obstruction and all. That's why lipase is better. So old man with steatorrhea, weight loss, weakness, cachexia, normal amylase lipase, which means it is not acute pancreatitis because amylase lipase is normal. But CT is showing pancreatic atrophy with multiple intraductal stones, means what he is having is chronic pancreatitis. These changes are suggestive of chronic pancreatitis. There is no mass or anything. What is the next step? Now, whenever a person has chronic pancreatitis, you need to look for three things. First thing, pain management. Second thing, exocrine problems, indigestion. And third thing, endocrine problem. That means diabetes. For pain, you will first try medical management. If it does not go with medicines, then only you will do surgery. For exocrine and endocrine, there is medical management. So here, answer is going to be enzyme supplements. Steroids don't help. Whipples is not used over here. Total pancreatectomy is not a good treatment. So understand, I will think of pain management, firstly medical, and surgery is done for pain relief. It is not done for cure. If you want to cure, you will have to do pancreatic transplant, जो किसी को मिलता नहीं है. So when we say surgeries, you are only talking about surgeries for pain relief, not anything else. And there are these three surgeries you should know. First one is head coring. It is done for inflammation in the head. That is called as BEGER, beggar. Second is longitudinal PJ. That is done for stones. If you are having stricture in the pancreatic duct, like the one in the question, stricture in the duct, stones in the duct, then you will do longitudinal PJ. That is called Pustho. Okay, you join the jejunum to the bile duct, to the pancreatic duct. And if you are doing combined, A plus B, beggar plus Pustho, burger plus pasta, that will be fray. Burger, pasta, fry. Not my mnemonic. Okay, this is not my mnemonic. Students have only told me this. Fine. Last thing, someone is asking about child score. In child, it's not actually surgery. Child score is not surgery. Child score tells me severity of cirrhosis. Okay, it tells me severity of cirrhosis. You just need to understand the logic. If you want to learn the components ka scoring, that maybe you can do. But it tells me severity of cirrhosis, and there are 5 components. I look given by the mnemonic ABCD is albumin, serum albumin, bilirubin. Now C here is not creatinine. C here is coagulation. Coagulation means INR. D is distension or ascites. And E is encephalopathy. Each component is given a score from 1 to 3 depending on the finding. हर चीज को 1 to 3 points मिलते हैं. So the total score, the minimum will be 5, maximum will be 15. Main thing you need to know, high score. High score is good or bad? Higher the score, it's better or worse? Hello? Hello, my dears. High score is severe cirrhosis. normally a score of 10 or more. It is called child C cirrhosis. Okay. Child A cirrhosis is good. His score is 5 or 6. Child B, 7 to 9. Child C, 10 to 15. Child C is the worst. In child C, you have to do liver transplant. Okay. This is the score. Fine. Now go take your lunch break. How much time you want for lunch break? Yeah, distension is ascites. How much time you want for lunch break? 20 minutes में तो मेरा भी नहीं होगा यार. I only won't finish in 20 minutes. ठीक है, so it is 108 now. 145 तक come back. 145 is okay. ठीक है, 145 I will continue. Okay, doc. See you guys. So now we go to part 2 by 145. See, amylase lipase only means acute inflammation. If it is normal, it means it's not acute. But in chronic pancreatitis, he's having steatorrhea, na? That's why you have to give amylase lipase. Why is he having steatorrhea? That means the enzymes are deficient. So you give enzymes so that his digestion improves. Hello guys, please come back. Hope you had your lunch. You wanted 20 minutes. You got little more time than that. Hopefully it's done now. Okay, shall we proceed to part 2? So now we'll do trauma, urology, breast endocrine, and general surgery. Okay? All IMP topics. These are the easier, relatively easier topics, and you will get many questions from this. So be attentive and be cooperative like you have been so far. So I'm happy we are going at a decent pace. Hopefully by 5:30 we should be able to finish. Then you'll have a little break before anesthesia. Okay. So trauma, these are the IMP topics. Every time they ask ABC of trauma, triage. You must have studied in PSM also triage. And in head trauma, favorite EDH, SDH. Most favorite. In chest trauma, tension pneumothorax. Most favorite. And bladder and urethral injury in urinary trauma. So these are the most expected IMP topics that I wish to cover first. Now, when we study trauma, the first thing we see in trauma is going to be primary survey. Okay. Primary survey means when you meet someone for the first time, you do a primary survey up to down. Briefly, see how they talk, see how they appear. You ask their name, hi, how are you? That is primary survey. According to ATLS guidelines, you are going to first check airway, breathing, circulation, disability, exposure in this order. So your own primary surveys, you may be doing different things first, but here you are going to do A, B, C, D, E in this order. The reason being, A for airway kills the fastest, right? Like all of us have some checklist in our mind, na, okay, if this person is of this gender, only then I will speak to him. If he speaks in proper English or proper Hindi, only then I will speak. So first, deal breakers is always going to be A for airway. The idea is you want to solve any life-threatening injury. Life-threatening problems have to be tackled first. So airway obstruction kills the fastest. First thing you're going to check is airway, and you will stabilize the cervical spine. How do you know airway is obstructed? What are the markers of obstruction? Patient is unable to speak a sentence. First thing you will do, ask his name. If he doesn't tell his name, obviously airway is obstructed, deal broken. Second thing, if he is unconscious. Third, if he is having stridor. Any of these, airway is obstructed, do something temporary. Okay, temporary to open the airway, like open his mouth, remove any foreign body, or you can do this chin lift, what you are seeing in the first image, or you can do this jaw thrust. Something temporary first. Make time, make arrangements, and then get the secure airway. That is going to be endotracheal intubation. If for some reason you are not able to do any of this, like person have a oromaxillofacial trauma, you are not able to intubate. In that case, you are going to get front of neck access. Okay, FUNA, front of neck access. One is the temporary front of neck access. That will be the immediate next step. That is going to be needle cricothyrotomy. So if they ask immediate next step, needle cricothyrotomy. What you're seeing in the third image, this one. Right. And if you want something secure, then you will do tracheostomy. Right. So that is going to be your A for airway. Once A for airway is done, then you move to next step B for breathing. Why breathing? You want to look for tension pneumothorax, flail chest, all those other life-threatening injuries. Front of neck access. Okay, FONA. Onani, FONA. Once B for breathing is done, you check C for circulation. Means check the person's vitals. that is pulse, BP, JVP. Take two large IV lines. A large IV should ideally be gray. Gray is ideal. Gray is going to be 16 number, or green. Green is going to be 18 number. Okay, so to put IV lines, give him IV fluid bolus. Which IV fluid will you give? Give him IV fluid bolus. Which IV fluid will you give? You will give 1 liter warm crystalloids. Okay, you can give NS, but it should be warm NS. RL भी दे सकते हैं, but it should be warm. Warm means body temperature warm. Otherwise, he can get hypothermia. So this is one thing in C for circulation. Second is you can also give tranexamic acid 1 gram, preferably within 3 hours, especially if the pulse is more than 110 per minute. If given in this time, it will reduce mortality. This is given by whom? This is as per CRASH 2 trial. Okay, CRASH 2 trial said if given within 3 hours in these patients, you have a chance of saving the person's life. So this is ABC. Then you come D. D is for disability. Disability is not external injury. Disability means neurological assessment, जिसमें you check GCS and pupils, which we will discuss in the next slide. Then you come to E. E stands for exposure. Exposure means look for any external wound, which may have to be tackled at that time. Now, in the recent INICT, they had asked a question. They had said, arrange the correct sequence. Now, normally, if the person is on the road or he's come to the emergency and they say something like field trauma, even before A for airway, you can do what is called a small C. That is control of life-threatening or catastrophic hemorrhage. That is called small c ABCD. This is usually going to be done only if it is active and the person is on the field. So if they say control of exsanguinating or catastrophic hemorrhage, that will come even before airway, but this is an exceptional situation. For us, primary survey means ABCD. Okay, so अपन यही पकड़ के चलेंगे. We will follow ABCD because airway obstruction kills the fastest. But in case this word is there, then watch out for it. Now, what do you check in GCS? GCS means Glasgow Coma Scale. Now, someone was saying, I can't remember. Now, today I will make you remember. You check for 3 components: best eye opening, best verbal, best motor. Okay. The score will be 4 in eye opening, 5 in verbal, 6 in motor. Then we start the class and I ask you, how are you today? And Abdul says, I am fine, thank you. He is giving a proper response. His eyes are open. He is looking here and there. So his eye opening gets 4 points. But his eyes are closed. And I say, Abdul, listen to me. And he opens his eyes. He gets 3 points for verbal response. But if he does not open his eyes, even when I call out to him, then I will give him a pinch. I will give him a painful stimulus. Painful stimulus opens his eyes, he gets 2 points. And if he does not open his eyes despite painful stimulus, he gets 1 point. Remember, there is no E0. Zero nahi hai. Okay, so the fact that Abdul is here in class, even if he is unconscious, not listening, not responding to painful stimuli, he will still get 1 point for eye opening. Zero nahi hota. Just that he is here, 1 point is minimum for eye opening. Then I check his verbal response. Hi Abdul, how are you? I am fine, sir. Thank you. Very nice, polite. He is oriented. He gets 5 points. But if I ask him, how are you today? What is GCS? GCS? Glasgow. Coma scale. Don't know, sir. Confused. He gets 4 points. But if I ask him, how are you today? Tell me about GCS. Who are you? Who the F are you? What the hell do you think? Get out of my face. I want PDF right now. Okay, is this enough? I am asking something and you are replying something else. You are cursing me, you are being inappropriate. That will be 3 points. Okay, if he's speaking words, but they are abusive, irrelevant, he gets 3 points. Okay, so whatever you see on Telegram, people writing nasty things for a lot of teachers and app people, they are actually V3. They are V3. But he's unconscious or barely conscious, and I'm telling Abdul, how are you? Tell me what's happening. And he just just makes some sounds. That will be V2. Incomprehensible sounds. So remember, words is 3, sounds is 2. But if he says nothing, he'll get 1 point. If you are doing GCS in drug or alcohol intoxication, then yes. But we are right now doing it in head injury. But it can be done. It can be done in septic patients also. Logic is the same. Last one is motor. So here also remember there is no V0. Zero nahi hai. No V0. Last one is motor. Remember, motor response is the best predictor of outcome. If I ask you to choose one out of the 3, it will be motor. Obviously, overall GCS is important, but if you are choosing one, it will be motor response. Now, how do I check motor response? If he's in the bed and just shaking his hands like this, doing some weird dances or other actions, then it is not motor response. Motor has to be tested, which means I tell him, Abdul, raise your right hand from wherever it was before. जहां पे भी था वो छोड़, raise your right hand. If he raises his right hand, he's obeying commands, he gets 6 points. So 6 points comes from obeying commands. But he is not letting go. Then what will I do? I will pinch him. Now see carefully. If I pinch him on the right shoulder and he takes his left hand and tries to push my hand away. Move your hand, sir. Don't pinch me. Don't pinch me. Move your hand. So he is going towards the stimulus. He gets 5 points, localizing pain. Okay. Don't ask me localize means what. Localize means take the other hand or the same hand. Move, 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 move. Don't touch me. Don't touch me. Don't pinch me. That is localizing. But instead of telling me to push my hand away, he pushes his own hand back. He takes his shoulder back, goes away from the stimulus. That is M4, withdraws to pain. So in withdraw, he is withdrawing the hand away. Instead of pushing my stimulus away, he is taking his hand away. That is withdraws to pain. M3, I pinch him, full body flexes. That is called abnormal flexion or decorticate. Okay, decorticate or entire body goes in flexion, full body. Decerebrate M2 is abnormal extension, full body goes in extension. That is M2 or decerebrate. M1, no response. Here also there is no 0. Okay, there is no M0. The fact that he is here, even if he is tolerating my pinches, he gets 1 point. So total response you will get E4, V5, M6. So the max or the best response, E4, V5, M6. But the least response is not 3 by 15. Least response depends on can I check everything. If something cannot be checked, like eye opening cannot be checked because his eyes are covered in dressing, or verbal cannot be checked because he's intubated, then I write NT, not 0. I write NT. NT means non-testable. Right. And based on this, I get a score anything between 3 by 15 to 15 by 15. Lower the GCS, more severe is the head injury, especially if the GCS is below 8. That means severe. And whenever there is a severe head injury, you must first intubate because his airway will get obstructed. Airway will get blocked if he's unconscious, right? So below 8, intubate. That is a dictum. ये इसको छोड़ के, I also check the pupils. Now, what do I check in pupils? Are the pupils reacting to light? Means are they constricting or are they fixed? Right. So that is going to be about GCS and pupils. Now, when I am doing primary survey, there are some extra things I can do. They are called adjuncts. Okay, these adjuncts may be done, compulsory nahi hai. I may be done in primary survey. Like I can put some tubes, Ryle's tube, Foley's catheter. I can do some investigations, some attachments, ECG leads, pulse oximeter. I can take two X-rays. One is neck plus chest in AP view and pelvis in AP view. And I can do some blood work, routine blood work, complete blood count and all, and arterial blood gas. ABG including lactate. Yeah, pupil whichever don't react, you can subtract. If there is a fixed pupil, that will be subtracted from your GCS. That is called GCS minus P. Only if they ask you GCS minus P. Otherwise, don't subtract on your own. If they just ask GCS, then this is GCS. Don't say, sir, I subtracted the pupils, even though it was not asked. ऐसा confusion मत करना. Only if they are asking GCS minus P, then you subtract the pupils. अपने मन से subtract मत करना fixed pupils. Right? So these are some adjuncts which you may do. There is one adjunct very important that they ask in the exam. It is called FAST or focused assessment by sonography in trauma. Focused means you look for fixed things. It is an emergency. Now, when do you do it? Abdomen trauma, pelvic trauma. If you do it in pelvic trauma, it is called EFAST, where you're also looking at thorax. E means extended fast if you also want to look at thorax. And the advantage of this test is it can be done even if unstable. Unstable patient may kar sakte hain because it is done bedside. Now, what do you see in this fast? You will see first epigastrium, but actually where you are looking is not in the epigastrium. Actually, where you are looking is the pericardium. So you're looking for pericardial fluid. If there is pericardial fluid, maybe is having cardiac tamponade. Second, you look at the right flank for free fluid. Again, you're not looking for any organ. You're only looking for, is there any free fluid? If it is there, maybe it is coming from liver injury, maybe it is coming from kidney injury. I don't know where it is coming from. Maybe it is from liver or kidney. So understand, it will not tell me exact organ. It will also not tell me exact type of fluid. Is it blood? Is it bile? All that I'm not seeing. I'm only seeing presence or absence. If the fluid is less than 100 ml, it may be missed. Right? Similarly, now I look on the right side. Now I look on the left side. Left side, I am looking for again free fluid. If it is there, it could be from the spleen or from the left kidney. Okay. It could be from the left kidney, not sure. Could be from descending colon. Then fourth, I look at the pelvis. If there is free fluid in the pelvis, it could be hemoperitoneum, perforation of bowel, perforation of bladder. I don't know. So it is not telling me exact organ of injury. It may miss free air. It may miss fluid less than 100 cc. It may not be very useful if the trauma is due to penetrating injury. Penetrating trauma may be missed. And the last, it may miss bleed in the retroperitoneum also. So many things may be missed. So don't think fast is normal or negative, then everything is fine because it has a lot of drawbacks. But yes, unstable patient, I can do it. So it is useful. If I do E fast, extended fast, then I also look at the chest. That means left and right thorax. Then I am looking for presence of pleural effusion. That means hemothorax or air, that will be pneumothorax. So this also I can diagnose. So fast is a good thing. Fast is like doing what we are doing now. We are doing marathon ना. Marathon is like fast. Focus on the IMP topics. कि भाई उसमें कुछ आ गया एग्जाम में, nothing like it. है ना, काम हो जाएगा. Right now you are unstable ना. This is done in unstable patients. But 3-4 months back in Feb March when you were stable, you didn't do fast. You did everything. So the difference is this same logic you use. Can be done in unstable patient. Once you have done all this, now someone was asking, sir, GCS पे question कैसा आएगा? Now see GCS पे क्वेश्चन क्या जाएगा. See before your doubt ना, answer is already there. Doubt के पहले ही. Patient presents in the emergency. He is intubated on arrival. Means verbal response will be non-testable. He opens his eyes on verbal command. Means eye opening will be 3 points. Opens eyes on pain. Eye opening will be 2 points. Moves all 4 limbs on commands. Motor response is 6. So it will be E3 VNT M6. This one. Right, this is the answer. If to this I add he has one fixed pupil and one reactive pupil. One pupil is fixed, one reactive. Okay, one pupil is fixed, one pupil is reactive. And tell me what is this GCSP? Then what will you say? You will minus 1. You will say E3 VNT M6 minus 1. अब बोलना नहीं सर ये माइनस करके बताओ. नहीं नहीं 8 नहीं हुआ. It's not 8. Come on. Don't say 8. Write it like this. अबे ये NT है ना. NT को आप 0 मत गिनो. Don't say GCS is 8. Okay, GCS will stop here. This is the GCS. यही मैं बोल रहा था. ज्यादा सोच के ज्यादा दिमाग मत लगाना. Like why did you count this as 0? It's not 0. It is non-testable. Okay, आ गया ना. सारे पत्ते खुल गए आप लोगों के. कैलकुलेट कर दिया. टू uncalculatable quantities. It's like saying if you subtract Abdul Moyes from Amrit, what will be the outcome? Arey, how can you subtract two people? We are not numbers, na? Okay, that's the difference. कुछ भी मत subtract करो. They should be subtractable. Hmm. So after you did this, now patient is going to be stabilized. And now you do secondary survey. Secondary survey means take this history. It is called ample history. History of allergies, medications, past illness or pregnancy, last meal, and events leading to injury. This will come as an MCQ. Huh? They will ask you which of these is not a component of ample. One of these they will change some letter. Okay, this last meal ke badle they will write something else which starts from L. So yaad rakhna hai. Then you come to examination, detailed head-to-toe examination. So now you have made someone your friend. He has passed the primary survey. Now you want to know the person more from head to toe. What are their likes, dislikes, what food they eat, what are their hobbies, take them for movies and all. So that is secondary survey. And when you are doing secondary survey, obviously you'll do detailed examination. And if you want to see the back of the patient, back or not backside, if you want to see the back of the patient, you will do this. This is called log roll. Where minimum people needed are 4, ideal number of people is 5. Okay, ideally 5, minimum will be 4. 3 people will turn the person, 4th person will examine the back. That is called log roll technique. This can be done in primary survey also. Yeah. Only thing is, if you have 5 people, then otherwise primary survey में नहीं कर पाएंगे. You need more people to help out, right? You need your friends ना to also see अरे ये इंसान अच्छा है या नहीं, शादी लायक है या नहीं. तो और लोगों के opinion, friends opinion, family opinion, best friend opinion. That is log roll. Okay, it can be done in primary, but easier to do in secondary. Now come to head trauma, VIMP. LMP included in ample. Yes, pregnancy and LMP आ गया ना. Past illness and pregnancy. तो pregnancy में LMP आ गया. Now when you come to head injuries, these 3 are the most important, especially the first 2. First 2 most important, extradural and subdural. Now how will you get extradural? The mechanism will be moderate velocity. Okay, like a cricket ball, season ball hit on your head, someone punched you on the head, someone hit you with a bat or a hockey stick, a moderate trauma. There will be injury to middle meningeal artery. There may be fracture of pterion. Okay, there may be a pterion bone fracture. This little bone over here. Person will have a lucid interval, which means first he will be unconscious, then he will be okay, then he will be unconscious again. period of normalcy between two periods of unconsciousness. Imaging will show biconvex hyperdense. Hyperdense means I am writing here white. Okay, it will show a white idli like this. Okay, because of this, it is attached to sutures over here. So the dura cannot spread anymore. The blood cannot spread. It can only go medially. That is why it will have this biconvex shape and it will cause early compression and it will require immediate decompression. How do you decompress in EDH? How do you decompress? Either you do burr hole or you remove a piece of the skull, that is called craniotomy. If they ask you which is preferred, it will be craniotomy. Okay, because the clot is actively bleeding, then just doing burr holes will not be enough. Craniotomy will be preferred. Herniation can happen in any of these. But yeah, commonly in this. Because the clot is big, na? So it will push the brain down. So brain will herniate. It happens very fast. Within 1 hour, the person can die. That is why it is called golden hour of EDH. In 1 hour, he can die. So that is EDH. Subdural, if it is acute, it will require high velocity trauma. Acute is the more common one, which happens in road traffic accidents. But there is a sober brother. As you age, you become sober. So the chronic SDH is the more sober SDH. It is seen in trivial trauma. It is seen in senior people. Senior means those who have brain atrophy. Trivial trauma. Here, the injury is going to be to cortical veins. The bridging veins are the ones which tear. Okay, cortical bridging veins. So here, the two different conditions, acute and chronic. In acute, person will have raised intracranial pressure. So he will have headache, vomiting, everything. Headache. I'm writing short form, LOC. LOC means loss of consciousness. Okay. Vomiting. All the findings of raised ICP will be there. In chronic, there will be a slow progression, 1 to 2 weeks. History will be there. Where the person will have imbalance. Little bit of headache. Thode findings will be there. Not too many findings. Imbalance while walking, little bit of headache. Because it's chronic, it will happen over time. The shape for both is the same. Both of these will have this concavo-convex or moon shaped. Both will be moon or banana shaped. But if it is acute, it will be a white banana. Remember this very well. Acute will be a white banana because it is fresh. And chronic will be a black banana or a gray. Okay, it will be black or it will be gray. This is chronic. Because as the blood will age, it will become from white to gray to black. Okay, don't remember any other bananas. Treatment for both here also will be decompression. Right? So that is going to be SDH. Last is DAI. DAI is diffuse axonal injury. This is one of the worst injuries. This will happen in high velocity trauma, like Michael Schumacher got. Okay, high velocity trauma. Here there is bleeding in the corpus callosum, the white matter or the gray white matter interface. There are small hemorrhages that you are seeing. Chote. Small hemorrhages in the corpus callosum. This person will present with a very poor GCS. Means he will be GCS below 8. And this person will not get better, but unfortunately, his CT will be normal. So only in this condition, MRI is the investigation of choice. And this has no treatment. Means you can't do anything. He will become vegetative and recovery is very poor. So head injury, poor GCS, but a normal CT is a diffuse axonal injury and the prognosis is poor. These patients are unlikely to improve. Right? Answer this. Which type of intracranial hemorrhage is depicted here? Okay, so this is SDH, but better answer is acute SDH. Okay, SDH can be acute, SDH can be chronic. EDH is always acute. EDH में तो chronic का scope ही नहीं है. But SDH can be acute or chronic. Huh? Watch out for this. This is where you will be trapped. White banana, black banana. That is only in SDH. Now the three most important topics in chest trauma. Most important favorite exam topics. First is tension pneumothorax. You understand what this condition is. So there is a tear in the pleura, but it's a one-way tear. So air will enter, but air can't escape. Okay. Pathology here, there is a one-way flap. Okay, one-way flap. So because the air enters but cannot escape, there will be a large pneumothorax. This will cause a mediastinal shift. And because of the mediastinal shift, there will be compression of SVC. And the heart will not be able to fill. Reduced venous return, reduced cardiac output. This is called as obstructive shock. So the main problem here is obstructive shock. Because the mediastinum is getting shifted, your little heart here in between and the great veins of the heart are going to be compressed. Now, because there is an obstructive shock, apart from the pneumothorax, in pneumothorax findings will be these. What I'm telling here, these will be seen in any pneumothorax, that is air entry will be reduced on the affected side. Percussion will be hyperresonant. This is seen in any pneumothorax, but what will make it tension pneumothorax? Tension pneumothorax means there is shock, so there should be hypotension, raised GEP. This means it is tension pneumothorax. Okay, so if in the exam only air entry, percussion, tracheal deviation is there, na, that is simple pneumothorax. But if you see hypotension and raised GEP, it is a tension pneumothorax. Tension pneumothorax is a clinical diagnosis. First thing you will do will be needle decompression. 4 times they have asked this. First step, needle decompression in the 5th intercostal space in mid-axillary line. Okay, in mid-axillary line or triangle of safety. Okay, needle decompression in mid-axillary line or in the triangle of safety. This is going to be the first step. Only after this will you do a chest X-ray, or you can do E-fast, and then you will put the intercostal drain. ICD is the treatment of choice. Right, but it always goes in this. Tension, mediastinal shift, no, it's not specific. It may be seen, it's not specific. Specific will be this in a pneumothorax patient. So this is going to be tension pneumothorax. Second is cardiac tamponade. In cardiac tamponade, there is bleeding in the pericardium, which is pressing on the heart. It's not letting the heart relax. It's not letting the heart have diastole. So this will happen if more than 50 cc of acute bleeding happens. Okay. Even if there is an acute bleeding of 50 cc, it will cause compression. This will not let the heart have diastole, reduced diastolic filling. The heart is getting tamponaded, and this will also lead to obstructive shock. So in both these conditions, the common phenomena is obstructive shock. In both these conditions, the heart is not able to fill, either because SVC is compressed or your heart is compressed. No filling, no cardiac output. Here the air entry will be normal because the problem is in the heart, not in the lungs. Here the percussion will be normal resonance. But when you will auscultate, you may hear muffled heart sounds. Heart sounds may be muffled because of the fluid around the heart. Here also you'll get hypotension. Here also you will get raised GVP. These three things together, it is called Beckstrand. Okay, so in tension pneumothorax, hyperresonance, hypotension, raised GVP. In cardiac tamponade, muffled heart sounds, hypotension, raised GVP. These two are the same. They are markers of obstructive shock. Now in cardiac tamponade, the first step is going to be E fast. Confirm that there is blood in the pericardium. Then the first step is going to be needle pericardiocentesis. Try to aspirate the blood from the pericardial space. Needle pericardiocentesis. But if they ask you treatment of choice, will I put ICD in this condition? ICD in the pericardium. How will the heart beat then? Please don't put ICD. Treatment of choice will be surgery. Means open the thorax, open the pericardium, drain the hematoma. It will be thoracotomy. ICD is only in pleural disorders, pneumothorax pleural effusion. It's not in tamponade. Heart में मत डालना ICD, please. Right? Third condition, massive hemothorax. This will happen when there is more than 1500 ml blood in the pleural space, which you can see here. Lot of bleeding in the pleural space. And this will happen when there is injury to some major artery. Usually there is injury to intercostal artery. That is a typical artery which gets affected. Injury to intercostal artery. Now, what is the problem here? When there is so much bleeding, it will not cause obstructive shock. It will cause hypovolemic shock. Are we clear? So the problem here is hypovolemia. Too much bleeding, hypovolemic shock. And because of hypovolemic shock, here the person, air entry may be reduced on the side of the pneumothorax or on the side of the hemothorax. Percussion will show dullness. There will be a dull note because whenever I percuss on fluid, it comes to be dull. Fluid percussion, air entry will be reduced on the affected side. Here also there will be hypotension, but here GVP will not be raised, here GVP will be decreased. Okay, because less blood in the body, less blood in the veins, less blood in the veins, neck veins will be collapsed. They will be not seen. Any person with lot of bleeding, what do you do first? First step. People will say intubate. Please don't intubate. He is not having hypoxemia. No need to intubate. First give him fluids. IV fluid, blood and blood products for the bleeding. Then you can do chest X-ray. Then to remove the blood, you can put intercostal drain. But intercostal drain is not the treatment. Treatment is stop the bleeding. So put ICD and see what is the output of the ICD. If the output is less, that means bleeding has stopped. If the output is more than 1500 ml, immediately. More than 1500 cc blood came. Immediately. Or more than 200 ml blood comes per hour for 3 consecutive hours. 100 ml per hour for 3 consecutive hours. This means it's an active bleeding. This means you have to do surgery. Okay, you'll have to do surgery to stop the bleeding. Right? If it's more than 200 ml per hour, urine output, no, ICD output, not urine output. That's why I want to see output in ICD. You imagine now you put the ICD, 2 liters blood came. That means bleeding was massive. That means you have to do something to stop the bleeding. It will not stop by itself. Cool. So the keywords to differentiate are the percussion. Hyperresonance in tension, normal resonance in tamponade, dull in massive hemothorax. This is one. Second is in all the three, there will be hypotension because of shock in all the three. And management for three is all totally different. If you know this, 100% one question is going in your pocket today. One question will come from this. It will go in your pocket straight. Okay. Now come to where you put the ICD. It is put in this triangle. That is called triangle of safety. So what is this triangle? Anterior limit, pectoralis major, posterior limit, latissimus dorsi, inferior limit, the fifth intercostal space, or line passing through nipple, horizontal line passing through nipple. This is the triangle of safety. In this triangle, you will give local anesthesia and then you will put the ICD inside like this. When you put the ICD, it will be just anterior to mid-axillary line. Or even if you say mid-axillary line, it's okay. It will be just anterior to mid-axillary line and it will be inserted along the upper border of the rib. Okay? You put it like this, upper border. Don't put it along the lower border. If you put it along the lower border, the intercostal arteries can get injured. So always put it along the upper border of the rib. After the ICD is put, usually we put it for maybe 1 or 2 days, depending on what the problem was. Once the problem is solved, let's say after 1-2 days, and now it's time to remove the ICD. Now, when you're removing the ICD, person should hold his breath. You know why? Why should he hold his breath? Either you ask him to hold his breath or you ask him to exhale. If while pulling the ICD, if he inhales by mistake, so when he will inhale, during the removal, the air will go back inside. Yeah, inhalation creates negative pressure, air will get sucked in, some pneumothorax will remain. That's why always we say hold the breath or exhale, or we say perform Valsalva. One of these things has to be done. Not inhale. He cannot inhale when you are removing the ICD. Now the ICD is attached to this bag. This is called underwater seal. The underwater seal, the tube goes all the way inside till here. Okay, before I put the ICD, I have to fill this bag with water till this mark so that the tip of the tube remains underwater. So that whatever air is there inside the bag, it should not go in the tube and then back into the lungs. Okay, I don't want it to create re-entry of air in the pleura. So to prevent air from going back, I put the tip of the tube underwater. That is called underwater seal. So whatever air comes can escape. But whatever air is there in the bag, it should not go back in. Right? That is why underwater seal. Okay, answer this. This question also came, similar question in Jan 2026. Patient had absence of air entry, hyperresonance, and hypotension. Do you want to add any finding in this? Since you are creating the question, can you add any finding in the same patient? Hyperresonance, absent air entry, hypotension, you can add just for your understanding. Raise GVP. All this together is tension pneumothorax. Next step will be needle decompression. Okay. Next step will be needle decompression. Please don't plan for intubation. Problem here is the tension. For that, you have to put needle decompression. Then later put ICD. Anesthesia class, hey guys, will be after some time, after surgery class. Okay. First we will finish surgery, then we will do anesthesia. Anesthesia will be done by anesthesia ma'am only, not by me. Originally it was supposed to be at 2:30, but ma'am is busy. So she said, can you accommodate? Like I had a choice. You know, like I had a choice. I wanted a break in between. But she said, sorry, screw your break, you continue till 5:30. I was like, but how will I teach 10 to 6? It's tiring, no? She said, I don't care. It's a part and parcel. So that's why, sorry, E85, it's me only. No choice. E85 fuel. Okay. So the fourth trauma is going to be abdomen trauma. Shantanu, you can say now, मैं तो नहीं सहता. But that's because you are not married. Okay, once you get married 10 years, 11 years into marriage, मैं तो नहीं सहता नहीं, ये अल्फाज ही नहीं निकलते. ओके, ये अल्फाज ही नहीं निकलते. दिस इज नॉट समथिंग यू वुड इवन डिस्कस. जाने दे. ओके, implied होता है, implied. She didn't ask me, will you do continue full? She said, I have work, so you continue full. Before I could say, topic is over. I didn't even have time to say, वो भी नहीं हुआ. Anyway, now come to abdomen trauma. Abdomen trauma happens typically in two ways. One is blunt, other is penetrating. In blunt trauma, the most common organ injured is spleen. In penetrating trauma, the most common organ injured is liver. Once they had asked seat belt trauma. That is also like blunt only. Seat belt trauma, it is mesentery. And if mesentery is not there, then go for hollow organ. Okay, if mesentery is not there, go for hollow organ. Now, when there is blunt trauma, the commonly injured organs, most common is spleen. When will spleen get injured? If there is injury to left-sided ribs, left rib fractured. Liver will get injured if there is right lower rib fracture. Kidney will get injured if there is injury to flank. In all the three, there may be some unique findings. Like in spleen, you get two signs sometimes. One is called KEHR, care sign. Other is called balance sign. Balance has two L, balance. So in care sign, what will happen? The person gets pain on the left shoulder in the area of the spleen where there is bleeding. It irritates the diaphragm and he gets left shoulder pain. In balance sign, he'll get dullness in the left flank. So these are some markers of bleeding around the spleen. In kidney trauma, you get a very typical finding. Person says, doctor, I am getting hematuria. I will always say abdomen trauma, hematuria equal to kidney, right? Nothing else can be injured which will give hematuria. Now, how do you diagnose and how do you manage a patient with blunt trauma? Favorite exam topic. If the patient is blunt trauma with instability, next step will be EFAST. Okay, and if EFAST shows positivity, means free fluid is there, you will do surgery. Okay. If EFAST is negative, then you have to see where else is the problem. Then abdomen is not the problem. But usually it will be positive, na? Blunt trauma to abdomen. If he is stable, then you will do secondary survey. Means you will do head to toe examination. Then you will do CT scan. CECT is the investigation of choice. Now, when you will do CT, you will get a grading of injury. You will know, is it spleen, liver, kidney, or some other organ, and you will get a grade of injury. That is called AAST grade, American Association of Surgical Trauma Grading, AAST. Normally, if it is AAST grade 1, 2, 3, this means the injury is mild to moderate. Mild to moderate injuries, you have to observe the patient. If it is grade 4 or 5, this is a severe injury. This person will either require surgery or he will require angioembolization. Okay, you will have to do angioembolization. One of these two has to be done to stop the bleeding in grade 4, grade 5. Now, if they say hollow visceral injury, you will do X-ray. You may see free air. What will you do if you see free air on X-ray? Obviously, you will do surgery and you will close the perforation. Close means primary repair or suture repair. You will close the perforation. But job is done. So blunt trauma to abdomen, management is just this much. If there is a liver injury, only if there is a liver injury and it is bleeding a lot from the liver, and you can't see where it is bleeding from. Temporarily, you can clamp this area. This is called Pringle technique. Okay, this is temporary. So when you will clamp now, this bleeding may stop. And when the bleeding stops, you will see it's bleeding from here. There is an injury over here. You can stitch it. Put some stitches there. The bleeding is controlled. And then you can release the clamp. Because this clamp cannot be kept for a long time. Huh? It can be kept for maybe 15 to 20 minutes at a time. Beat each may have to release the clamp, otherwise he will start becoming, his liver will start becoming ischemic. So this is liver injury. Yes, this is DBK. Very good. If you know the name of this clamp, mission student, correct. Mir, this is DBK. It's a vascular clamp. Very fancy. Okay. Now come to penetrating trauma. Penetrating trauma management is very easy. No need to do too many investigations. If any one of this is present, he has a penetrating trauma, he is unstable, or he has a gunshot injury, or impaled object, or evisceration means intestine is coming out, or peritonitis features. If any one is present, you will straight away take for surgery. So penetrating trauma is straightforward. Any bad finding, straight surgery. But if none of the findings are there, if all absent, means he is stable, there is no object which is stuck, there is no evisceration, there is just a wound. Then what will you do? You do wound check. Evisceration means intestine is coming out from the stab. That is the meaning of evisceration. Intestine is coming out. So you have to put it back in. Na? So if all is absent, you do a wound check. See how deep the wound is. You know how you do wound check, na? 1 finger, 2 fingers. See the depth of the wound. If the wound is deep, or there is a peritoneal breach. Okay. If the wound is deep, or there is a peritoneal breach. Okay, breach is B-R-E-A-C-H, huh? Not B-R-E-E-C-H. That B-R-E-E-C-H is obstetrics. When the baby's head is up, that breach is different. That is the breach presentation. This is B-R-E-A-C-H. Breach means puncture. So if there is a peritoneal breach or the wound is very deep, something inside may be injured, you will do CECT. A lot of people will say peritoneal breach, do surgery. No, 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 no. Don't do surgery, do CT. Surgery is only in these cases. However, if the wound is superficial, you are sure nothing inside is injured, everything is okay, then you don't need to do anything. Then just suture the wound. But you have to be sure, if in the exam you have any doubt about the depth of the wound, always go for CT. When in doubt, CT. In real life also, when someone comes with a stab, if you feel it's deep, don't say, Arey, peritoneum is not breached, nothing is injured. It's better to do CT. Because what if it's a deep injury? What if? So always best answer will be CT. Such situation will rarely ever be the answer in the exam. Watch out for this. Okay. So this is about abdomen trauma. Now you can answer this favorite exam topic. See, I've tried to put many PYQs, as many as possible. So person has this wound injury. This wound looks like a degloving wound. Looks like. No, after CT, if there is injury, then surgery. If there is no injury, then nothing. So this looks like a degloving wound. Degloving usually will come in yellow. Okay. Red will show active bleeding. Any bleeding which is active bleed will be red. Or of course, the other ABCD of trauma. Anything that comes in ABCD of trauma will be red. Open fracture bleeding, EDH, all that comes in red. Yellow will be degloving, which is not bleeding. So degloving injury. Open fracture, which is not bleeding. Okay? So these kind of things will go in yellow. Green will be simple fracture or a laceration. And black, the worst one, in which the person will not survive. He is about to die. So black is moribund. Okay, black is going to be moribund. Moribund means about to die. If there was active bleeding, answer becomes red. Any bleeding nahi, a bleeding that can kill, that is going to be red. Any bleeding कैसे होगा यार? Any bleeding is such a non-specific thing. It should be active bleeding. Active means something that can kill the person, like a open fracture with bleeding or a vascular injury with bleeding. Ambulatory is green, yes. Ambulatory simple injuries will be green. Peritonitis is yellow. Peritonitis comes here in yellow because peritonitis will not kill him immediately. It will take some hours. That much time you have. Okay. By lower limb is a very big thing. If lower limb में femoral artery, popliteal artery is bleeding, it can kill. Obviously. Femoral artery say you will die now within minutes. If someone stabbed you in the thigh, femoral artery is bleeding. It won't take much time, right? Last is going to be urinary trauma. So here there are two injuries we should know. One is bladder rupture. Other is urethral rupture. Very easy topics. Very easy topics. What you need to understand is the basic anatomy. That this is the bladder. Okay, this is the bladder. This is the intraperitoneal space. This blue structure here, what is this? What is this blue structure here? This is the levator ani or the pelvic floor. This structure behind here is the rectum. Right? Now, bladder rupture can happen in two ways. One will be injury is a little high, suprapubic. It will come over here, hit the roof of the bladder, and the bladder will tear here with the peritoneum on top. So the urine from the bladder will start going upwards like this into the intraperitoneal space. This is called as intraperitoneal rupture. Right? So when the bladder will burst, the fundus has torn, the peritoneum has torn, and the urine is going into the intraperitoneal space, that is intraperitoneal rupture. What will be the problem in this? If the urine collects over here, what problem will happen? Patient will get peritonitis. So when I say intraperitoneal rupture, very simple, site of injury is suprapubic. It will be a suprapubic injury and there will be leak in peritoneum. Urine will leak in peritoneal space. Fundus has torn. Blood-eyed hiatus will not be seen. Abdomen will be rigid because of peritonitis. Other findings will not be there. Now compare this with the second injury. Injury happened at the pubis, lower down. This is pubis. It caused an injury in the lateral wall. Lateral wall urine will collect over here above the pelvic floor in this area. That is called cave of Retzius. Here there will be no peritonitis. Okay, because urine will collect in the space over here. यहाँ पे कुछ नहीं होगा. So there is no peritonitis. So in extraperitoneal rupture, injuries to the pubis and the leak is in cave of Retzius. That is perivesical space. Here also no blood at hiatus. Here abdomen will be normal. No other findings will be there. If I want to prove the bladder has ruptured, what do I need to do? How do I prove bladder has ruptured? I will put a catheter into the bladder, inject contrast. If the contrast leaks, I know bladder has ruptured. What is this test called? What do you call this test? No, don't say RGU. No. Don't say RGU. RGC, retrograde cystogram. You want to see bladder, you will do cystogram, retrograde or ascending cystogram. Okay. Now, when you will do the retrograde cystogram, it will look like this. You can see the first image, contrast has gone in the bladder, but it is leaking little upwards. So this is likely to be intraperitoneal rupture. Second image, you have injected contrast in the bladder. It is leaking from the side like this. So this is likely to be extraperitoneal rupture. So this cystogram will tell you intra versus extra. Is it important to differentiate intra or extra? Is it a must? Why? Why? Because treatment is different. In the first year in intraperitoneal, you have to do laparotomy because there is peritonitis and you have to repair the perforation. In extraperitoneal rupture, you don't need to do anything. Just keep a Foley's catheter for 8 to 10 days. The perforation will close by itself. Okay, just keep a Foley's for 8 to 10 days. It will heal by itself. Right? Whatever leak had happened in the cave of Red is urine is sterile. It will not cause any problem. Okay? So management of intraperitoneal rupture is surgery, extraperitoneal rupture is conservative. Now come to the second. This is urethral rupture. Clearly you can see in bladder rupture, bladder was full. That's why bladder burst. In urethral rupture, bladder should be less full. You know, less full. So if the bladder is empty or it has very less urine, it will not rupture. In that case, urethra will rupture. Urethral ruptures, the injuries are extremely different. Means बहुत ही अंतर है. Because urethral rupture can also happen in two ways. One is injury here at the pubis, and this will hit this urethra, the posterior urethra, membranous urethra. So when this urethra will tear, not much, little urine will start leaking here. Not too much, little bit. So here also urine will collect in the cave of Redzius. And in this rupture, sometimes the prostate loses its ligament. The ligament of prostate also tears. So prostate may become high riding or free prostate. So in posterior urethral rupture, the injuries to the pubis, and there will be a tear of membranous or prostatic urethra. Okay, there will be a tear of membranous or prostatic urethra. Here there will be blood admeatus. Abdomen will be normal. Other finding will be high riding prostate. That is, you are right, you are writing correctly. Vermeulen sign. Okay, that is called Vermeulen sign. Now the second injury is very different, extremely different. Second injury will be if you got hit over here in the perineum, this area. Okay, injury to perineum. Now if there is an injury to perineum, the injury is going to be very different. It will go and hit this curved urethra, bulbar urethra. Here urine will start collecting in this area. It will start collecting in the perineal pouch and little bit will go into the skin of the scrotum, little bit. So this kind of an injury where you get a bulbar urethral rupture or a perineal trauma, this is called a, what you are seeing in the photo, fall astride injury. This is a PYQ, fall astride. also called as perineal injury. So injury will be in the perineum. Perineal trauma, urethral rupture, bulbar rupture, blood will be seen at hiatus. Abdomen will be normal. But here you will see perineal wound. Urine will collect in the perineal pouch. It can collect in the scrotum. So you may get a scrotal swelling. Now, how do you confirm urethral rupture? Understand, in urethral rupture, I can't catheterize because the catheter will go and it will make the rupture bigger. So what I do, I don't put the full catheter. I just put the tip of the Foley's in the urethra, just the tip, and inject a contrast which will go in the urethra into the bladder. Wherever there is leaking, it will show the leak. This is called as ascending or retrograde urethrogram. Okay, this is called as ascending or retrograde urethrogram. If I want to see urethra, urethrogram. Right. Least likely site in bulbar rupture. See, if it is leaking in the bulbar urethra, it will collect in the perineum, from perineum in the scrotum, scrotum into penis. From penis, it may go in the thigh. Where it will not go will be cave of Retzius. Okay, it will never go in the cave of Retzius. Thigh also is rare because the inguinal ligament will limit it from going in the thigh. It can go in the anterior abdominal wall, but thigh it won't go. But it's a very odd question. मतलब कुछ कनेक्शन ही नहीं है यार दोनों का. इतनी लीक होती नहीं है. Anyways, now you've done a retrograde urethrogram. Now how does it look? First image is the normal one. You have put the catheter, contrast is gone, penile urethra, bulbar urethra, this curved one, then into the prostatic or membranous urethra. That's what I'm saying. Thigh में नहीं जाएगा, abdominal wall में जा सकता है. But that's so unusual. इतना लीक होता ही नहीं है यार urethral rupture में. Unless the patient does, the patient comes after 1 month. That's so unusual. Now see the second image. Contrast is going in the urethra. This is the bulbar urethra. And in this posterior urethra, it is leaking. So the image here, it is showing posterior rupture. Membranous or prostatic, they are all kind of together. This is the posterior urethral rupture. And see the third image, contrast is going and it is leaking here only at the curved urethra. So this is going to be bulbar rupture. Understand from the image now it's very difficult to make out. अभी इसमें समझ में नहीं आ रहा, there is a curved urethra here. It's very hard, which is why don't go by the image alone. You have to see the history. History will tell you fall astride, bulbar rupture, pubic trauma, blooded meatus, posterior rupture. This history will be there. Do I need to differentiate the two for management? Is the management different for the two? Honestly, not that much. At least in the emergency, the management is the same. In emergency, you will do a suprapubic cystostomy so that the urine gets an outlet. And then you wait for a few months. You wait for a few months. After 1 to 2 months, it will form a stricture. And then you repair the stricture. So you wait for 1 to 2 months, let it form a stricture. Yes, like bile leak, exactly. And then you repair it. Easier to repair after the stricture is formed. Very hard to repair in the emergency. Cool. Got the logic? So this is going to be the management of urethral rupture. This entire page is one of the most important pages in the whole of trauma. If you get a question on any of these topics, it will come in this page. You will get the answer in this page. ठीक है, काफी टाइम से they have not asked, but 2 years back they were asking this a lot. Maybe it will come again. Maybe. Anyone said SS? You will get the PDF, na? Why you are worrying? See now, Don't worry about which questions you're getting right or wrong. That ship has sailed. At this point, only worry about what you're going to study today after my class is over and what you're going to revise tomorrow. Only think of that. That's it. Don't think of anything else. डर लगना तो जायज है. Obviously, you will be scared, but that's normal. If you are scared, that means you have studied. That means you are valuing the exam. So don't think scared means unprepared. Scared means the exam is valuable. That's what it means. You know from where I learned this? Should read notes or PYQs. Entirely your choice. Okay. चलो आगे बढ़े. Now the little easier part, that is going to be breast. I think we will finish maybe around 5:30 approximately. I think we'll be halfway in the next half an hour. Then you'll get chota break. Then another 1.5 hour approximately. So maybe about 2 hours or so more with one short break in between. Now, 35-year-old female, this is the examination finding. You need to focus on this finding, the one on the skin. This is going to be peau d'orange. It is due to involvement of dermal lymphatics in breast cancer. Very famous exam topic. So whenever you have a CA breast, what in the picture will make you think it is CA breast? It will be seen in elderly females. Okay, it will be seen in elderly females, more common than males. Obviously, breast cancer is very common in females. If there will be a lump, it will be hard and fixed. So patient will say, I have a breast lump. You will palpate it. It will be very hard. It will not be mobile. And it will have history of rapid growth. Patient may have bloody nipple discharge. This is the most common cause of nipple discharge in elderly. Elderly patients, bloody nipple discharge, most common causes cancer. Young patient, bloody nipple discharge, most common causes. It will be ductal papilloma. Very good. So these are some of the markers which will make you think maybe the lump is a cancer. But there are some which are more suggestive of cancer. One is if there is infiltration of Cooper's ligament. Cooper's ligament infiltration, you will get an appearance which is called dimpling. The skin will get pulled inside. If there is infiltration of lactiferous ducts, the nipple will get pulled inside that you are seeing here. This is called nipple retraction because lactiferous ducts go into the nipple. Third, you already saw subdermal lymphatic infiltration. You will get peau d'orange. That is orange peel skin. This one over here. The hair follicles become prominent. Between these three findings, which of the findings will affect the staging? Peau d'orange is the only finding which will affect the T stage. Okay, remember this. Cooper's ligament, infiltration, dimpling, as well as lactiferic duct. None of these will affect the T stage. So T stage is not dependent on this. Then there can be mets to lymph nodes. Most commonly, which lymph node is involved? Most common lymph node affected in breast cancer, it will be axillary. Any other lymph node which is affected? Any other? Apart from axilla, it is internal mammary. But internal mammary you can't feel. It is behind the ribs. The lymph node you can feel is axillary. Okay, it goes like this. It will go to axilla, level 1, level 2, level 3. Then from axilla, it will come to infraclavicular. then it will go to supraclavicular. So neck nodes, but neck nodes are much later. First, it will go to axilla. Hematogenously, where does it go? Most common. It goes to lumbar vertebra. How? Via Bateson's plexus. Very good. Lumbar vertebra via Bateson's plexus. So this is the pattern of spread and the metastasis. Now, VIMP for the exam is the TNM staging. If there is one thing you should study in breast, it is the TNM stage. It comes in all exam and not just in FMG. Any Indian entrance you will prepare for, you will get TNM stage. Any Indian entrance. Prostate also lumbar, correct? Prostate we'll do, na? That's also lumbar. Most common cancer with bone mets in females, breast. Most common cancer with bone mets in males, prostate. Okay. Now see, when I say the T in TNM of breast, T stands for tumor size. Okay, it's not tumor depth. Where you have an in situ. In situ means DCIS, ductal carcinoma in situ, or a Paget's disease. Paget's disease affects which part? Paget's disease affects which part of the breast? Hello? Hello, hello? No, it's not lymphatic. Eczema is the mimic of Paget's. It's Paget's disease of nipple. Okay. It's a in situ breast cancer of the nipple, not areola. It can spread to areola, but it starts in the nipple. Okay, this is pre-malignant lesions or in situ lesions. Then you have T1, T2, T3, up to 2 centimeter, 2 to 5, more than 5. Please understand, this number talks about the maximum diameter. Means if the tumor is this, let's say this is the tumor, and it is 2 by 4 centimeter, 2 into 4. Then you look at the number 4. Okay, don't look at number 2. And don't say 2 into 4 equal to 8. It is not into, it is not multiplication. So don't say 2 into 4 equal to 8. 8 is more than 5 T3. ऐसी मैथमेटिक्स मत करना. दिस इज लाइक योर GCS. VNT को तुमने 0 गिन लिया और -P कर दिया. ठीक है. दिस इज नॉट इनटू, इट इज बाय. Okay, it is by. Like you are height 6 feet, weight 90 kilos. That does not mean your body volume is 6 feet into 90 kilos. ऐसा नहीं है ना. They are two individual parameters. Okay, so you look at the bigger number, 4 centimeters. Yes, obviously bigger. Now, why will you take smaller number? So that is T1, T2, T3. T4 has a 4A. 4A means infiltration of chest wall, but are not counting pec major. Pec major is not counted, right? So when I say infiltration of chest wall, it means it should be fixed to ribs or fixed to intercostal muscles or fixed to serratus anterior muscle. Any of these words, then you will say T4A. Pec major invasion is not a T4A, right? Then you have 4B, skin invasion in the form of ulceration. Peau d'orange, that's why I told you peau d'orange affects the T stage if it is less than 33% or less than 1/3. Small skin peau d'orange is going to be counted as 4B. Or satellite nodules. Satellite nodules means multiple smaller nodules around the tumor. 4C, A plus B means skin and chest wall, and 4D is inflammatory breast cancer. This you will know if there is peau d'orange more than 1/3. This is a PYQ. 3 years back they had asked this. They had said peau d'orange occupying 50% of the skin. What is the T stage? Everyone marked 4B. It is not 4B, it is 4D. So watch out for this, especially the T4. Okay? So patient was a tumor 2 by 4 centimeters. It is fixed to pec major. What is the T stage? Fixed to pec major. What is the T stage? Hello. Oof, oof, oof. First and foremost, fixed to pec major does not affect the T stage. Okay? 2 by 4 means it is 4 centimeter. 4 means between 2 to 5. If it is between 2 to 5, it is T2. Why the hell are you guys saying T3? अरे T3 कैसे हुआ? T3 तो नहीं हो सकता ना. T2 हुआ. Okay, now same patient, tumor is fixed 2 by 4 centimeter, tumor is fixed to ribs. Then what is the T stage? 4 centimeters means T2. Fixed to ribs means chest wall, that means T4A. Take 4A. Answer becomes 4A. Okay. Same patient. Now I'll make it 2 by 6 centimeters. Fixed to ribs and ulceration. There is skin ulceration. What is the answer? So 2 by 6 centimeters, 6 is more than 5, this becomes T3. Fixed to ribs, this becomes 4A. Ulceration is 4B. So you are tempted to mark 4B. But remember, when there is 4A and 4B both, it equals to 4C. Okay, answer is going to be T4C. A plus B is 4C. Oh yes. See, such a simple concept. How many questions can be made and how much I am able to trick you today. In the exam, how much will you be tricked? Now don't be tricked. Okay. अब नहीं अटकना. मैंने आपको सारे के सारे pitfalls बता दिए क्वेश्चन में. Right. Now you come to N. N, if it is mobile axillary, it is N1. If it is fixed axillary, it is N2, fixed or matted axillary lymph node. Okay, if it is fixed or matted axillary lymph node, it is N2A. If it is infraclavicular, N3A and supraclavicular N3C. ये चार याद कर लो. ठीक है, these are the ones you need to remember. N1 mobile axillary, N2A fixed axillary, 3A infra, 3C supra. Because first it will go to infra, then it will go to supra. So this will come first. 4D and 4B. If they say patient has a peau d'orange and it is occupying 50% of the skin, then what will you mark? PDO more than 50% of the skin, it will be 4D. Okay? If I change it to PDO, 25% of the skin, means less than 33, it will be 4B. Okay? Please remember, dimpling, retraction, all that does not affect the T stage. वो आता ही नहीं है. Pec major invasion does not affect the T stage. Okay. Now come to treatment of breast cancer, stage-wise treatment. So just like GI cancers, breast cancer has the same logic, divided into early, advanced, locally advanced breast cancer, metastatic. Same breakup. If it is early, first you will do surgery, then you will give adjuvant chemo. In breast, you can also give radiotherapy. And you can also give hormonal therapy. These are also used in treatment of breast cancer. So there are other adjuncts apart from surgery, chemo. If it is advanced, same like you did in GI, first give chemo, then do surgery. Chemo first, then surgery. Here also you can give radiotherapy, hormonal therapy. They may be given in addition. So for all breast cancers, you are practically giving all treatment modalities. Metastatic is palliative. Here you just want to improve the quality of life. Okay, for palliation, improve quality of life. Right, if it is M1 tumor. So when I do surgery for breast cancer, two surgeries I should know. First one is called MRM. Early till T3, no. Early means T1, T2, some T3. सारे के सारे नहीं. T1, T2, N0, N1. And some T3 will be counted in early. Advanced means T4, N2, N3, and T3, N1. T3 plus N1. That becomes locally advanced. इतना याद कर सकते तो ठीक है. Otherwise, you judge that is it looking like an early cancer or an advanced cancer. Means if it is stuck to the skin, chest wall, lymph nodes, does not look early, then it looks advanced. If it looks advanced, you take it as locally advanced. that you can answer by common sense, means you don't have to take a very strict rule over there. Now there are two surgeries. First is MRM. MRM means modified radical mastectomy. Since you are seeing the word here, mastectomy. Mastectomy means you are going to remove entire breast, including nipple areola complex. Entire breast plus NAC. NAC means nipple areola complex. That is mastectomy. Second word you see is radical. Radical means you will also remove the lymph nodes, means axillary lymph nodes. Always will be removed. So please remember, in MRM, there is no sentinel lymph node biopsy. Okay, even if it is N0, in MRM, lymph nodes are going to be removed. बात खत्म. MRM decide कर लिया ना, lymph node निकालने हैं. Then what are you preserving? Because you are calling it modified, means there must be a radical mastectomy. Now you have modified it. So what you are preserving? Pec major. Okay, pec major. Second, ribs. These are going to be preserved. Pectoral fascia will be removed. Pec fascia is removed. So original radical, this was also removed. Pec major and ribs. Here we are preserving it, so we are calling it modified radical. आया समझ में? Most common complication is seroma formation. Most common nerve injury is intercostobrachial nerve. Swelling in the arm within a few weeks or months. This is lymphedema. Okay, within a few weeks or months is lymphedema. It's very common because you have removed the lymphatics. So arm lymphatic drainage will not happen. You will get shoulder and arm swelling. But if you get nodules like this after many years, that is going to be lymphangiosarcoma. PYQ. Okay, this they have asked 2 years back. Lymphangiosarcoma, also called as Treves syndrome. Stewart-Treves syndrome. Right. So these are some complications of MRM. Plus you are losing the full breast, which is why in younger patients, you will prefer to do breast conservation. Shoulder pain mentioned, then lymphedema. No, most common is seroma only. Shoulder pain can be lymphedema, but lymphedema is not necessarily painful. Swelling is more important. So if the woman has a small breast cancer and she's a younger patient and she says, I don't want to do mastectomy, so you can do breast conservation. Breast conservation means don't remove full tumor. Remove tumor means don't remove full breast. Remove tumor with some margin, wide local excision, 1 centimeter margin. Second thing, don't always remove the lymph nodes. You may remove axillary lymph nodes, you may not. Axillary lymph nodes, you have to decide what is to be done. And third component, compulsory component, is radiotherapy. Okay, third component, which you will always do, will be radiotherapy. Always. It is a compulsory component. So what about the lymph nodes? To remove or not to remove, how do you decide? So logic here, if the lymph nodes are enlarged, that means there is metastasis. So if lymph nodes are already enlarged, then remove. Then do axillary clearance, same time as you are doing wide excision. Okay, then do axillary clearance, same time. But if not enlarged, means it is N0, then what will you do? Sentinel lymph node biopsy. Okay, so please remember the golden rule. Sentinel lymph node biopsy is done only if N0 axilla. If it is N1 axilla, don't do this. Do axillary clearance, same time. So when you do SLNB, no lymph node metastasis, which means you will inject some chemicals like methylene blue or technetium 99 albumin. So you inject these chemicals, methylene blue or technetium 99 tagged albumin. They will be injected around the tumor. They will go into the lymphatics of the tumor and they will go to the axillary lymph nodes. Then open the axilla, identify the sentinel node, whichever has become blue or whichever has technetium 99. You remove the node, send it for frozen section. Okay, now when you send for frozen is like a fast histology report. If the histology report says, yes, there is cancer metastasis, mets present, then remove all nodes. Okay, remove all the axillary lymph nodes. But if it says no metastasis, close the axilla. Job is done. So the idea is you don't always do an axillary clearance. Lymph nodes can be kept inside if it is N0 and if SLNB is also showing no metastasis. You are judging the axilla based on the sentinel node, like how you will judge people who you meet for the first time, and then you will know, oh, this person is talking in good English. He's saying please, thank you, welcome. That means he's coming from a family which is the same. So you represent the family or you represent your friend circle. कि हाँ, if I am someone who drinks, eats, smokes everything, if my friends will be the same, no? So we represent the company we keep. The sentinel node represents the axillary lymph nodes. If sentinel node is clear, axillary lymph nodes are clear. If sentinel node has cancer, other nodes will have cancer, remove all of them. That is the premise. अगर ये समझ गए तो कुछ बात बनी, अगर ये नहीं समझे तो तकलीफ. अब आई थिंक आपको ये आंसर आ जाएगा इस पे. Now, in which patients can you not offer BCT? Even if patient says, doctor, I am young. Doctor, I don't want MRM. But you will say, no, 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 no. Sorry, you need MRM. Why? If I can't do wide excision or I can't give radiation, if any one of this can't be done, then I can't offer BCT. So, any contraindication to radiotherapy. Most important, pregnancy, prior chest radiation, connective tissue disorders like SLE. Few days back, someone messaged me on the group. Sir, if the patient is pregnant, can I do BCT, the surgery part, then wait for her delivery, then give radiation? Because the problem is radiation, na? So can I give radiotherapy after delivery? मैं भी हैरान रह गया, लोग ऐसा सोचते कैसे. So I said that if patient is in first trimester and she is breast cancer, you will do breast conservation. Then tell her to wait for 6 months. Then आराम से I will do radiation. ऐसा हो सकता है क्या? But sir, what if patient is in the 9th month? Exam में ऐसा question आएगा. They'll say patient is in the 40th week of pregnancy. Now she has a breast cancer. Now what will you do? Can they give such a question? It is so ridiculous. But these are the kind of traumatic experiences I face day in, day out. Okay. My message is please don't think of outrageous scenarios. Please think of normal scenarios. If they say pregnancy, then don't say if it is in first trimester, then contraindicated. If it is in 40th week, then I get. ऐसा मत सोचना, please. Okay. Pregnancy equal to no BCT. Okay. Pregnancy, no BCT, only MRM. Similarly, where I can't do wide excision, like a very big tumor, breast is small, or if it is a multicentric tumor, I'll not offer a BCT. There I'll do mastectomy. आई बात समझ में? My main message is please don't think of outrageous things. Please think of normal things. If you can't answer normal things, then outrageous things are far off. उसका आंसर क्या आंसर नहीं है. आंसर मत दो. आंसर बोलो प्रेगनेंसी इक्वल टू कॉन्ट्राइंडिकेशन. बस बात खत्म. नॉट थर्ड ट्राइमेस्टर प्रेगनेंसी हाँ कर सकते हैं, अगर ऐसा मत सोचना, अटक जाओगे एग्जाम में. ठीक है. We'll just do this topic, then I'll give you chota sa break. After this, we'll let us finish breast, then I will give you. So these are two easy topics. One is mastitis. It is seen in lactation. The risk factor for mastitis is cracked nipple. This is a PYQ. Okay, if there is a cracked nipple, infectious agent is staphylococcus. So when the baby will breastfeed, the staphylococci from his oral cavity will enter the skin and they will cause mastitis. Mastitis means only redness, little bit of fever. What is not seen in mastitis? Mastitis में क्या नहीं होगा? There is just redness, pain, little bit of fever. What will not be seen? There is no lump. Okay, lump नहीं होगा. Obviously no discharge. So if it's only a mastitis, the treatment is going to be antibiotics, amoxicillin or cloxacillin, right? But if you didn't treat it, if it became an abscess means now there will be lump. There may be high fever. If all this is happening, then now you don't straight away do IND. Next step will be ultrasound. Because I want to know how big is the abscess. If it's a chota sa abscess, then I don't need to do IND. Then I can just aspirate. Small abscesses, aspirate and give antibiotics. ABX means antibiotics. Big abscesses, more than 3 centimeters, you will put this catheter and remove the pus. This is called as suction catheter drain. What is the name of the suction catheter? What is the name? This is Romovac. So either you do suction catheter drain or you do IND. If both are there in the option, go for suction catheter. This is better because she can breastfeed from the same side. Yeah, suction drain has to be closed, na? Open drain में suction कैसे आएगा? Closed drain में ही तो suction आएगा. So suction catheter drain is the treatment of choice. No, suction catheter drain is single. Does not have to be done two attempts. That 2 attempt was for aspiration. Okay, 2 times you aspirate and try, but that only holds good for small abscesses. Don't do it in big abscess. Second is this very bhayanak tumor, pileid tumor. Pileid tumor is a mixed tumor. Mixed means it will come from gland, it will come from stroma. It is typically going to be seen in senior women and it will be considered malignant if it is having more than 10 abnormal mitosis. More than 10 abnormal mitosis per 10 high power field. This is a pathological report. Yeah, mastitis also, if the pain is bearable, she can breastfeed. Pain has to be bearable. She can, but if it's painful, then how will she, na? But she can definitely express the milk, right? So if it is having more than 10 abnormal mitotic figures, it will be counted as malignant. Presentation, it will be an elderly female who will present with this huge breast lump, large. But remember, this mass is usually going to be non-invasive, means it will not be fixed. Breast cancer was fixed to skin, to muscle. This is not fixed. Okay, it will show some mobility will be there, little bit. And your diagnosis will be on biopsy. Biopsy will show clusters of cells in leaf-like pattern as you are seeing here. You can see the cellular clusters are in the shape of a leaf. That's why it's called phyllides. So biopsy will be diagnostic. Treatment is going to be wide local excision with a 2 centimeter margin. Or in such a big tumor, you will do simple mastectomy. Now the question is, should I do MRM? Is MRM needed here? Alia Masoodi. Will I do MRM? Answer is no. there is no lymph node mets because it's not a carcinoma, it is a sarcoma. Firstly, it's not necessarily cancer, it may be benign, but even if it is cancer, it is Phillips tumor, it is a type of sarcoma. So sarcoma does not have lymph node mets, it only has hematogenous mets. That's why only mastectomy. You may give chemotherapy if there is metastasis, but you're not going to do axillary clearance, right? So that is going to be mastitis and abscess and Phillips tumor. Take one last chota break. Come back in 10. We'll come back at 3:40 and then we'll do the rest of the general surgery, urology and general surgery. Hello guys, please come back. Shall we move on? Are you ready? Okay, last leg, thyroid uro and some general surgery. Now understand, before I start, this is the last leg of your preparation. So just a few words. Don't, take the foot off the pedal at this point of time. Pull it till the end, take it till the last moment. And in the exam, the most important thing that you need to do, most important, is going to be the time management. Manage your time properly. Only if you will manage your time properly, you will do justice to all 300 questions. Don't think in one section there were tough questions, now you're screwed. ऐसा नहीं है. 300 questions is a big number. Your aim is the difference between that one properly done question and one half-hearted question. That 1 mark could matter. Don't let that happen. Long questions सारे नहीं होते, थोड़े ही long होते हैं. Now don't think about how those questions will come. You have to do 300 questions full. Okay, full 300 questions. No question you should be like, ये क्या है? छोड़ दो. Obviously, there is no negative marking, so leaving is not the choice, but it should not be you could not complete it. That's a crime. क्योंकि क्या easy questions रह जाते हैं. The question number 1 is as important as question number 300. Marks are the same. So if you don't get 1, 2, 3, 4, 5, but you get 294, 295, 296, it's the same. तो बीच में छोड़ मत देना. If you manage your time, if you just do justice to all 300 questions, it will make a bigger significance. Okay, keep this in your mind, remember these words. ठीक है? तो सारे के सारे क्वेश्चन अटेम्प्ट करने हैं. Last question will be given as much value as first question. It will not be, I am tired, it's not happening, I am not crossing 130 also, why should I manage, why should I even try the last 20 questions. ऐसा कुछ नहीं है. Try तो करना ही है. Right? Now come to papillary cancer. नहीं, recall recall की thinking is not for now. Now you just need to study today or tomorrow, give the exam, then think. Now there is no time for introspection. Introspection you can do after results, not now. Now you only need to take it till your exam. Now no introspection. अरे वो ये GT score, I am forgetting things, I am making silly mistakes. No, that period was 1 month ago. Now the last 2 days, don't think all this. Now just you need to go and give the exam, finished. Then introspect. अरे ये नहीं पढ़ा था, अरे ये पढ़ा था, अमृत सर ने परसों ही बताया था, उसमें से क्वेश्चन आ गए. That you do after the paper. Okay, fine. So, and again I'm saying some questions will be tough. Those are not your goal. Your goal is not the tough questions. Your goal is the easy questions. Easy questions, if you get it right, you will easily cross 180 to 200 marks easily. Tough questions, 40, 50 tough, छोड़ दो, कोई बात नहीं. Some subjects you didn't prepare well for. Okay, no problem. Attempt सब करना, पर उस पर दिमाग मत फोड़ना कि अरे ये क्या पूछ लिया, ये मेडिसिन में ये कौन से क्वेश्चन आ गए. तो आने ही है, सर्जरी में भी आएंगे. 3-4 questions will be some, एकदम bouncers. No problem. It's okay. Right? So now come to thyroid. In thyroid, the first thing you study, most important are the cancers. Overall, the most common is going to be papillary. Second most common is follicular. Medullary is not a true thyroid cancer. Medullary comes from the C cells of the thyroid gland. So it's actually not OG thyroid cancer. And anaplastic is undifferentiated. So you can't make out it is thyroid. It is undifferentiated. Now papillary, the risk factor, prior neck radiation. Okay, prior neck radiation. Or if someone has had a thyroglossal cyst. Okay, someone has had a thyroglossal cyst. This metastasizes to lymph nodes, typically the neck node level 6. What is this neck node also called? Level 6 node. Other name? Other name? Delphian node. Now, papillary, it's very easy to diagnose because when you will do FNAC, on diagnosis FNAC, you will see orphan nuclei. So it's very easy to diagnose on FNAC. Second thing is on biopsy, histology, you will see these psammoma bodies. Psammoma is not on FNAC, psammoma is after removal. Tumor marker for papillary is serum thyroglobulin. And the treatment is going to be total thyroidectomy plus level 6 clearance. Because it spreads to level 6 nodes, you will remove level 6 node also. So total thyroidectomy plus level 6 clearance. Right? That is going to be the treatment of PTC. Second is follicular. Follicular is seen in people with long-standing goiters. So if you have had goiter for many years, it can suddenly one fine day become follicular. And this will metastasize to bones. Okay, which bones will this metastasize to? Don't say lumbar vertebra because thyroid is here. Lumbar vertebra is very far. This will go to thoracic vertebra. And it will go to skull. These are the two common metastases, thoracic vertebra and skull. This is not diagnosed on FNAC. FNAC is non-diagnostic. Because for this, actually you need biopsy, but you don't have biopsy. So this is diagnosed on frozen section. Okay, frozen section will be diagnostic, means intraoperative diagnosis. This also has the same tumor marker, thyroglobulin. So when I do FNAC, I just know it's a follicular tumor. I don't know benign or malignant. So what I do in the treatment, I do hemithyroidectomy. This is a PYQ. It was asked in INI-CET recently. Patient has a follicular neoplasm. What will you do? Answer is hemithyroidectomy plus frozen. And if frozen shows cancer, then you will do total thyroidectomy. Okay, this is the management. If frozen shows benign, then stop. Hemithyroidectomy will be sufficient. Third is medullary. Medullary is seen in patients who have MEN2 syndrome. MEN2A, MEN2B. This has metastasis to both lymph node also, hematogenous also. This is diagnosed on FNAC. It will show cells containing amyloid. There will be amyloid stroma seen. Tumor marker for this, there are two. One is CEA, other is calcitonin. And this also treatment will be total thyroidectomy with level 6 clearance. Okay, because this also has lymph node metastasis. Last is anaplastic. This has a poor prognosis. This is seen in elderly patients. And it is very locally aggressive. Means it will quickly infiltrate the trachea. It will quickly infiltrate the recurrent laryngeal nerves. So prognosis here is very poor. How do you diagnose this condition? It will be a woody hard goiter. Okay, it will be woody hard goiter. And to diagnose it, you will do an open biopsy. What do you want to differentiate from? There is a condition it mimics, which has a good prognosis, for which you do biopsy. Otherwise, in thyroid, we never do biopsy, except here. You have to differentiate from Riedel's thyroiditis. This has no tumor marker. The cells are undifferentiated, and this has a poor prognosis. There is no treatment for this. Okay, so person normally will not survive with an anaplastic carcinoma. Some complications, and there are questions, easy questions with important complications. Female underwent total thyroidectomy. Post-surgery, she is unable to sing high-pitched notes. What nerve is injured? Answer is External laryngeal branch or superior laryngeal. This is the most common nerve injured. Most common nerve injury, external laryngeal branch of superior laryngeal nerve. If recurrent laryngeal nerve is injured, the person will get hoarseness. If it's bilateral, he will get stridor or airway obstruction. Okay, he'll get stridor or airway obstruction. This was another very nice question. Again, you have to use simple logic to answer this question. It was based on a logic. Patient has a slowly enlarging neck swelling. It moves with swallowing. It is hard and irregular. You want to identify the extrathyroid spread. So if you want to identify extrathyroid spread in any head and neck swelling, it will be MRI. So remember, MRI, where do we use in cancer? Head, neck, pelvis, and limbs. So where do you not use MRI? Or rather use sparingly. I won't say not, but sparingly. You don't use MRI that much in chest and abdomen. Okay, chest and abdo, MRI has less role. You can use it, but not that much, because wherever there is movement, MRI will get artifacts. Okay, radioiodine scan is for metastasis. It is not for extrathyroid spread. It is for metastasis, distant metastasis. Bone mets and all. There you will do radioiodine scan, not extrathyroid. It means local spread, na? It's like saying PET scan versus EUS or PET scan versus MRI. जो हम GI cancer में कर दे. That's the logic. Right? Now come to uro. Functional metastasis, yes, correct. I gave you now all the important. CT is for chest and abdomen. Bas itna hi. Remember this much only. And MRI is for this. You will get the answer from this. Now, first we do the renal malignancies, the urinary malignancies. First one is RCC. All of these are seen in elderly smoker males. Now, you basically need to know the TNM staging and the treatment. So for RCC, the T in RCC talks about the size. So when do I say RCC T? T1 maximum size up to 4 centimeters is T1A. More than 4 up to 7 centimeters is T1B. See, I'm revising these things so that you don't have to study it yourself, so that it will be there. You don't have to do all these stagings. T2, more than 7 centimeters. T3, embolizing into renal vein or IVC up to diaphragm or IVC above diaphragm. And T4, tumor invading adrenal gland or Gerota fascia. Okay. And for each stage, there is a treatment. Treatment is very simple. If it is a T1A tumor, you will do partial or nephron sparing nephrectomy. Okay, partial or nephron sparing nephrectomy. In T1B, you will do partial if the kidney is big and the tumor is small, or if it is big tumor and kidney is okay, means it is almost as big as the kidney, then you may have to do radical nephrectomy. So it depends on the size of the kidney also. So either you'll do partial or radical nephrectomy. Then for T2 and T3, you are going to do radical nephrectomy. But remember, if the tumor is going into IVC, that tumor has to be removed. That is called IVC embolectomy. The IVC emboli also have to be removed. And T4 will be palliative. Will I give adjuvant chemo or adjuvant radio? Or both? Adjuvant chemo, adjuvant radio, or both? Both. Why? Nothing. Treatment, only surgery. No chemo, radio. Sorry. No chemotherapy, no radiotherapy. It is resistant to both. RCC, no chemo, radiation. Wilms tumor, जो बच्चों में होती है, pediatric urinary tumor. There you give chemotherapy. Okay, that is Wilms tumor. Huh? That is not RCC. In Wilms tumor, you can give chemotherapy. Patient presents with a mass. He is having abdominal discomfort. It is kidney tumor, 8 by 5 by 3 centimeters. What will be the treatment? So 8 by 5 by 3 means more than 7, means T2. T2 will be radical. ठीक है? More than 7 is T2. Again, don't multiply. 8 5s are 40, 43s are 120. ऐसे mathematics मत करना. Look at the biggest number is 8. Now come to CA prostate. What is unique about CA prostate is that it arises from the peripheral zone of the prostate. Benign prostatomegaly arises from the transitional zone. Means it arises near the urethra. So if it's a benign prostatomegaly, these are the lobes of the prostate. Okay, if you see from the side, this is the urethra. Inside the prostate, these are the lobes. Now when I say CA prostate, CA comes from here, very far away. So CA, very far. Benign prostatomegaly comes from here, from the transitional zone. So it will cause compression very early. This is benign enlargement. CA prostate, peripheral zone. Benign enlargement, transitional zone. Okay, it arises from the transitional zone. So since it is arising from very far, it will not cause any symptoms. It will straight away present with a malignancy, typically in senior men, with a metastasis, most commonly to lumbar vertebra. So ideally, you should diagnose this tumor when the person is having no symptoms, incidentally or on screening. So ideally, it should be diagnosed on screening by doing PR exam and by doing PSA. If PSA is between 3.5 to 10, it is strongly suggestive of CA prostate. If it is more than 10, if it is between 3.5 to 10, you must do biopsy. If it's more than 10, it is CA prostate. Okay, so first you start with rectal exam and PSA levels. The IOC is going to be biopsy. It will be done with the help of ultrasound, transrectal ultrasound, TRUS, with the biopsy. How many biopsies do you take for CA prostate? How many pieces do you take of CA prostate biopsy? You have to take at least 12 pieces. Why you take 12 pieces? Because this will give me a grading which is called Gleason grading. Okay, it is to get the Gleason score. Then the rest is the same. For local spread, you will do MRI. For distant, you will do PET scan. That will give you the TNM stage, right? And based on the TNM, you determine the treatment. So now here you don't need full TNM. You need very basic. T1 CA prostate is found by chance, incidental. And T2 CA prostate is limited to prostate. This is the very least you should know. So T1 incidental, T2 limited to prostate. Treatment for both is going to be radical prostatectomy. Okay, treatment for both is going to be radical prostatectomy. And if you want, you can give chemotherapy also. But if the person says, doctor, I don't want radical prostatectomy, alternatively, you can also give radiotherapy. Or radiotherapy. Yeah? Chemotherapy, though you give only, that is adjuvant chemo. I am saying if the person does not want prostatectomy, radiotherapy can also be given. It's possible. Obviously, surgery is the treatment of choice. It's an alternative treatment, radiotherapy. But if the person is very old, T1CA prostate, low Gleason score and low PSA. So in that case, doing a surgery is not that much required. Only if all of these are fulfilled, you can do surveillance. Means you can tell the patient, we'll do nothing, we'll wait and watch. We'll do periodic checkup. And if the tumor starts growing, then we'll think about prostatectomy. But all of these have to be fulfilled. Huh? It's not or, it is plus, plus, plus. Age more than 70, T1CA prostate, Gleason 6/10 and PSA less than 10. Then you can offer surveillance. For T3, T4 tumors, usually you don't offer surgery, you offer androgen ablation. Right? Androgen ablation means give those drugs. GnRH. You can give GnRH like Goserelin or Leuprolide, or you can give anti-androgens. Any name you know? Flutamide, yes, very good. Anti-androgens like flutamide or bicalutamide. So these will not cure, but these will make his life more comfortable. The metastasis will subside. At least they will reduce in size, right? So this is going to be the management of CA prostate based on the stage. Now come to urinary bladder cancer. What type of cancer is RCC, is a bladder cancer? Is it a adenocarcinoma or a squamous cell carcinoma or something else? So it is neither. It is transitional cell carcinoma, TCC. Okay, it is transitional cell, also called as urothelioma. And this is the cancer linked with chemical carcinogens. You know, people who work in textile factories, dye factories, petroleum factories, they get exposed to certain chemicals, benzidine, toluidine, aniline dyes, and that will cause bladder cancer. It's an occupational cancer. So here, the person will present, he will be an elderly smoker male. His classical presentation will be painless, profuse hematuria. Okay, he will present with painless, profuse hematuria or gross hematuria. Thumb rule of urology. Any patient with hematuria, what is the first step? Urology thumb rule. He will present you. What will you do? Urine routine microscopy plus USG KUB. Okay, USG KUB will show mass in the bladder. If you want to confirm the mass, you will do cystoscopy with biopsy. It is also called as TURBT. That is the other name. TURBT or cystoscopy biopsy. For local spread, you will do MRI. Same scenario, elderly smoker male, if he presents with painless profuse hematuria and USG KUB shows renal mass, then what will you do? If USG KUB shows renal mass, not a bladder mass, you will think of RCC, na? Then what will you do? How will you confirm it as RCC? Then don't do cystoscopy biopsy, then do CECT. Okay, CECT is the investigation of choice. You don't need biopsy for renal masses. CT is sufficient. And then for local spread of RCC, what test will you do? I didn't tell RCC separately because I'm doing it here. How do you check local spread of RCC? You do MRI of the IVC. Okay, it is called MRI IVC venogram. Okay, so hematuria in an elderly male, RCC or bladder tumor. First do urine routine USG KUB. USG shows bladder mass, cystoscopy. USG shows renal mass, CT. That's the answer. Okay, use this logic. And this will give you the TNM stage for bladder cancer. Now for bladder, the treatment is a little different. If it's a TA, mucosa, or a T1, lamina propria, that is non-muscle invading tumor, NMI, non-muscle invading. In these patients, the treatment is going to be TURBT or cystoscopic removal, transurethral resection of bladder tumor. And here you will not give systemic chemo. Here you will give intravesical chemotherapy. This is what they will ask in the exam. Intravesical chemotherapy. Intravesical means you will give mitomycin or you will give BCG straight into the bladder. It will have contact with the cancer cells and it will kill the cancer cells directly. It is not an IV chemo, it is intravesical, means you are giving the chemotherapy straight into the bladder. That is called contact or intravesical chemo, but it will only be used for non-muscle invading. If it is muscle invading, that is T2, T3, muscularis or adventitia, here you will do your normal radical cystectomy. Now, if you have done radical cystectomy, how is the person going to urinate? How is he going to piss? So for him to urinate, you need to do this. Take a piece of the ileum, make it into a stoma, and put the ureters into the ileum. So ureters are implanted into a disconnected segment of ileum. That is called ileal conduit. Okay, that is called ileal conduit. It's a type of urinary diversion. And here you will give chemotherapy. This chemotherapy is not intravesical. Huh? This chemotherapy is systemic. Like you give for other cancers. It will be in the IV or oral form. Right? Systemic chemotherapy. Invading adjacent organs, you can do palliation. Or you can give neoadjuvant. Okay? Either palliation or neoadjuvant. Depending on metastasis is there or no. So the main message, what they ask in the exam, non-muscle invading bladder tumor, contact chemotherapy, muscle invading bladder tumor, radical cystectomy, that is the logic. Another important urinary cancer is CA testis. Most commonly, CA testis is going to be seminoma. Seminoma is seen in what age group? Who gets seminoma? Usually it is seen in youngsters like you, usually in 20s and 30s. So 20 to 40 years of age. I'm not writing males. Huh? Male नहीं लिख रहा हूँ, वो assumed है. So usually in 20 to 40 years of age, it will present with a testicular mass. Hematogenously, it may spread to lungs, but lung metastasis is more common with choriocarcinoma. Okay, it is more common with choriocarcinoma. The metastasis is called bilateral cannonball. Lymph node metastasis is common with seminoma, and this goes to which lymph nodes? Para-aortic. Okay, para-aortic are in the abdomen. It normally doesn't involve inguinal nodes because testes does not go to inguinal nodes. Inguinal nodes get drained by scrotum or penis or anus. Inguinal nodes are affected in scrotal cancer, penile cancer, anal cancer. Which is why don't do biopsy for CA testis. No biopsy or FNAC. Because if you do FNAC, the tumor can go from testis to scrotum and from scrotum to inguinal nodes. So scrotal biopsy, because you will puncture the scrotum, na? Then it will go to inguinal nodes. But that's why it is contraindicated. So when the person comes with a testicular mass, first what you do? You will do USG of the testis, plus you will do tumor markers. Okay, you will do USG testis and you will do tumor markers like alpha fetoprotein, beta HCG, LDH. None of these are specific. They are all non-specific. Since you don't have a diagnosis, the diagnosis and the surgery is going to be the same. That is going to be high inguinal orchidectomy. Okay. You will do high inguinal orchidectomy, means you will open the inguinal canal Remove the spermatic cord with the testis. Check the testis. If there is a tumor, do a high inguinal orchidectomy. And after doing this high inguinal orchidectomy, if it comes out as cancer, then you will do PET scan. And then you will give adjuvant chemotherapy. Okay, this will be the pathway of management. This is one of the few cancers where first you do surgical resection, then do PET scan. Otherwise, all the cancers we did in GIT, breast and all, you first did metastasis. Here, first you do surgery, then you do PET scan, then you give chemotherapy. That will be the order of management of CA testis. Very nice topic. Management of renal and ureteric stones. How do you confirm the diagnosis of ureteric stones or renal stones? IOC. It is plain CT KUB. Okay. Plain CT KUB or NCCT KUB. Not USG. USG is the first investigation. So you start with USG. Means वही अपना same ना, urine routine microscopy plus USG. But IOC is plain CT. Exactly this question was asked in INI-CET. Female presented with flank pain, rest of the abdomen is normal. How will you investigate? Answer was USG followed by CT. This was the exact answer. USG followed by CT if necessary. So use this logic. Our thumb rules will save you in the exam. Now, how do you treat a renal stone? If the stone is very small, up to 5 millimeters, no need to do anything. You can just observe. This stone will pass. But if the stone is more than 5 millimeter, it will have to be removed. If it's between 5 to 20 millimeters and it is not in the lower calyx, you can do this ESWL, which is extracorporeal shockwave lithotripsy. Okay, extracorporeal shockwave lithotripsy. Tripsy means to break the stone. However, you cannot do this in everybody. Contraindication: stone more than 20 millimeter, big stone, staghorn stone, stone in the lower calyx, or if the stone is very hard, like a cystine stone. And most importantly, if the patient is pregnant. Pregnancy is an absolute contraindication. And there are some problems with ESWL. If there are bacteria sitting on the stones, so when you break the stone, there can be bacterial infection because of the release of the bacteria on the stone. Second is you can get this complication. If the fragments are very big, they will start collecting in the ureter like this. This is called as Steinstrass or street of stones. Okay, Steinstrass or street of stone. So this may happen if the ESWL is done on a very big stone. Which is why for all other cases, you are going to do PCNL. PCNL stands for percutaneous nephrolithotomy. Otomy means to break and remove the stone. Okay, it's a proper surgery. It is done in the OT. It is done by urologist only. This is the ideal treatment. You are physically removing the stones. So this can be used wherever I can't do ESWL, like a big stone, staghorn stone, lower calyceal stone, hard stone, like a cystine. So for all of these, I can do PCNL. Only contraindication is pregnancy. PCNL also has some problems, obviously. So problem can happen. There can be bleeding because you have to puncture the kidney. There can be injury to adjacent organs. So there can be injury to colon or even pleura sometimes. So the idea is for big stones, PCNL, small stones, ESWL, but this ESWL is not done by urologists. It is done by radiologists or anyone who has this machine, which is why nowadays urologists are saying forget ESWL for smaller stones or for ureteric stones. So if the stone is between 5 to 20 millimeter, or if it's a ureteric stone, do this retrograde intrarenal surgery or ureteroscopy. It's an endoscopic removal. You put this endoscope, take it in the ureter, remove ureteric stone, take it in the kidney, remove smaller kidney stones. So in today's day and age, for smaller stones, we do RIRS. Ureteric stones, RIRS. Bigger stones, PCNL. Advantage is it is safe in pregnancy. That's the best advantage. You can do it in patients with horseshoe kidney. You can do it in patients who are pregnant, who are having obesity. In all these patients, RRS is a good treatment. Only thing is for bigger stones, you can't do it. So you will ask me, sir, stone more than 20 millimeters and pregnancy, what you will do? Will I do RRS? No. Can I do PCNL? No, it is contraindicated. So what to do? Exam mein what to select? Exam mein they will tell you clearly what to select. Okay, you will know from the language. They will say 10 millimeter stone, patient is pregnant, or 10 millimeter stone, patient wants an endoscopic procedure. ऐसा कुछ बोलेंगे. Then you will mark RIRS. Okay. So they will give you a clue clearly, don't worry. So if the stone is more than 20 millimeter, you have nothing to do. So only in these cases, you will wait for the patient to deliver and then do PCNL. Okay. And after delivery, you will do PCNL. Right? Answer this. Patient has bladder cancer extending up to muscle layer. If it is muscle invasive bladder cancer, you cannot do intravesical. This is for non-muscle invading. So here you will do radical cystectomy followed by systemic chemotherapy. First radical cystectomy, then systemic chemotherapy. Right? And a few chota topics of testis and scrotum, smaller topics. First is undescended testis. Testis lies anyways in the anywhere in the normal path. Most common site is high scrotal, followed by inguinal. Okay, most common high scrotal followed by inguinal. Ectopic testis, most common site is superficial inguinal pouch. Okay, superficial inguinal pouch. If I replace this pouch with superficial ring, then it becomes undescended. Okay, so the keyword here, superficial inguinal pouch. That is the site of ectopic testis. The problem with all these, there is higher risk of seminoma. Cancer risk is high. It may be associated with a congenital hernia, and it may affect fertility. Right? Especially if it's bilateral. When do you treat undescended testis? Time to operate? Best time is 6 months. What is the reason? Why not at birth? If it's diagnosed at birth, why do you want to operate at 6 months? Because it may descend spontaneously in the first 3-4 months. Okay, it may descend by itself in the first 3 to 4 months. So you wait, give it that chance. If it didn't come in 3-4 months, then you plan to operate. Right? Now, how do you locate the undescended testis? First, you do clinical evaluation. See if you can find it. If you didn't find it clinically, then you can do imaging. So you can do USG or CT. But if you still didn't find it and they ask you best way to localize, answer will be laparoscopy. Okay, or surgery. Laparoscopy is the best way to localize. Put the laparoscope in the abdomen, see where are the testicular vessels, where is the vas deferens, trace it, and then you will find it. GnRH is only considered if it's bilateral undescended testis and it is found in the abdomen, only then. Otherwise, no. So in the exam, I don't expect them to ask you a question where the answer is GnRH. It's only for bilateral abdominal testes, which is a little far-fetched, right? So best will be laparoscopy. So answer is going to be orchidopexy. Remember, if it is intra-abdominal and you have to bring it down, you will have to do it in 2 stages. What is that called? If the test is intra-abdominal, what is it called? You do Stephen Fowler procedure. It is done in 2 stages. Right. So that is about undescended testis. Varicocele is a very easy topic. You have dilated pampiniform plexus of veins of the scrotum. Typically, it is seen on the left side. Left much more common than right. Bag of worms feel. It may be associated with oligospermia. Diagnosis is on venous Doppler. And the treatment is going to be the first preferred treatment is percutaneous embolization. Means you put some chemicals in the pampiniform plexus, they will undergo sclerosis. That is called percutaneous embolization. If it didn't work, next step will be excision. That is called varicocelectomy. Excise the varicocele. Okay, varicocelectomy. In the exam, they will ask you diagnosis and complications. Third, very favorite FMG exam topic, favorite one, torsion of testis. The testis underwent a twist, and when it underwent a twist, it became ischemic. Usually this happens because of high investment of tunica vaginalis. So the tunica vaginalis is attached only at the top, testis is floating freely inside it. It looks like a clapper and bell. This is the most common problem, anatomical problem, clapper and bell. It will present usually in teenagers. He will present with acute testicular pain. Pain worsens on lifting the testis. What is this called? When the testis is lifted, the pain worsens. What is this called? Trend sign, positive or negative? Pain worse. Is pain negative? It's not positive. If pain is positive, means the pain improves on lifting the testis. That is a marker of epididymoorchitis. The test is for epididymoorchitis. We use it for torsion. Normally, clinically, you can diagnose it. Cremaster reflex will be absent. Young teenage boy with acute testicular pain. Only if you have a doubt, you will do arterial Doppler. Otherwise, it's not needed. And ideally, you have to untwist it not later than 6 hours. So explore, untwist, see if it is viable. If viable, do orchidopexy, and always do same time contralateral orchidopexy. It means always do it on the unaffected side also. Okay, plus, so affected side to you do only orchidopexy, but normal side also do orchidopexy because that will also have this clapper and bell. This can cause torsion in the next other testes also after some time. So always do contralateral. Right? Answer this. 14-year-old boy, his left testis was found in the superficial inguinal pouch. What is the diagnosis? It is ectopic. Okay. If I change the word pouch and call it ring, superficial ring, then it will be undescended. Right? Nutcracker is a mechanism to explain why left varicocele is common. Nutcracker is the testicular vein getting compressed by the SMA and the aorta. That is called nutcracker. It only explains why left side is more common. Right? Now come to general surgery. We'll try to do as many topics as possible. We'll do some plastic surgery also. So जितने हो सकते उतने करते हैं, जितने मैंने रखे हैं. First, you talk about peripheral vascular disease. Means the artery, peripheral artery, is getting narrowed. Which artery is not counted in peripheral vascular disease? Which artery is not counted? Occlusion of peripheral arteries except. Which artery is not counted? One is coronary and second is cerebral. So whatever you study in your beloved medicine, everything except that comes in peripheral. So ischemic heart disease and stroke, chhod ke, it is peripheral vascular, but the common cause is the same. Most common cause is atherosclerosis only. Atherosclerosis only will give you heart attack, it will give you stroke, and it will give you PVD. All three happen because of atherosclerosis. Now, when the artery starts narrowing, the first symptom you get is intermittent claudication. That is, the person gets pain on walking some distance. That is called claudication distance. It gets relieved by rest within a few minutes, usually within 1 or 2 minutes. The character of pain is cramping. It happens in the muscle which is being exercised, like typically in the calf muscle. He walks, calf muscle, he gets cramping. That is intermittent claudication. And once they had asked Boyd's grading, that in Boyd's grade 1, he walks, he gets pain, but as he continues to walk, the pain gets relieved. That is Boyd's grade 1. In Boyd's grade 2, he walks, he gets pain, but he is able to walk. The pain is bearable. He is able to walk with a limp. And in Boyd's grade 3, he walks, he gets pain, but he is compelled to take rest. He has to stop. So they are given this scenario. Person gets pain when he walks, he is unable to continue, he has to stop. What is the Boyd grading? That is grade 3. Some people say, what is Boyd's grade 4? What is that? Grade 4? What is Boyd's grade 4? There is no grade 4, but people say grade 4 is rest pain. But rest pain is not a part of it, actually. How are you getting pain at rest? While walking, you get pain is fine. How can you get pain without walking? It means there is ischemia of the nerves. It is called cry of dying nerve. Now the nerves are becoming ischemic. Cry of the dying nerve. Then later, the ischemia is so much, he will start getting arterial ulcers or ischemic ulcer, which are extremely painful. Okay, they are extremely painful and they have punched out edge. Painful ulcers, punched out edge. Eventually, he will get dry gangrene. What you are seeing in the photo. Okay, he will get dry gangrene like you are seeing here. So this is dry gangrene. Part has become thin and there is a line of demarcation. Okay, PVD, dry gangrene, infections, wet gangrene, acute block, wet gangrene. Okay, remember this. Whenever there is a acute occlusion, volvulus or twisting or thromboembolism, it will always cause wet gangrene. Only in chronic occlusion you get dry gangrene. Okay, answer this. 2 times this question came, and once they asked what is the vein which is affected. So patient came with health checkup. He is diagnosed with asymptomatic varicose veins. What C category is this? This is C2A. Okay. What vein is this? This is great saphenous vein. So what they had asked, all of these questions have been asked in the CEAP classification. Last time they had given an image where it was telangiectasia that was less than 1 millimeter and reticular varices which is between 1 to 2.9 millimeter. This was asked last time. Okay, this is a PYQ. What is the C grade? C stage. If it's varicose veins, it will be more than or equal to 3 millimeters. And 99% it will be grade saphenous vein. No, most common site is not aortoiliac. Most common site is femoral artery. Okay, not aortoiliac. Aortoiliac is Lerich's syndrome. C3 is going to be edema. C4A is going to be pigmentation or eczema. What you are seeing here in the side, all this black thing you are seeing, that is pigmentation. And the white scales that you are seeing, that is eczema. Then 4B is lipoderma sclerosis or atrophy blanchi. Blanchi means white patch. Then C4C is corona phlebitis. What you are seeing here, these dot-like arrangement of veins like a crown, that is called corona phlebitis. So C4C, B4B. C5 is healed ulcer, C6 is active ulcer, A is asymptomatic, S is symptomatic, R is recurrent, which we already did. So this is the ulcer typically located at the gator area. Okay, the hallmark gator area. I asked you the C stage of this. What is the answer? You will say, sir, eczema pigmentation 4A. Ulcer? What is the C stage? Gator area ulcer, C6. So eventually your answer will be C6. Okay. Active ulcer is C6. Hello. Healed ulcer is C5. ये healed थोड़ी ना है, ये तो है ना, दिख रहा है ना ulcer. How it is healed? It is active ulcer, it is C6. And when they ask you treatment of varicose veins, two treatments you should know. First is this, my favorite image, my favorite treatment. This is laser ablation, also called as EVLA, endovenous laser ablation, or EVLA, done under tumescent anesthesia. It's a type of local anesthesia for great saphenous vein incompetence. Second is this. This is called as foam sclerotherapy. It is used for smaller varicosities. And this technique of creating foam with the help of a three-way cannula, mixing it with air, this is called as Tessari technique. Okay, mixing air with the sclerosant. That is called Tessari technique. Right. So these are some of the things you should know. Very important. 100%. I am not exaggerating. 100% between these two pages, PVD and varicose veins. One question is coming in your exam. 100% from these two pages. Okay, एक question आना ही है. If you're lucky, you'll get 2-3 questions from varicose veins and PVD. But just from these two pages, you will get one question. I'm telling you. Right? सौ बात की एक बात I always say in surgery, if you give little more time, na, like let's say you have some time today after anesthesia. If you want to revise something, revise general surgery. Means these छोटी मोटी चीजें, whatever I am doing, it will give you much more score, much more marks. 100%. Because they are easy questions. General surgery is the scoring part of surgery. Because you will get ranula, cystic hygroma, and all those parotid swelling, submandibular stones, MR, same things come. TPN. Okay, same things come. So, उसमें आप गलती नहीं करना. ठीक है? तुरंत, हाँ तुरंत. I will send this तुरंत. Before anesthesia class, you can revise whatever we have done today. It will take you maybe 1 hour. Before anesthesia, you revise surgery and keep. But if you have little time, if by chance, spend it on general surgery. Okay. If you have time, do our mission notes, if possible. There's instruments and all. Now, TPN, parenteral nutrition, will only be used when there is a GIT problem. For more than 5 days, person cannot take any enteral nutrition. So how do you give this TPN? Most common vein we use is internal jugular vein. But the ideal vein is subclavian vein. Okay, ideal vein is subclavian, but we are not able to use it always. This TPN has everything. It contains dextrose and it contains lipid emulsions. So the white thing you are seeing is lipid emulsion. It also contains amino acids. Some also are fortified with vitamins. So this whole thing will be mixed and it will be put with a neckline. And from the neckline, you will get this TPN. It will give you good amount of calories. Like the calories in one bag will be between 800 to 1200 calories. Okay, so अच्छा खासा nutrition you get from TPN, but it has many problems. So I always say use it as the last resort. Yeah, I will tell her. She will give 1 hour. I think her class is at 6:30. We'll finish before that now. So you will have 1 hour. 6:30 she will take. We have one bag 24 hours because it's a lot of liquid. Remember, TPN will be the last resort. Where nothing else will work, you will give TPN. So always prefer enteral nutrition. If enteral is not possible, then give parenteral. It has many problems. Most common overall is catheter sepsis or catheter line infection. So every 5-6 days, the line has to be changed. You have to put some other one. And re-feeding syndrome happens when you give sudden nutrition. Most common problem is hypophosphatemia, hypomagnesemia, hypocalcemia, hypokalemia, all hypo. And this can be avoided or this can be prevented. How do you prevent refeeding? Always give gradual refeed. Always start gradual refeeding. Like always start with a value something like 10 calorie per kg per day. ऐसा कुछ. So if you have 50 kg person, give him 500 calories on the first day and slowly increase it. Okay, don't give this full 1000 calorie TPN on the first day when you are restarting. Always start gradually. Otherwise, he'll get refeeding syndrome. It will be a disaster. All these electrolyte problems can kill him. Right? They will cause cardiac problems and all. Few things, these are the most easy topics of surgery. That's why I hate it when students get these wrong. Like these are the crime. This is the criminal part of surgery to get mistaken. First are surgical knots. The first knot you are seeing, this one, this is called square knot, also called as reef knot. Okay, square knot or reef knot, and this knot is a secure knot. How do you recognize it? Simple way to recognize, you see this blue loop. Okay, one side loop you see, and you see how the threads are going. Both the red lines, the red threads, are they going on the same side or they are going on opposite sides? If you see the C loop, both the threads are going on the same side, na? They are going above it. See the other side. This is the C loop. The blue threads are both going from below. So if both threads cross the same side, it is a square knot. Okay, they have to cross on the same side. Now see the second image. This is the loop. This is going from below. This is going from above. One below, one above. This is called granny knot. And granny knot is insecure. Okay, insecure or granny knot. Right. When you tie your shoelaces, na, the knot you automatically generate is this one. Because we know only this knot. Our knots are never square. And the third one, this is the easy one. Here you can see there are 4 circles. If there are 4 circles, it means it has been made like this with a needle holder. So if there are 4 circles or 4 loops, it has been made with a needle holder. This is a surgeon's knot. Okay, this is a surgical knot. So first learn the knots, then learn the suture materials. When we think of suturing, what material we choose? We think first either we take polyfilament like this, which is like a choti, लड़कियों की चोटी जो स्कूल में जाते हैं, or we take a single thread, that is monofilament. Polyfilament problem is bacteria can sit in between, high risk of infection. But the knots are good. कभी चोटी खुलती नहीं है ना, कभी लड़की की चोटी एक बार बांध दी खुलेगी नहीं, it is secure. Contrarily, monofilament, less infection, but knots become loose. So it's little dangerous. Your knotting has to be proper. Now, these knots or these threads can either be absorbable. Best example is Vicryl or polygalactin. polygalactan or vicryl. This polygalactan or vicryl is known as the workhorse suture. Okay, it is known as the workhorse suture. Non-absorbable is Mersilk. Mersilk we use in today's day and age very rarely. It is used for drain fixation. Okay, so these are polyfilaments. In today's day and age, polyfilament sutures are used very sparingly. Monofilament are more preferred. Monofilament absorbable is PDS. This is what we use in biliary surgery, bowel surgery, and bladder surgery. Because it is delayed absorbable, it will not remain forever and it will not form stones. Stone formation risk will not be there. Non-absorbable, one is nylon, which you use for skin suturing. Common name is ethylon or nylon. Second is your favorite proline, right? Proline is the one which we use in vascular surgery. Okay, these are some suture materials. In INI-CD, they asked which suture material causes a lot of tissue reaction. What is the answer? Tissue reaction is maximum with which suture material? Answer is catgut. Basically, natural suture materials, catgut and Mersilk, they cause a lot of tissue reaction because antibodies will go and recognize it because it is natural suture. It is coming from other antigenic material. So that is catgut. A few knots and sutures we should know, easy ones at least. This is simple interrupted. Okay, this you must have done, or maybe you will do when you do internship after you get your FMGE result. Simple interrupted, individual sutures. Whenever you see 4 bites, like you are seeing in this photo, here there are 4 bites. This is a thread. You have entered from here, gone inside, come out from here, then gone down, re-entered from here, and come out from here. So there are 4 bites. 1, 2, 3, 4. This is a mattress. If the 4 bites form a shape like this, a square shape or a rectangle shape, this is called as horizontal mattress. Okay, this is horizontal. Also called as box stitch. Okay, whenever 4 bites, mattress. 4 bites forming the shape of a box, horizontal mattress. Now see the second image. Here, the 4 bites are all in the same line. You can see he's gone from here, come out from here, same line, gone back from here, and come out from here. So entry from here, exit from here, then reverse, entry from here and exit from here. And then he ties it. All 4 are in the same line. This is vertical mattress. Horizontal mattress has good hemostasis. Vertical mattress, instead of 2 bites, if you've taken 4 bites, the advantage is it will hold the tissue together. The tension will be less. So wherever there is a lot of stretch on the suture, I use vertical mattress. 4 bites will keep it in place, na? It will not let it break. So whenever I want more strength, I use vertical mattress wherever there is a lot of tension. ठीक है, like when you study, if there is a topic which gives you stress, you study it extra. एक बार वापस पढ़ लेंगे TNM steering. That is like vertical mattress, right? Which of the following is typically not associated? Answer is hyperkalemia. Same question, if I remove the word not, if I say which of these is typically associated, then what is the answer? Then it is hypophosphatemia. This is the most typical finding. INI-CET question. Most typical. Because it gets used up, the phosphates get used up to form the ATP. Right? Now, few extra topics, burns, plastic surgery, few things you will do. In burns, one of the things they love asking is burn surface area, especially in an adult. You use Wallace's rule of 9. Okay, so remember in this rule, head and neck fully, front and back is 9%. Okay, full head and neck is 9%. Full upper limb is 9%. Front and back. Full chest and abdomen 18%. Back is 18%. Each lower limb is 18%. And genitalia is 1%. Okay. In a child, we don't use this. In a child, we use charts. You know the name of the charts, na? Browder charts. First word will be muted. So we use these charts, Browder charts. Beep and Browder charts. So what do these charts help us? They tell us that depending on the age of the child, these three areas will vary. Okay, these three areas will vary. Other areas are fixed. So head, thigh, and leg vary with age. Other areas are fixed. No, chest anterior posterior nahi. Chest is 9, abdomen is 9. So chest plus abdomen is 18. Back is 18. Think of it like that. इसलिए chest and abdo we don't separate. We say torso, front, back. That becomes 1880. Right? But everybody will not have burns like this. Okay. Everybody will not have burns like this. If you have patchy burns, then you use the hand rule. Size of the patient's hand is approximately 1%. Patient's hand, na? Everyone's hand size is different, but approximately one hand for one patient is 1%. बच्चों का याद करना मुश्किल है. It's a little difficult. That's why I said at least know what areas change with age. That is the very minimum you should know. Second, they love asking is the resuscitation of burns. Now, when you want to resuscitate, you should know two. First is Parkland equation, where the fluid you use is Ringal lactate. And Ringal lactate will be used in the formula 4 ml burn surface area into body weight. Half over 8 hours, half over 16 hours. For example, if the person, for example, is 50 kgs and his burn percentage is 40%. So his Parkland's equation for the first 24 hours will give him RL 4 into 50 into 40. This will become 8000 ml. Now this 8000 ml you split in the first 8 hours, you give 4 liters. In the remaining 16 hours, you give the remaining 4 liters. This is how you will break it, right? So this is Parkland's equation, but it is a little aggressive. So came ATLS. In the exam, they will tell you which formula to use. Don't worry. They will specify. So in ATLS, he said, use RL only, but formula should be 2 ml, not 4 ml. Same breakup is the same. Further, don't count first degree burns. First degree burns are excluded. And keep a target urine output. Adult 0.5 ml, child 1 ml. If this target is not met, if you don't get this much urine output, you try it for 2-3 hours, urine output target is not met, then what will you do? Then you give bolus RL. This is a PYQ of FMG. Give bolus RL about 10 to 20 ml per kg. Right? That much bolus has to be, it's a top up, right? Further, if it's a child age less than 14 years, the formula is 3 ml. If it's a patient with electrical burns, the formula remains 4 ml. So these three different formula apply to adult, child, and electrical burns. Okay, so there are two exceptions. One is for child, other is for electrical burns to this 2 ml equation. Each of this comes in the exam. All these are exam questions. Now come to plastic surgery, skin grafts and flaps, I will tell you. The meaning of the word graft is it doesn't carry its own vascularity. Right? It doesn't carry its own vascularity. So it will get blood supply from where the graft is going to be put. So there are two types of skin grafts. One is partial thickness, Thiersch, full thickness or Wolf's. Partial thickness are good for large wounds. Full thickness are good for small wounds, especially wounds over face where you need cosmesis. None of the grafts can be used in any wound where there is infection or there is poor vascularity because they require the vascularity of the recipient site. So I cannot use them anywhere where the vascularity is poor. So first things first, the wound should be healing. Healing wound, I can put a skin graft. If the wound is infected, very deep wound, poor vascularity, can't use it. Okay, clearly contraindicated. Harvest site for a split thickness graft is the thigh, and it is harvested with this Humvee knife or with a dermatome. So when I harvest the graft, depending on the size of the wound, I make some perforations in it, and then I put it on the wound which has to be covered. So it has to be perforated. That is called meshing, and then it is placed. Right. But remember, it has to be put on a healing wound, not on a dirty wound. But a full thickness graft is normally put on the face. So you take it from supraclavicular fossa or post-auricular. Basically areas where the skin is neat and tidy. It should be a hairless skin. And it is going to be cut not with this Humvee knife. It will be cut with scissors or knife. Normal knife, surgical blade. So you cut it, put it on the face and stitch it. Here we don't need to mesh it. There is no meshing in a full thickness skin graft because it has to look cosmetically nice. So I cannot do too much of chhedkhani with it, right? It has to be very cosmetically appealing on the face. So where there are small wounds on the face, full thickness skin graft, large superficial wounds, split thickness skin graft, but where I need bulk of tissue, like oral cancer after resection, and I want to put a cover, I cannot put skin graft. Okay, I cannot put skin graft. There I need bulk of tissue. There I will use flaps. So the idea of a flap is they have own vascularity. Okay, they have their own vascularity. And one of these flaps they will ask in the exam. First one you are seeing, this one, you have a square shaped wound and you are filling it from tissue from the side. When you take tissue from the side, it's a local flap. So you take tissue from the side in the shape of a square, turn it and put it. This is called as Limburg flap or rhomboid flap used in pilonidal sinus. It's a type of transposition flap. Second, this one, you have a contracture over here. You excise the contracture and you fill the gap with the two triangular flaps from the side. Two chote triangular flaps. You turn them and you fill the gap. This is called as Z-plasty. So Z-plasty is basically for scar excision. It is also a type of transposition flap because you are transposing tissue from one side to the other. It is used for scar excision or contracture release. Third one, the most famous lip reconstruction or Abbey flap, also called as Abbey Aslander. So if I have a defect in the upper lip, I take tissue from the lower lip, turn it and put it there. So this is also a transposition only. That is Abbey flap. You take tissue from lower lip and fill the upper lip. And the fourth one, this can happen to you. You had a cooking accident. You cut your fingertip by mistake. And to fill the gap, you take tissue from the proximal side. So you take proximal tissue from the finger in the shape of a V, advance it, put it at the tip, and suture it like a Y. This is called a V to Y advancement flap. Okay, this is called a V2I advancement flap. So these are all local flaps. I'm using tissue in the vicinity. But if I take tissue from far apart, like for oral cancer, I take tissue from the chest. Chest goes on the face or shoulder tissue on the face. Those are called as distant flaps. They are of two types. You can use pedicle flaps, where the pedicle is intact, like this one. This is a pedicled deltopectoral flap, where you are taking tissue from the shoulder and putting it on the face, but the pedicle is intact. So the blood supply, which was going there, same blood vessel is going here. So this is deltopectoral flap, or you can use tissue from the chest, that is called PMMC flap. Pectoralis major myocutaneous flap. So you take tissue from the chest and put it on the face. This is also known as workhorse flap for head and neck reconstruction. Means it can be used whenever no other flap is working, you can use this. And the last remaining flaps are these are free flaps, where you have to do a vascular anastomosis. Means you have to do artery to artery anastomosis, vein to vein anastomosis. These are free flaps. Free flaps are the best flaps in terms of cosmetic outcome. This one you are seeing, you have taken tissue from the forearm and put it on the face, and you have done artery to artery anastomosis. This is the radial forearm flap. Radial free forearm flap, where you have taken tissue from the forearm. If you want a bone also, you can take tissue from the calf. That is called as free fibular flap. So here you have taken skin and muscle and bone and put it on the face. So this is a free fibular flap. It is a type of bone including, so osteomyocutaneous flap. Remember, between all the flaps, the ideal flaps are the free flaps wherever possible. If you can't construct a free flap, you can do a pedicle flap. Leg ka kya hua? Fibula you can take, nothing happens. Fibula is not weight bearing. So if I cut fibula ka piece, I don't have to do any reconstruction. Nothing is needed. Okay. Do hai nahi means tibia is the weight bearing bone. Fibula is not weight bearing. So it can be sacrificed. Then this a beautiful technology for wound healing, which is called negative pressure wound therapy or VAC. So here there is a wound. I have covered it with this dressing which has a suction. So this suction from the machine generates a negative pressure of 100 to 125 mm of Hg. So what it will do, when I put this on the dressing and I leave it there for 5 to 7 days, it sucks out all the kachra from the wound. It will suck out the exudate, the bacteria, the pus will be out, granulation tissue will form, blood supply will improve, the wound will become smaller. So basically, it will promote wound healing. So it is used in non-healing wounds. Remember, skin graft was used in healing. VAC is used in non-healing wounds or large wounds, which I want to reduce in size, like a burst abdomen. So in these places, burst abdomen, infected ulcers, these are the places where you use VAC. Bed sore, no, not really. In bed sore, first you have to do offloading, means first the pressure has to go. Then you may have to put a flap. It will not heal by itself. Gas gangrene requires debridement. Whenever there is gangrene, you have to remove the gangrene. Na? So first remove the gangrene, then see how big the wound is. If it's a big wound, you can put a VAC. No problem. Okay. Last couple of questions. These are the kind of easy questions you have to get correct. No way you can get this wrong. Child has a swelling near the canthus of the eye. It is not compressible. What is our diagnosis? This is an angular dermoid or a congenital dermoid. Okay, this is a congenital dermoid. 3 times they have asked this question. What is our treatment of congenital dermoid? It is typically seen on the face. Treatment of any cyst will always be excision. Okay, treatment of cyst equal to excision, right? And answer this. So this is a ranula. It is an extravasation cyst. Arises from which gland? It is a extravasation cyst arising from. No, it's not sequestration. It's extravasation of the sublingual gland. That's why it's in the floor of the mouth. If I ask you iska treatment, yes, it will be transilluminate brilliantly. Iska treatment. How do you treat this? You either excise it or you marsupialize it, but something more has to be done. That is just part of the treatment. Excise or marsupialize and remove the affected sublingual gland also. The affected sublingual also has to be removed. Okay, cool. Okay, we are done. So I have tried to cover innumerable topics, whichever are possible. Now the ball's in your court. Now don't start analysis and don't start wondering what to do, what not to do. I didn't know this, didn't know that. Now that period is gone. Now just look to finish till the last moment tomorrow. Okay? Yes, of course, my prayers and blessings with you. You will do well, but the mindset has to be clear. The mindset has to be correct. Don't go with a negative mindset, go with a positive mindset. Time management, most important. Okay. Don't say I could only complete 270 questions. 30 questions, I got tired. That's not done. If you are sitting here from 10 to 5, listening to my, same kind of talk again and again and again, and you sat till now, so many people, when the class started, there were around 480 something. Now also there are almost 300 people waiting. So 70% people still sat 2 days before the exam. That means there is some commitment, na? So the same commitment take till Sunday. बस ज्यादा से ज्यादा क्या होगा, काम नहीं होगा, काम नहीं होगा तब का तब देखना. जब तक काम हुआ नहीं है तब तक आप मेहनत करो. Then see how it works. Cool. Then please also help me with the recall after the exam. You have my Telegram ID. Please be some kind-hearted people and give me the recall questions. Okay, be gentleman like. Don't vanish. You can message me on Telegram or Instagram. Okay, please have some kindness. See you guys. All the best. Take care. Bye bye.